branch of these two branches you see here at this point. Primary and common. Common hepatic artery.
So common hepatic artery, just good liver. Both liver.
Go common hepatic artery, right.
Go high. Or what's the artery that in the segment 2 and what?
What is artery?
So actually,
Okay, whatever it is, without saying that, how do you know it is common hepatic? And we right hepatic artery. Stop commenting. Already there is abnormality. Stop commenting that don't say that it's common hepatic.
That is the it's getting in the surgical sheet. We take it out and down something wrong.
You should be clear. There are three terms and each has a different meaning. The right or left hepatic artery can be apparent. An apparent artery can be either replaced when there is no native artery, or it can be accessory. Point what Dr. DJ was saying, you said it is common hepatic artery. You say that it is common hepatic artery, you have to show that it is divided into both right and left. If there is an apparent left hepatic artery, unless you show that there is a native left also, then also only it becomes common hepatic artery. Otherwise, there is a separate right hepatic and there is a separate left hepatic. The other thing is there is the duct. What the pancreatic artery? You see that both the dilated ducts are coming close to each other. That is of ducts. That is the finding of any of the ducts. Whereas it cancer, both ducts will still be dilated, but they will not come close to each other. So inside the parts, dilatation will not be.
We not discuss about all the diagnosis.
Central dilated. CBD is electric lower end and pancreatitis in continuity with the CBD.
No, CBD is not a CBD and the Bombay joins the pancreatitis. Okay, after that, what is the structure of it? What is that? The body. Now, actually see which structure very clearly. So is that growth from the covered by? Are you seeing a growth there?
No. And lower end, diabetic thing now.
Where is that? There is a dilated tender, pancreatitis, common channel you are seeing. And now what is are you seeing a little? It's not so by the local
the later wall of medial wall. Second part of the
Yes, sorry, capillary adenocarcinoma, cholangiocarcinoma, carcinomas from ampulla, carcinoma from major duodenal tract. These are the four structures.
It's the pancreas.
Is it pancreatic adenocarcinoma?
No.
Is it pancreatic adenocarcinoma? We need to write. Both. Is it abdomen side? Yes. Where is the double duct sinus classically described? Which disease is classically described? Duct sinus classically explanation problem. That will not help you to diagnose it. Just some guy finding you that go ahead from here. One is the obviously coming to the same point. That's just second diagnostic and it's just part of the point.
There is a hypertension at the papilla, Adila, the left, with the axillary, sorry, with the axillary left artery, with no disturbance. There are no significant lymph nodes which are visible. Significant lymph nodes.
Pancreatic circular obstructive jaundice, probably renal adenocarcinoma or very diabetic adenocarcinoma. With so this second it is rejected.
What you say duodenal, there is no abnormality in the duodenal wall, at least from the CT. The growth is at the papilla, not at the duodenal. Peripapillary duodenal carcinoma also is a part of variability, but here we didn't see any of this. Is the papilla, which is the dimple-like projection into the medial wall of the second part of the hand. And again, all students should be clear, there is a difference between ampulla and papilla. Ampulla is the common channel formed by the terminal part of CVD and terminal part of the pancreatic. That papilla is the nipple-like projection which you see when you do a side viewing endoscopy. A lot of students say side viewing endoscopy and ampullary growth is seen. That is not correct. What you see is the papillary growth. There is a difference between papilla and ampulla. So this is a mass at the papilla, not duodenal.
Patient.
Pancreatic substance, pancreas, everything. That will be the anastomosis. So,
That's investigation to
Also, we need markers for the current nutritional status of the patient. I would, and I would like to get a blood investigation done with which includes
Which marker you want?
sir, I
See the CT, don't like it.
I want to know the nutritional status, which I need to have CA19 levels, but for that I also need a total clinical report. CA as well. It can be raised. So
what he specifically says of CA19 It's very important that CBT by that related by and many and category in which it is a pointed for the explanation of the certificate. It is a diagnostic term stuff. So there are two questions in which stage. And second question, why do you want diagnostic already done by the CT scan?
So we need a baseline value so that in post-operative period, it will also.
Why do you need us? CN is marker which causes so that is out now. Okay. This tumor, what is the tumor marker? If you want to tell there is a tumor marker.
C
So C is the tumor marker here. So in this jaundice patient, what do you expect? CN accidentally traced. So it has no significance. Okay, so marker is CA, not CN. And then if you want to tell as a marker.
And what else in addition to that? Obviously, you mentioned the condition, maybe that is maybe this patient with it's a kind of pre-operative survey and then nutritional parameters, then population parameters. So these are the blood investigation on this patient. So that
Suppose this was a CA head pancreas, not papillary or a perioperatic carcinoma. Why did you want CA99? There is an obvious mass in the head of the pancreas. That's all.
As well as to monitor the it's not in specific things. It was a model in the center, and we are planning a new adjuvant start of just to assess your prognostic.
Is there any other use of CA99 level in further investigation of the patient with CA head pancreas, which is primarily resected?
We should go stage laparoscopy.
So those groups which use PET scan and staging laparoscopy as a selective indication, they may use CA99 level as a selecting marker parameter to decide whether PET scan they do or not.
Anything else? Yeah, so you have to say that.
So we don't have to.
Did not do.
So it was not.
Dr. Surya has raised another question. Would it be not possible to consider starting the stated symptoms in this patient examination finding further investigation is inside with this not question. If it is not questioning, then what is the outcome side? Questioning, then
Can be a
Can be
if there are questions, you can just try. Any question may be right, any question may be wrong. And it put height of approach to the patient, approach to management will obviously it's a on discussion. We can deeper with argument.
this patient has spent 2 months. Okay. Now you have to be very clear what you're talking. With adenoma, why? You want to see the liver function test. You are not show the liver function test. So this patient has progressive jaundice progressive weight loss, everything is progressing, progressive pruritus, clay-colored stools, palpable blood, plus CT showing a growth at the ampulla papilla, and this is you have two bilirubin values here, and two alkaline phosphatase value here, and two albumin values here, right? And two dialysis values. Now, are you considering adenoma? Yes or no?
Suppose even if an side-wing endoscopy is done and biopsy is done, biopsy is negative. Does it mean it is adenoma?
So biopsy is always 70%.
I have a very direct question. If biopsy necessary in our patient, which is clinically, neurologically, biochemically, how to have this diagnosis of
Biopsy is not mandatory.
no.
Not mandatory, but possible. Biopsy.
If you don't
Clinically,
lesion, possibly, but patient has to be told explained by all method of clinical assessment is you are likely to have not necessarily accepted the full
I think we take up you may all reflected to standard diagnosis, but it is not mandatory to have tissue diagnosis. You go ahead with resection, which means that in this case, but it doesn't mean that if it is negative, you would not proceed. Second is that if there is a doubt between ampullary carcinoma, because on ampullary carcinoma, as I said earlier, side-wing endoscopy will be normal. You will see a normal papilla. In that case, you may have to do an endoscopic ultrasound. And if endoscopic ultrasound also shows equivocal findings, then you may need a endoscopic ultrasound guided FDC. So dictum is that you make every possible attempt, which is possible in your setup, to arrive at a tissue diagnosis, but it is not mandatory to have a tissue diagnosis before you resect a resection. Am I correct?
Sir, yeah, absolutely. When is it mandatory to get a tissue diagnosis?
For new adjuvant.
Pardon?
When you're planning for new adjuvant.
Yeah, so when you have a situation like what Dr. Kapoor said, or when you have to establish a diagnosis of a malignancy because there is a plan for neoadjuvant treatment.
When you said the angular impact of stone, the area, really you can doing second endoscopy, big gap. Growing air in the papilla can cause deep meningitis. So the biopsy should always followed by stenting. Otherwise, patient will definitely go for meningitis. Stenting, preferably metallic stent, possible, short term.
What is the common scenario you get a biopsy in a patient?
whenever we want to, the primary itself, diagnosis is not the first indicator.
Commonest scenario is when you are with the setting. That is the commonest scenario. What is the indication for a biopsy means? First, you have to tell that a patient who is otherwise indicated for a side-wing endoscopic setting. Okay, that is the commonest. Majority of the patient get biopsy. This is the indication for biopsy. Because you are going in for stenting, you get biopsy at that time. And looking at the parameters here, what do you think? You want to take a biopsy? This patient will end up biopsy or not?
what is your next plan? This patient the routine is pending and other function are going to operate this patient.
So his albumin is okay and his performance status is fine. His breath holding time was good. So I think there is no need of reducing the bilirubin.
Have you seen the total leukocyte count?
Look at to rule out.
Is it enough? Not enough.
I would want to first stent the patient.
Why?
Because the bilirubin is more than 20 milligram%. INR is also 1.64. So we assume that during surgery, we will encounter increased bleeding.
What is in the DLC? What are you seeing?
Neutrophilia.
Even if the TLC is normal, near normal,
Neutrophil count is elevated. Neutrophilia is.
platelet, neutrophil, what are its? So you want to step.
So you want to stent because of the hypertrophy, because of the IDA, and why you don't want to stent this patient and operate straight? Debate between yourself.
So for me, I think INR is slightly elevated. I can give vitamin K shot for 5 days again, repeat the INR value. And he's resectable. If we stent him again, we'll have to.
Change it comes from 1.2 or 1.1. Bilirubin is not going to change the vitamin K. Do you still want to operate this patient?
Yes, sir.
What complication do you anticipate in this patient if you are operating in bilirubin 20?
So there's prolonged cholesterol.
How you prepare this patient for this high bilirubin or for major surgery?
So he's in prolonged cholestasis. So
Again, do you have renal function of this patient? Is it important to decide this question?
yes, sir.
First and also, you don't know. No? So first, the question is the first thing is whether you have the complete information to answer. If you don't have information, please ask.
Bilirubin alone is a very debatable indication for stenting. Most groups will not stent only for bilirubin. It depends more. The indication is cholangitis, which is not responsible to a short course or 48 hours of parenteral antibiotics. Then come the other indication. Not responding to 5 days of vitamin K. Nutritional status is poor. We want to improve the nutritional status. We want to buy some time. Then the operation from the patient side. Bilirubin alone is not. So the answer should be bilirubin alone is not a acceptable or universally acceptable indication. Different groups have different philosophies. Some groups go by bilirubin level, but that cutoff also is very variable. Somebody will say, as you said, more than 20, somebody will say more than 15. But bilirubin, as opposed to other indications, is a softer indication, is a debatable indication. Cholestasis or cholangitis?
Said what will be the implication of bilirubin? The length of the jaundice is an important criterion. The length of the jaundice is often more important than the height of the jaundice. And other factors, as Dr. Kapoor said. So one of the biggest challenges is that one is not able to assess the extent of the bilirubin rise and its impact on the hepatic function per se. That is the one which is respond to decompression promptly. It is the result that the benefits of stenting also were not clearly tangible in many randomized trials. This is a gray zone which needs to be really emphasized by the academic exam. That I would like to see the patient as a whole. However, with a greater awareness of sarcopenia and sarcopenic obesity, whether that is there or not, a comment would be really relevant. If that is there, then it gives you time for rehabilitation. And that time can be used to also bring down the bilirubin. So this is a multi-pronged attack. There is now growing understanding that you don't have to call the tumor to raise cells to get survival. You can wait, and you don't have to give neoadjuvant therapy also. So in that broader concept, it is a emerging indication.
Sarcopenia, you have low platelet level also. Patient can have underlying liver disease also, pre-existing. So it is NASH, alcoholic hepatitis, underlying mild cirrhosis also. So many things are there. When there is not much intracranial dilatation, but prolonged jaundice and high jaundice, you should always think of underlying liver disease also. Because alcoholic hepatitis also, overlap syndrome also.
I request the moderators to wind up the session quickly so that we can proceed to the next section. Thank you.
Thank you, dear.
So I presume all of you are attending the Monday morning PG clinics. If anyone is not attending, for them, please send me a mail, bkkapoor@gmail.com, and ask for 1 2 chapters which have related to topics which have been discussed here.
Dr. Mohammad Yasir and Dr. E. Said. And I would like to invite faculty members, Dr. Ramesh Pradeep sir, Dr. Rajesh Gupta sir, Dr. B.K. Kapoor sir, and Dr. H. Ramesh sir. And for conducting the session, I would like to invite Sri Arjuna Sarangi for the session.
Good morning, everyone. First post-op case scenario. My patient is a 71-year-old female patient with no back comorbidity, with past history of of liver abscess 10 years back. She underwent open classical pancreatitis with diagnostic portal reconstruction with feeding jejunostomy. And the indication for the surgery was carcinoma head of pancreas, critical stage T4, 10+ stages, which status ERCP and staging. Her post-op day 1 to 4 uneventful. She extubated on the 1. She remained vitally stable and active. FJ dash started on post-op 2 and was tolerating FJ feed at 15 ml per day. At a persistent high digestive output around 700 to 1000 ml per day, and digestive output remains around 1000 ml, and her two drains anterior to pancreatic instrument drain and one external drain was removed on posterior drain 3, and one drain is now situ with posterior instrument drain, which drain around 150 ml top weight content. Today is post-op day 5. She is complaining of 1 pressure of fever, patient with chills and dry. Her RT was full of secondary and she is drops. On examination, the patient is febrile with temperature 100 Fahrenheit. Her pulse check was 109 beats per minute, BP 102 by 60 millimeter per mercury, and chest there decreased basal variability at bilateral basal zone, height left basal zones. Abdomen is soft, non-distended, non-tender. Valve sounds are present, no circumference glass. Says Patterson's 2. Her therefore the input output and 320 ml negative. What drain is there is left side of abdomen, which drain around 150 ml of dot bit content, and the range tube outward 700 ml. Now, what is the
What do you think this patient is now? It's on day 5 and this is the history. So is the patient as expected or is it a problem? Is it a problem? What do you think clinically this patient is having?
this patient is post classical pancreatico derivation.
Just let me interrupt. One of the biggest time wasting tactics is to describe the situation again by saying this is a post-classical. Everyone knows that. So just get on with it. What do you see of the scenario?
Scenario is a post-operative pancreatic fistula. The patient, the clinical condition is getting worse.
The rice tube came out accidentally. It was 1100 cc in the last 24 hours. Do you want to put the rice tube back?
The patient was having delayed gastric emptying also, sir.
Did you place the rice tube back?
Yes.
Yes, sir. No.
Yes. The patient.
Would you like to get an abdominal X-ray before the putting the rice tube back?
I would like to see any succussion splash is there or not. If there is, then with X-ray.
Succussion splash.
Still requirement is there because high
I
RTO
don't
output and
think succussion splash.
How accurate is your succussion flash? Post-operative patient.
yes.
The patient would probably say, ouch, if you do a suction splash. So I would like an abdominal X-ray because I want to know if the subsequent loops are also dilated, in which case there is more to it than just a gastric delay. Maybe just gastric delay, or it may be a postoperative ileus, which has a different connotation. So an abdominal X-ray I would do, but it's up to you to do whatever you want. So otherwise, what is your next step?
Drain fluid amylase.
So if the drain fluid amylase was what on day 1 or day 3 or day 5?
So it is on day 3, sir. If it is elevated more than 3 times or the upper limit of the normal laboratory values.
If it is not elevated, does it mean there is no fistula? What are the reasons why the drain fluid amylase may be falsely low? Either the drain is not amylase, or the pancreatic fluid has low amylase because it's chronic pancreatic gland.
Or not fluid is not getting drained through the drain, getting into abdominal.
Or if there is pus, sometimes it doesn't show a high amylase. So for all these reasons, you can get a false. But what do we do with the patient now? Do we put the ice tube back? Then what we're going to do?
First thing, yes, sir, we put a rice tube, and I would like to see the clinical blood picture. As a
You have the clinical picture.
Whatever you have, you have.
You have no.
Patient is having fever, sir. So we'll plan a CT abdomen to see if there are any undrained collections. Fever and tachycardia.
Yeah.
And
respiratory rate also
elevated, sir.
So he has tachycardia, he has tachypnea.
Yeah. So probably there
fever.
are undrained collections. So I do a CT abdomen, sir.
If you're doing a CT abdomen, you should do a chest as well. Because it's got possibly a basic confirmation. But otherwise, you do auscultate the chest, get a chest X-ray, do incentive spirometry, do all of those things along with this concurrently. Because the diagnosis and therapy in the postoperative period have to go hand in hand. Can't be that you do a setup investigation and then you act on it.
The answer should have been day 5 after PD. Patient is not well. Patient is in sepsis. There is evidence or suspicion of either delayed gastric emptying or paralytic ileus. There is a high suspicion of a leak. I would go ahead and investigate this patient. You have to show the gravity of the situation. From your answer, it doesn't appear that you are worried about this patient. I am worried. I have to investigate this patient. Based on its clinical, what is the with this clinical condition, drain fluid amylase is not going to give you the direction. Whatever it is, you have to investigate this patient. That is what has to come out in your answer.
Conversely, if it is low, sit on the patient and relax.
Yeah. I'd like to do the contrast imaging of the chest and abdomen. Contrast imaging of CACT of abdomen with HRC thorax. Contrast enhancer CACT of abdomen with HRCT thorax, and I would like to send the culture of the drain as it is therapy simultaneously. And before that,
let's see.
Blood investigation.
Anything else? The culture of the drain or anything else? What about the intraoperative oil? Will you get the culture report of that?
Previous culture report of intraoperative oil is also available.
You should know whether the patient had stenting.
Stenting is there, so history of can be possible.
CT scan, sir.
Yeah, one of you keep reading as he's showing the CT.
Basic mild pleural effusion and bilateral sides with the both positive contrast has been information.
Only pleural effusion?
Basal pancreatitis.
Do you see rice tube also?
Yes, sir.
Keep reading.
There is a collection beneath the liver.
Where is the collection?
It's a subabatic space.
It's got the collection.
Posterior to in subabatic space near the hilum. Yes, sir.
Or behind the caudate lobe.
Yes, sir.
Behind caudate lobe. Caudate lobe and the right crus. Yes?
Yes, sir.
You describe it. I mean, expression is part of the whole process. I mean, everyone knows it. I'm absolutely certain that each one of you knows all this, but it's just that somehow you don't express it. So just keep talking. And that's the only way that even when you say it, you realize your mistake sometimes and then you correct it. That's what happens. Most of us. Is that bowel dilated? Is the stomach dilated? Is that bowel like what tube is that?
Stomach is distended, sir, with positive contrast. Along with that, even the PG and HG limb are dilated with the contrast, positive contrast in it.
And then what so the drain? What
Drain is located just
top on the drain, please. You trace the drain on its way. Keep tracing. So this drain, does it contain any contrast? Is it important to look at contrast?
No, it doesn't, no contrast. Drain doesn't have any contrast. It is lying just posterior to PG. It's not draining the no positive contrast. Also not draining the collection. It's not near the.
Why is that more dilated? As you said, you're rightly.
One possibility of like FJ, I would like to see the FJ side also. Post-op Julius or any FJ side narrowing can be a possibility.
Very good. And some is a possibility of a distal obstruction.
Yeah.
So how will you proceed to further establish whatever you are finding?
If the positive contrast is reaching distal to the FJ also, then it is unlikely of FJ side narrowing. More probably can be Ilias. So it is reaching distal to the FJ.
Probably it's not dilated.
It's not that.
And this is some amount of contrast. It's not gone rapidly.
Yes.
No, but the loops are not dilated.
Not dilated. Maybe edema at the FJ side. Maybe it can.
Distal obstruction can have PGD. Distal obstruction at the FJ level or at the gastrointestinal level.
Can be one of the reasons.
So, can somebody else say what is the next step? We are seeing this much. You want to see or show some electrics to show us what's happening in the contract? You don't have it. Can you give us information?
Sir, one tissue was placed in the patient, sir, and it then around 100 ml zero coolant contains. Yes.
Sorry, but what the track used for the root used for that? PCD
Hepatic comes down.
Left through the left lobe of liver, the reported transhepatic issue.
What next after PCD insertion? Sit back, relax.
No, I would like to clinically monitor the patient, whether the fever has been resolved. But at the same time, I would like to trace the culture reports and give it the sensitivity antibiotics and monitor the patient with the drain output and PCD output. There is no dilatation of the distal limbs beyond the
answer to this question.
yes, sir.
Yes.
Yes, I would like to continue the internal nutrition with the FJ. Yes.
But yeah, maybe not one answer. The reason for the answer. I just want you to know why. I don't want to know why. I just want to know what to say. Will you continue to
Yes, sir.
or not? Yes.
So it is, always yes, if patient is tolerating. It's not that, the condition will still remain the same.
So, now coming to second case scenario, sir. He's a 53-year-old male without any comorbidities. The diagnosis variance.
I have one question. So somebody speak at all. What is this type 3 venous dissection was said? Can somebody tell me? Maybe this one gentleman actually my left. Is type 3 venous dissection? How about next? There was a slide at the first saying type 3 venous dissection. It was there for the purpose. The host said put that to the purpose. So you need to know the type of resections. So if a patient has a venous resection, immediately in the postoperative period, there are one additional dimension that we have to think of. Can you tell me what is this statement here? This corner. Suppose you have a patient who is having a type 3 venous resection. What additional postoperative care must be factored in your brain?
To start the patient on anticoagulant.
No, not necessary. There is no such guideline that anticoagulants are necessary. The perioperative anticoagulation that we give is more than sufficient. That is the consensus. No additional anticoagulation is not recommended actually, unless the patient has a prolapse robotic state. What else?
We need to monitor for bleeding.
Bleeding is not a feature. Ascites is a feature. If there is a thrombosis of the vein, there can be ascites. Therefore, a higher propensity to infections. And when in doubt, if there is more ascites, what would you do?
Ultrasound Doppler.
You do a Doppler ultrasound of the flow of the portal vein.
Second case, sir. Is a 53-year-old male patient without any comorbidities. He diagnosed with periampulary adenocarcinoma, status 4 segment 3 PTBD. And in preoperative imaging, one important finding was his aberrant arterial anatomy. His CHA was arising from SMA directly. And he underwent classical pancreatitis with feeding jejunostomy. It was uneventful surgery. His post-op 1 to 6 is uneventful. Morrison pouch drain removed on post-op 4. And both superior to PJ drain removed on post-op 5. And inferior to PJ drain retent, which drained turbid content with raised amylase 1200 unit per ml. But drain was accidentally dislodged on post-op 6. Today is post-op 7. He had a complaint of hematomasis, one episode large volume containing clots. He is complaining of giddiness and generalized weakness. On examination, pulse rate is 120 beats per minute. BP is 90 by 62 millimeter mercury. His respiratory rate is 24 per minute. Saturation 95% room air. And the respiratory system is bilateral air entry equal the normal examination. Abdomen is soft, and on diarrhea examination there is melena. And extra this total input was 2900 ml, and you was tolerating oral soft diet with liquid contents. And total urine output was 1700 ml.
Give the diagnosis.
Patient is having late severe intraluminal bleeds. Post-op grade C bleeds.
You should have used the technical term. What is this bleed called?
Post-operative post-hemorrhagic.
That is what
Grade C means what? You have yourself gone into an area which you don't probably want to go. What is grade C?
That is post-pancreatic hemorrhage, late severe intraluminal extraluminal is grade C according to IASG.
What else are required to call grade C?
Intervention, angiography.
Have you looked into the crystal ball and decided what's going to happen to this patient, or are you an astrologer?
We can't
So-
even see hemoglobin report.
Grade A, B, and C are post-treatment, pigeon kabhi holding. It's not a prospective classification. So what next? What do you want to do?
So, I would like to resuscitate the patient, sir. Patient is having
What was the
hypotension.
point of station? You resuscitated. Why is it called?
Resuscitate with what?
So, initially IV fluids and blood transfusion simultaneously.
Why you don't even know what is the hemoglobin.
So I look
So
for
where give blood.
patient is in shock, sir, with BP of 90 by 60. Better while for IV cannulas.
It's only hemorrhagic shock.
Patient has
They have
hematemesis.
estimated the amount of blood loss. They said there are clots in hematomesis. You want to know how much is that clot volume and have some rough estimate. Melena, how much is the volume of melena? There is hypotension, yes.
First of all, more than 1/3 loss of the median arterial pressure in arterial pressure is what is called a hyposignificant hypotension. That has happened. You have to see the fluid response to a crystalloid first. You have to see if the patient is pale. If the patient's hemoglobin is also low, and then you want to transfuse, that is acceptable. But you won't want to keep the hemoglobin too high. You want to keep it. What is the recommendation?
7 is the recommended. If above 7.
8 is okay, and 9 if it's cardiac, there are cardiac issues. So that is one side. What else are you going to do?
Blood transfusion for the hemoglobin.
Yeah, all that we have done already. In 2 seconds, we have completed that.
TT angiography, I would like.
Isn't it
Yes, sir. The possible is post-operative 7 in still like
CT angio. What is CT angio as opposed to contrast enhanced CT? What is the difference?
in contrast enhanced CT, venous phase is usually taken. So
Only venous phase. Arterial phase is not taken. Plane scan is not
plane scan and venous phase are usually taken.
only in contrast enhanced CT. They don't put arterial phase in it. I know certain radiology units practice that, but what is the essential difference between a contrast enhanced CT and a CT angio, which you just mentioned?
Earlier arterial phase was taken in the CT angio.
Double the contrast is used, IV contrast. So if I have a patient who is hypotensive, who has suddenly had a bleed, I would like to check the creatinine before I send the patient down to a contrast enhanced CT. I don't want to cause them to have a renal shutdown. So I would not agree with just blindly sending the patient to a contrast enhanced CT. So I assume that the creatinine is 1.7 and it was 0.9 before the surgery. What's the next step?
We can plan for immediate endoscopy because
What
like
are your-
low exhaust
Delayed
molar
severe
confidence.
hemorrhage. What is your suspicion? What are you expecting in this patient?
One possibility of staple line bleed as the patient has intraluminal bleed. And
Stable
they,
stable line.
I would like to know the most gastrojejunostomy. Any
Training period, how many gastrojejunostomy staple line bleeds have you seen?
On day 7.
Day 7.
On day 7. If you have seen one,
no, sir.
no. So it's not fair to tell the audience here who has collected to listen to you that you want to talk about a fictitious scenario. Let's be practical.
After 10.
After?
Staple line bleed. Will it happen later or will it happen
Immediate in the post-operative 2 or 3 the patient.
Day 1, day 0.
In the right tube also, yes, day 1.
So if it is bleeding, it is bleeding. It will only manifest at a different time, but it is bleeding there. So what are you suspecting? Then investigate and try to find out and treat that cause.
Pseudoaneurysm is a possibility, sir. Usually, morely or GDS term or common hepatic artery. And splenic artery or IPDA can also be a possibility. Corresponding to aneurysms and any stress cells.
IPDA, those will not lead to intraluminal bleed. No, they will lead to bleed in the drains.
Abdominal.
If it occurs, what you're saying that is aneurysm and it is blood into the GI tract. What are the immediate implications of that observation? Suppose there is an aneurysm in the GDA. What is the communication between that and the GI tract? If you are saying that aneurysm in the GDA, and if you say there is an intraluminal bleed, then straight away you are assuming something. What is that? That there was a connection, the connection has either ruptured into the bowel or the bowel leak, the leak and so on happened, and then that connection eroded into the vessel or created a pseudoaneurysm. So there is obviously a connection. It's also sealed off, that's why it's not coming through the drain. And anyway, the drain has slipped out.
So pseudoaneurysm 1 second.
Without pseudoaneurysm, can you get a bleed?
7 day. This is severe hemorrhage. 7th day, severe intraluminal hemorrhage. So one is pseudoaneurysm rupture. Second,
Post-pancreatectomy leak, erosion of the vessel.
Stress cells.
where?
In the stomach.
Which anatomy?
Can anastigmatic ulcers happen after pancreatitis? If so, where? That's the question. They occur at the gastrojejunostomy. They occur. Why should they occur at the gastrojejunostomy after the classical after pancreatitis? What predisposes to anastigmatic ulceration at the gastrojejunostomy?
the acid getting elevated because of the
presence of intact parietal cell mass, alkaline pancreatitis secretions. Sorry?
PG, pancreatitis.
But the pancreatitis comes into the stomach. It is very uncommon after PG.
In which type of reconstruction you will not have neutralization of the acid by the alkali? Only if there are separate loops. So bleeds are described as intraluminal or extraluminal, but you have to remember that what you said, that if it is a GD pseudoaneurysm which has bled, that hematoma has eroded. Other could be that jejunal anastomosis, where you have anastomose the entire surface of the gland into the jejunum, or if it is some kind of an imagination anastomosis and there is a cut surface bleed, that bleed then causes disruption of the anastomosis and the blood also comes out in the drain. So very frequently or not infrequently, you can have both intra and extraluminal bleed. But delayed bleed, whether it is intraluminal or extraluminal, is more likely to be because of a leak and vascular complication rather than pure intraluminal. Pure intraluminal bleed is only patient with severe sepsis, gastritis, or a situation like anastigmatic ulcer.
I want to see the CT scan.
Non-contact CT, sir.
Non-contact CT useful.
Collection said the bubble.
Yes or no?
Yes.
Definitely the person. How is it useful? How is CT useful?
In this setting, what will non-contrast CT show? Obviously, it will show calcification, but that is not important. What's important? Yeah, you can see.
Hyperenancy collection.
Yeah, blood. Which part of the GI tract the blood is lying? That may give you an indirect hint as to what could be the possible site of bleed.
Although you have to always say,
Retro.
we are depending on the motility of the bowel, the blood may actually present at a different site. That is why a contrast enhanced CT would be infinitely superior. Because it may actually show you a pathology, either an acute aneurysm or it may show you the actual extravasation, both of which are very conclusive. Here, this is subject to biasing because where the blood is may not be where the bleeding is.
The arterial pressure.
Yeah. If you have to go to these two, because
the hyperenancy collection.
Next, what?
Can plan for
Can or you will
plan for ecology.
without angiography or with angiography?
With DSA. With
DSA. What is
digital
digital subtraction angiography? You said DSA. When I say DSA, you are sending me the wrong information. What is digital subtraction angiography?
the back.
Is that important here for us to subtract anything? Here, is the therapeutic angiogram? I'm not sure. I don't think so. You don't angiogram for this patient because if you are starting off a GI unit and you have a radiologist, he may also be, may not be very experienced in this particular condition. So, what is your sort of strategy to look at bleed from the pancreatopiliary area? Although you saw a CT, you got already an indicator that there may be bleeding there, but you have to follow a certain system. So it's good to do actually an aortic injection first to know whether you get a general picture. Sometimes there may be more than one side of bleed, sometimes there may be a very strange origin bleed. Then, of course, you go into individual arteries. And many bleeds may be shown only when you go and catheterize the individual arteries, for which you need the microcatheters. So you must have microcatheters. Without having a excellent radiologist is no use.
So you said embolization. So all post-PD GDA pseudoaneurysms you can embolize?
No, sir, if we have adequate stump is there.
Yeah, so you have to say the treatment will depend based on
Especially there
the
is stump.
angiographic findings. If there is a stump, then only you can embolize. If there is no stump, if it is like a hole in the common or proper hepatic artery, then you can't embolize it.
And stenting can be stenting.
What's
Couple hours.
how many millimeters?
Just
My grandmother taught me that if you have to make sambar, you need to have the entire information. Otherwise, you can't make sambar. Get somewhere stuck and yes, you won't turn out sambar. So you need all this basic information. This is what you do when you go to a site, a place. If I come to Lucknow, I need to have more information about Lucknow. So I need to have some basic general information. What kind of stent is required? Because you may not have it locally available. So you have to get it.
So do you have embolization or a stent here?
Stand here, sir. This is the standing place, sir.
there is no
There is stent
stump.
here.
Would you use either a Plavix or clopidogrel or aspirin or heparin for these patients who have stenting?
Yes, sir. Antiplatelet.
What would you use?
Antiplatelets. Clopidogrel.
For how long?
But
What is the recommendation? Because you are treating the patient, you need to know this. So 6 months is the recommendation. And that of it, you can inform a doctor if you like, but very often the portal, the hepatic artery is still thrombosed and collaterals have taken over. It's not actually the patent stent which is working. The fact that time was available for collaterals. Thank you.
Anyone in the audience wants to ask some question?
Sir, my question is regarding pediatric compression. So, what should be the ideal time of pediatric compression for surgery, specifically for PD or inversion?
Take that. It depends on what indication you get the stenting for. If you, it's otherwise it's impossible to judge. If you did for cholangitis is satisfactory. Sometimes the patient is well, you can accommodate. If you operated for renal dysfunction, for an acute kidney injury, you have to wait for that kidney injury to turn the corner. So it depends on the indication for which
You do a stenting.
get the stenting for.
Like neoadjuvant, the reason is different. You have to finish a neoadjuvant, right? With a nutritionally bad patient, usually it takes about 3-4 weeks for them to get back to nutrition. And even for nutrition, it depends on how bad is nutrition to start with. So if it is very low, then probably it might take longer. It all depends on what is the objective of your stenting in these patients. If it was bilirubin, then most people would want bilirubin to come down to less than 5 or maybe less than 3. Because if you've done it, then you might as well wait.
You're supposed to reach.
Thank you all the faculty members for this wonderful session. Coming on to next session, we have a long case scenario. Delegates who are invited are Dr. Praveen Agarwal, Dr. Rahul Ashok Mishra, Dr. SPG Praveen Kumar Reddy, and Dr. Prasoon Kumar. And I would like to invite from the faculty members Dr. Rohini Mittal sir, Dr. Ashok Kumar sir, and Dr. R.A. Shastri sir for setting the session. And for conducting the session, I would like to invite Dr. Atul Goel for the session.
It's a case of 28-year-old female, which is homemaker, resident of Prayagraj, present with a complaint of bleeding per rectum from last 9 months. She was in her usual state of health till 9 months back when she developed fresh bleeding per rectum, which was painless, separate from stool, small in mouth, not associated with clot, associated with progressive constipation requiring laxative on and off. History of vascular mucus per rectum present, history of tenesmus present, no history of generalized weakness present, history of loss of appetite and weight present, no history of spurious diarrhea or urgency, no history of any perianal
pain, marked per rectum or incontinent, no history of any pain, abdominal distension or vomiting. In past history, there was no medical risk factor, no history of past surgery. Personal history, she consumed mixed diet, appetite is reduced, blood habits are normal, doesn't smoke or don't take alcohol. Family history, she has got significant family history. Mother has got breast cancer, which was treated successfully 3 years back and she is alive. Obstetrical history, she is 6 months pregnant presently at the time of history. And in treatment history, she was evaluated with colonoscopy and biopsy and MRI. She chose for early delivery for initiation of the therapy. She delivered on 32nd week of gestation. That was on 11th July.
You can start right now. I mean, up to the history is very important. You start the treatment history and just summarize the history in nutshell so that we can start the discussion. This female, how old is female?
28.
Huh?
28.
The 28-year female patient presented with painless bleeding per rectum 9 months back. And this was not associated with any previous history in the past, but there was no history of other associated symptom, no mucus discharge, no blood clot. There was a history of association with tenesmus is there, generalized weakness there, and loss of weight is there. And patient is pregnant about 6 months, and this is the history. And so, what are the possibility in this patient? A 28-year female patient which is pregnant 6 months without any comorbidity has history of bleeding per rectum for 9 months without any other associated symptom with loss of weight of 4 kg. That is the summary of the history.
Because of long
Don't
history.
give explanation, just tell the possibility in this history.
Yes, sir. First possibility is hemorrhoids. Second possibility is polyps with the associated malignancy. And third possibility is rectal, solitary rectal ulcer.
What else? What is more common in of pregnancy in this patient? 4 months pregnant, though the history of 9 months and breathing PR. So
Fissure
fissure is
but
not same. Even the chronic constipation because of the gravid uterus enlarging and lead to compression over the rectum and even the sigmoid, and this sometimes lead to constipation. But that is the 9 month history. Patient pregnant only for 4 months. So that you should exclude this, very unlikely, but that can superimpose the history of constipation in the setting of bleeding per rectum. So you just ignore that and think of only history of bleeding PR without any mucus, any perineal situation with loss of weight of 4 kg. She's pregnant 4 months. In pregnancy, usually the patient gain, the mother get weight, but she is being pregnant of 4 months, losing weight for 4 kg. Tenesmus is there. So what are the possibility? Just focus on this small history. It is start from your side.
Please, polyp which has transformed into
You are telling that benign disease turning into malignant, and the more likely is the polyp.
Polyp.
What else?
could be
I think for every possibility you give, you need to give the background evidence for why do you say that?
so the history of
I think it's a polyp, but why do you think it is turned malignant?
so the 9 month history of bleeding per rectum. So long standing history is there. Initially she was it was tolerated well.
So probably it was a benign disease, but recent history there is a recent loss of weight of 4 kg. That is why my suspicion of maybe she had.
Importance do you give to loss of weight when a polyp turns malignant? Does the patient lose weight or does it happen? So the weightage you give to each symptom is more important. It's not just loss of weight.
So in this case, what are the red flag symptoms? A lot of patients who are pregnant will come with rectal bleeding. What is different, which is making you think that this is something more than just hemorrhoids or fissure?
So tenesmus is there, sir.
Okay, tenesmus is there. So that is a very big red flag symptom. What else?
Passage of mucus.
Passage of mucus. Okay.
And
third one, mother has been treated for breast family history.
Yeah,
family history of cancer in a young individual. So all these things should make us say that okay, I would think of hemorrhoids, but we would also keep in the back of our mind a differential that there is something more sinister, maybe rectal cancer.
So, now coming to the background history, because there's a family history, what is not in favor of malignancy in this patient?
long history.
One in the long history, second,
Young age.
young age of the patient, what else? Now, theoretical question to you. What is the commonest presentation of CA rectum?
Bleeding.
Rectal symptoms, like tenesmus, urgency, frequency.
Start common symptom first.
Painless bleeding.
What is the bleeding mixed with these two? Don't say painless. Bleeding mixed with these two. Or bleeding PR. Second.
And tenesmus.
Tenesmus.
And spurious diarrhea.
Before that, mucus discharge.
Mucus discharge.
What else?
Spurious diarrhea.
Yes.
Altered bowel.
Altered bowel. So these are the common symptoms. The one point not in favor of the patient is the young age of the patient. But at the same time, the contradictory point is that there is a strong family history of the malignancy in this patient. So that's why you should also think of what kind of malignancy can this patient have in the presence of this system at this age. What has led to develop this malignancy? You tell.
This family polypoidal disease, because mother has been treated for breast cancer, it can be HNPCC or Lynch syndrome.
The question again is, what are some conditions which you are thinking, because there is a family history which will lead to young people getting colorectal cancer?
Family adenomatous polyposis.
Familial adenomatous polyposis. Okay.
Lynch syndrome also can be there.
Okay, Lynch syndrome.
Remaining Peutz-Jeghers also.
Peutz-Jeghers, but rarely.
Cowden syndrome.
Cowden syndrome. There are syndromes. You can have Cowden syndrome. So, what is the main difference between familial adenomatous polyposis and Lynch syndrome, which you can actually see on clinical examination? Before even you do clinical examination, you can think about what you will find.
Age of the patient, sir.
So, age, clinical examination.
We are the number of polyps.
Now, we will go more. So, the differential diagnosis based on the history. One, benign disease possibly, if you are thinking, then hemorrhoid is one. Then, among the malignant disease, it's possible that C has a CA rectum in the setting of a polypoid lesion or Lynch syndrome. It's a Lynch syndrome or maybe familial inverted polypoid turning. The one point of benign is a hemorrhoid, second is the malignancy, part which led to the malignancy. So, which one you put the first in this patient, knowing the history?
Polypoid syndrome turning into malignancy.
Why?
So considering all the factors, one's history, which is painless bleeding per rectum, tenesmus history there, family history is also present. So we'll prefer more for malignant etiology. Benign disease and weight loss also history being instead of she's a pregnant, instead of gaining weight, she is losing weight.
That we discussed in the very beginning. Having not pregnant for 4 months and over a period of 9 months just bleeding PR, 4 months weight loss, past history of malignancy in the family of CA breast. What the differential diagnosis?
Hemorrhoids, most likely.
And right, what else?
Inflammatory bowel, bleeding tear for 9 months.
SRUS, solitary rectal ulcers.
We should also discuss in the history today about the type of history of bleeding, type of bleeding, amount of bleeding, then obviously the bleeding before and after defecation, and the character of bleeding, and then bleeding associated with other symptoms like feeling of incomplete evacuation, tenesmus, altered bowel habit, progressive constipation, alternate constipation, and diarrhea. So these are the many symptoms you should take into history to reach a kind of various differential diagnosis. So here we are starting with the diagnosis of benign disease, which is malignant disease. So if you tell some examination finding would be better to tell at this point in time. Don't tell the treatment history. What is your differential diagnosis? Differential diagnosis? Yes, sir. Proceed for the examination finding.
You already
said summarize it.
So what examination points, what are the things you concentrate on in this examination to differentiate the various possibilities in your differential diagnosis? Detail, but what are the important
key points that you will look? Your differential is hemorrhoid disease, a benign disease, malignant disease, which is likely to be CA rectal, maybe a background of genetic examination. Per rectal examination, proctoscopic examination will help us to differentiate.
In general examination, there are many associated findings you will find that like patients first you will see. Loss of weight or features of hypoproteinemia in this patient. Patient history has gravidae it's a tumor. Gravida, we don't know. Maybe tumor,
you should take over. You should be speaking. Please come out.
Yes, sir.
This keeps talking.
First, I'll see the BMI, then echo performance status, then patient's vitals, then any features of anemia, the pallor, then pedal edema, then generalized lymphadenopathy, I'll see. And if left supraclavicular lymph node is palpable, then on abdominal examination, whether any palpable mass, any palpable lump, or any umbilical nodule, then any pulsations or any peristalsis.
Identify a little because you are considering the rectal problem. How many times have you seen an umbilical nodule or a lump in the abdomen with a rectal malignancy and rectal problem? So the key points are what you are asked. So don't dilute that because that will not give you any credit by mentioning an umbilical nodule in CRT.
So again, I told in the previous discussion about what we are looking in the imaging. One is to establish the diagnosis. Second, finding what are the associated feature, whether it is which kind of treatment you help you, and obviously the pre-operative will build up the patient. So just look in this. Diagnosis is still not clear, specifically what point you look. Then in that diagnosis, what are the findings you can find in general and specific examination?
Then palpable liver and spleen, any features of ascites. Then rectal examination, features of perianal skin, whether any excoriation, whether any hemorrhoids, and
4 months pregnant.
Yes.
What precaution you will take in this patient? With what finding you anticipate of abdominal examination?
Sir, first I will take the consent. After taking informed consent and with adequate exposure and with the female, in presence of female attendant, then I will examine the patient. And
So, there is suprapubic mass, if it is a negative patient, are not. And obviously, the rest thing you nicely mentioned that in a female patient is the attending for examination. Maybe if doubt, then you can send the patient to gynecologist before the confirmation of pregnancy. And you should not be very forceful on pressing that down. It sometimes lead to a forceful abortion or threatening abortion. So these are the precautions. Even during the per rectal examination, PV, you may or may not do it. Obviously, it will go to the gynecologist. So they are not permitted to do in this scenario.
So the rectal examination findings are given there. Is that enough, or is there something more you want to know on this rectal examination? Or is there something more you would do? With circumferential non.
So Pelvic was not under March fixed growth. And next overclock vision. So
there is circumferential. With circumferential hard nodule for mass 4 centimeters, finger not able to cross the lesion, upper border not pancreatic. Given this history, is there anything else?
Surface ulcerative or polypoidal.
Okay, that is all technical. It doesn't really make a difference to your management.
Yes, sir.
What else we want to know? Given the history, 29-year-old.
Whether any other polyps or
any other polyps. So it's very, very important to actually look and say, are there any other polyps or not in this particular patient? Then we go to the next. So how will you proceed next? There's nodularity palpable in the posterior vaginal wall also. Now, given this examination findings and the history, what is your diagnosis?
Carcinoma
Lower rectum. Okay. What else can you say?
with probably infiltration into
In this patient, so I carcinoma of the lower rectum, or even it would be mid rectum coming are involved in the lower rectum because it could not go to the upper. So mostly the motion is that, and scientific evidence also say it is it when not go upward, possibly it's coming from up, down. It doesn't go
below.
down or up. So maybe either middle rectum or lower.
You see that the anal verge is mentioned. What is anal verge?
And depression between
Oh God. Because the what is the perineum? There are three. Dr. Shastri has asked you another word, another terminology for surgeon is the dentate line, another terminology is the anorectal junction. The tumors are described in various textbooks, or maybe various clinicians take it as another one, or the relation to the dentate line, or to the anorectal line. So,
what is the importance? Why anal verge and why anorectal ring? Why two levels?
Can be felt.
One by one.
Sorry. Anorectal ring will represent termination of rectum into an anal canal. So
the anatomical thing is not important. Now, what is its importance to you as a surgeon?
So it will decide on what surgery I will do.
It decides on the location of the malignancy, whether it is in the lower rectum, mid rectum, and upper rectum, and the further plan of action, what surgery we'll have to plan according to that. Distance from the tumor from that one.
So which is most important? Plan. What are you thinking about?
No, cancer. See, from the anal verge, distance is enough to say whether it is low, middle, or high. Why anorectal ring?
Anorectal ring, as in if there is involvement, then the sphincters can also be covered.
So in the exam, you have to actually clarify or display to the examiner what you're thinking. So essentially, what are you wanting to say?
So whether sphincter is it?
What is the difference?
So we have to plan for the sphincter preserving or APR or complete.
Yes. So whether you will plan for an APR with permanent colostomy, or is there possibility for sphincter preservation with temporary stone? So you have to actually say that. If you don't say that statement, then you're not displaying your knowledge. So, and on what level will that decision be made? What is your thinking? How will you, on this rectal examination, which is one of the factors you will take into consideration, what is the thinking?
Shastri's question is not still over. what is the anal word? You have to answer this question.
Anal valve is junction between anoderm and anal submucosa. Dentate line is
Inner word
sub.
of the perianal skin. That is the perineum. That is the perianal skin to the squamous part of the anal canal. Squamous epithelium or squamous part. Anal canal is two parts, anoderm and ectoderm. So it is the squamous epithelium where it merges with the perianal skin. That is the perineum part. That is the anal. What you can see is significant differentiation between the anal canal black color mucosa with the perianal skin. And then you're coming to the dentate line.
Dentate line junction between squamous and anal canal squamous epithelium with the rectal mucosa and rectal columnar epithelium.
Squamous epithelium. The part of the above the dentate line is the anal canal.
Yes.
The interrectal canal is the made of anorectal junction. How do you identify anorectal junction on clinical examination? That is part of the examination.
So we bring palpable
Your finger and ask the patient to squeeze. This is the point of contraction with the pimborectal muscle. This part is slings at the anorectal junction, and you feel tiredness. That is the anorectal junction clinically. Now coming to the patient.
So that is the anatomical definition. But surgically, clinically, how do you make a decision? Based on a rectal examination, what is when you do, which patients do you think will be amenable ultimately for a sphincter saving operation, and which one will definitely need a
sphincter is not involved. Then
fixity is one thing. Okay,
if tumor is above the rectal,
how far above the anorectal?
1 centimeter, 1 centimeter, more than 1
centimeter.
Yes.
Okay, so you can make clinical decisions based on the anorectal ring, because dentate line is not palpable. Okay. So that is why it's very important on that rectal examination to also mention how many centimeters from the anorectal. So when you say 4 centimeters from the anal bulge, anal canal length can differ between people. In males it is longer, in females it is shorter. So additional point is distance from the anorectal. So many centimeters above the PR ceiling or above the anorectal. It's a very important clinical
Patient now. So here's the finding that the correction of the currently 4 centimeters from the anal one. Let the watch here for the diagram. What do you do next?
First, I will review the previous investigations and previous records.
Previous investigation.
Yes, sir.
And the gynecologist and the patient is pregnant.
I will do, sir, proctoscopic examination, proctoscopic biopsy of the tumor. Along with, I will send complete blood count, liver function.
Biopsy, what other things you are looking for at the proctoscopy, which are not clear on the digital examination?
Yes, sir. If any other polyps or any other lesion, apart from this, then sir, distance of the tumor, that distal margin from the anal bulge on proctoscopy examination, and distance from the proximal margin of the tumor.
So if the finger cannot go proximal margin, spread the proximal will go up and tell the proximal. What is the objective of this patient at this point of time?
To take biopsy.
You believe you may not be able to move properly. So only objective is the biopsy.
It was a exotic proliferative mass lesion seen in the rectum.
Even you ask biopsy, you will not ask what is OPC. Tell this biopsy finding.
Biopsy was suggested for adenocarcinoma.
So biopsy is adenocarcinoma. What will you do next?
Sir, I will do blood investigation, complete blood count, liver function test, kidney function test, PTINR, and tumor marker CA, and then colonoscopy to see the other synchronous lesion.
See the cronus lesion. What would be other indication in this patient?
Sir, if any other polyps, because patients, based on history, patient might have polyps.
So there are several indications in this patient. One is the proximal extent of the tumor, which we are not able to see clinically and also on MSD proctoscopy. Second would be obviously the synchronous lesion, and third we are discussing malignancy in the background of familial history, maybe polyps. So there are three common.
Will you have any reservation to ask for a colonoscopy or do a colonoscopy, considering that she is pregnant? Are there any other ways of getting that information? Whatever you want to have from a colonoscopy.
What precaution you will take if colonoscopy is required at all in this patient for treatment? So, what precaution is the 4-month pregnant lady?
Gentle insufflation.
Yes, so minimal or gentle insufflation. Here, objective is not to see the mucosa so that too much insufflation is required. Just you want a synchronous lesion. The second objective precaution will be the positioning of the patient. Yes, because that will lead to. I thought would be very gentle, not a forceful colonoscopy. If at all it is necessary, it can be done with the.
Is it that important to know the upper margin? Which is more important? Okay, you have all these investigations here.
So go back to the yeah. Read.
It's an exophytic proliferative mass which she present from 5 centimeter to 10 centimeter from the anal verge.
Biopsy is adenocarcinoma. What about the other part of the colon? It's not. They haven't done full colonoscopy. Whatever they have seen, it is presumed that it's normal. Suppose that we presume that the rest of the colon is normal. So what would be your next plan from here? In 25-year-old female patient, 4-month pregnant, rectal carcinoma, adenocarcinoma,
MRI of these. Mark chest with the pelvis.
So you will do MRI of the pelvis.
MRI of pelvis for local staging, high resolution, low field of light, and MRI of abdomen, chest, and.
Are you doing MRI in this patient because the patient is pregnant, or would you do MRI anyway, even if this patient was not pregnant?
For local staging, MRI is required, but for she's pregnant now for metastatic staging, CT is not.
Supposing she was not pregnant, and most of the surgeons are very familiar that in fact that's the excuse given why you want to do a CT over MR. You always say I'm more used to CT. Why do you not do a CT if she is not pregnant?
Like involvement of superficial resection margin, you'll get to know more on the MR as compared to the CT.
Resolution of rectal wall is better, is not so good, but which is quite important in your decision making.
What other features are you looking for in the MRI? Even before you order the MRI, one is you're looking at staging and what things will you get from an MRI which you won't get from a CT scan?
So
Circumferential resection margin, yes. EMVI, nodal staging, depth of injection. Okay. So all these things you're already wanting to look for in the MRI. So when we come to the MRI, one of you should look for it and read.
And when you go and see an MRI on the console or in your, you see a lot of sequences, whole lot of sequences there. Which one would you, which are you are interested in a CA rectum? I think it's what is surgeon would see
First, digital tens of anatomy. After that, I will see axial images. In that, I will see circumferential dissection margin and lymph node involvement and depth of invasion pre-staging. And EMA also I can see in axial images. If specters are involved, then I will see coronal imaging. It is better.
Very important, very good answer. So T2 high resolution images. Do you need to give contrast? No, contrast not required.
Contrast, do you see in T2? When you give contrast, which
T1 weighted.
T1, do you do T1 weighted image at all in CA rectum, and what is the results?
No, sir. T2 staging in post neoadjuvant setting, we may to see for response, but
Post neoadjuvant response, which sequence is important? Is it T1, T2?
T2 weighted again, T2 weighted only.
Something else over there. An answer.
Diffusion weighted imaging. Diffusion weighted imaging is
that is the one which
yes.
decides differentiates between fibrosis
Yes.
and malignancy. But T1 itself, is it useful at all? It may be useful when the surrounding viscera are involved and you're planning a multi-visceral. Say you want to plan an exenteration, then you would.
So let's look at the images. So somebody can, one of you can look and just sort of give a commentary.
This is the MRI pelvis showing thickening in mid and lower rectum. It's a mass protruding into the lumen from the anterior wall.
Did you see any nodes or anything?
So nodes are there posteriorly, sir.
You can,
Yes, sir. There are nodes.
Same time, like you mentioned that the nodule into the vagina, you should also take the posterior wall of the vagina where there is infiltration, yeah, it's so free, or there is any mass into the vagina. It's complete infiltration involvement of the posterior wall, which is more likely in this patient because the patient is very young. Younger patient likely to have more aggressive carcinoma, advanced stage of the disease. So, and the poor prognosis. There are three important things to look at. Maybe scroll up and down. Yes, stop and see. Stop it and do it.
anybody, all the points that sir has mentioned.
And extra finding, you see the gravity plus is
right. Yes. So vagina doesn't look to be really better seen in axial images.
So we can look at the axial for the anterior involvement. Can we see nodes?
Yes, sir.
So lots of large nodes just behind the sacrum, which we can see. Okay. So initial impression is it's very bulky, sort of reasonably long segment growth, and with lots of nodes. Shall we look at the axial?
Is the size of the nodes important?
Yes.
Yes. So 8 centimeters around.
So this.
If it is 6 mm, you not give any importance to it?
No, sir. There is
They are more important than the size in rectal.
Yes, sir. If
that you should the margins around,
yes, sir.
the irregularity, and they are much more.
There is a criteria, sir. If more than 9 mm, then we can consider. If 5 to 9 mm, then we have to consider these features. If less than 5 mm, then all three features should be there: round and heterogeneity and irregular margins.
take for and if you find tumor mentioned, the tumor is more than 5 millimeter of the similar characteristic, it is taken down to this model that we want to
Yes. Because we have to look at the
Yeah, keep moving.
let's look at the
Yeah. But this is crucial. And
then circumferential growth, sir.
Superficial growth extending from mid-rectum, sir.
You want to know whether vagina is involved or not? Can you see that on this MRI? Involved, not involved.
Anteriorly involved.
You can see that it's almost there infiltrating the vagina, full thickness infiltration of the vagina. Okay. So if you were to guess a stage for this, what stage will you guess from this MRI?
T4.
T4 what?
T4.
T4B.
T4B because it's infiltrating adjacent organ full thickness. N
And
N plus. N plus. Most likely going to be N2 with the amount of nodes that you got.
Yes, sir.
What about M stage? You can't say from this.
No.
But we'll assume that there were no other metastasis. So T4B and 2 M0. And was there any MK?
Yeah, you have not look.
how do you identify AVA?
So it is continuous tumor thrombus from protruding into the vessel. So there is continuity dilatation of the vessel.
Distended vessels coming from the tumor margin.
Do they have to come from the tumor margin, or can they be separate?
It can be separate.
Can be
Can be
separate.
separated.
What about sometimes you see spicules from the tumor? How do you differentiate them from AV?
In EMI, it will be hyperenhanced and dilated.
One of the thing is intensity of the EMBI should be same as of the tumor.
Yeah, we have a radiology session.
But it's a very important feature, EMBI, because EMBI is more important than nodes in prognosis.
Why is it important?
High chunk metastasis.
It means it's a hematogenous vector.
Yes.
Lymph nodes is only local lymphogenous, whereas this is hematogenous. Yes.
Yes. It's a circumferential heterogeneously predominantly T2 and T1 hyperintense wall thickening involving the mid-rectum for a length of 4.6 cm, approximately 4.3 cm from the anal verge. Maximum thickness is 1.7 cm. There is extension to the perirectal fat stranding into the mesorectal fascia, presacral space, and surrounding piriformis. Anteriorly, it is involving the rectovaginal space and possibly posterior wall of vagina. There is extracellular venous invasion and fibrocompletion at the lower margin of the region. Is seen infiltrating the internal sphincter, external sphincter, and posteriorly levator aneurysm. Multiple varied size necrotic perirectal lymph node and internal lymph nodes are present. Approximately size is 1.5 to 1.3 centimeter. No definite involvement of the urinary bladder, uterus, or pelvic side walls. Overall staging was T4B and 3M.
So let's keep moving forward. Suppose it was M0. We've done the CT and the other MRI it's M0. So you've got a lady with T4B and node positive lower rectal cancer infiltrating mid-rectal infiltrating the vagina and the levators. Biopsy is adenocarcinoma with some signet ring cells. What do we do next? Any other tumor marker you want to do? CELM. Do we have a CELM? CA is normal.
I see on biopsy also available.
Pardon?
MSI.
Biopsy with adenocarcinoma.
MSI status.
MSI status. Why do you want to know MSI status?
So, because I'm planning neoadjuvant, so it may have a bearing if it is MSI unstable. Then it is of a better prognosis, better results with immunotherapy.
So is immunotherapy common or is it the standard?
But if we can find
Patient is
patient
not responding
to it, sir,
we can
immunotherapy.
How will okay, this is how we get into trouble in the exam. What is the role of immunotherapy and what is the evidence for it?
What is that?
What is the evidence for immunotherapy in low rectal cancer as neoadjuvant therapy today? This is how you dig a hole and you go deeper and deeper in the exam. What is standard treatment?
Neoadjuvant chemotherapy, sir.
But why is MSI important? It's not to give neoadjuvant
Because of prognostication.
It is prognostication. And currently, it's only for prognostication.
Yes, sir.
There are trials, it may come up today, but today it is not the standard of care. So MSI should, as a routine, be done in all. What percentage of rectal cancer will be MSI?
15%.
20%. Less than 20%. That's for colon. For rectum, it is actually less than 10%.
Yes.
Do we have an MSI report? Okay.
This is the investigation now. You tell, it's not telling. What we do next?
We'll discuss in the tumor board meeting and plan for the neoadjuvant chemotherapy therapy after the discussion.
What about the baby?
What will be your contribution to the team?
I think for the further,
Okay.
there is no involvement of
You are the tumor board member there, sitting there, and everybody is looking to you. What do you think should be the management in the tumor board? When you put a patient with a tumor board, you have to have some plan in your mind. So what will your plan be?
The patient comes to you first. She came to us as a surgeon. And obviously after evaluation, we are going to the tumor. I and the tumor board of chair will tell us, yes, what is your plan for this patient?
after as the tumor seems like more aggressive and it is
Give explanation. What is your plan? We know what is the tumor.
In the exam, always answer first, explanation next.
see for the response of the CRT and after that you plan for surgery. Being more aggressive tumor, it doesn't seem like it will respond well and she'll require surgical management.
What are the types of neoadjuvant treatment?
Long course chemotherapy, short course chemotherapy.
Long course chemotherapy, short course chemotherapy, total neoadjuvant.
How do you select between these three? See, that is the intention of asking your contribution to the
Yes, sir. Total neoadjuvant therapy is total neoadjuvant therapy chosen.
Why do you say total?
Sir, T4 disease, N2 disease, distal rectal carcinoma.
What is your intention of giving a total neoadjuvant treatment?
Sir, my intention is to pathologically regress the tumors.
Let me ask you, is this patient operable?
No, sir.
Why not? Can we not do an accentration?
Yes.
Yes. We can do an APR with posterior.
Yes.
So then when we can actually do that, why do you want to give
Before that, we should regress the tumor. And second thing is micrometastasis also we should deal with.
To decrease the local recurrence.
Very specific.
To decrease the local recurrence and to decrease the systemic recurrence and to avoid the futile surgery because it is locally advanced disease. And then to regress the tumor and to see the tumor biology.
She's 4 months pregnant.
Yeah, so that is a different discussion. Let's focus on only CA rectum now. Okay, let's for 2 minutes forget that she's 4 months pregnant. Now this patient has come to the tumor board. You are saying you want to give neoadjuvant therapy. What is the intent of neoadjuvant therapy?
Sir, to decrease the local recurrence, to decrease the systemic.
Decrease the local recurrence. So how will you decrease local recurrence?
Radiotherapy.
Okay.
Yes, sir.
All right. So what are the types of radiotherapy you can give?
So short course radiotherapy, long course chemoradiotherapy, then TNT, along with the long course and
short course and there is long course. Which one will you choose for it?
Long course, sir. Because it is locally advanced disease, so I'll choose the long course radiotherapy.
Long course radiotherapy. Yes. Now, do you want to give chemotherapy?
Yes, sir. EMVI positive because EMVI indicates systemic chances of micrometastasis. So it will deal with micrometastasis.
So then, in your mind, what do you want? What is the sequence of treatment?
Yes, sir. My sequence is total neoadjuvant therapy, and in this first long course chemoradiotherapy followed by systemic chemotherapy.
Followed by
chemotherapy. After that, then followed by surgery.
After this staging and
in between you have to do restage.
Yes, sir.
In your mind, all this has to be very clear. Does this patient require radiation? Does this patient require chemo? And how I'm going? And all the options are possible. There is no wrong answer. You have to be able to justify to the examiner why you want to do what.
So this patient you are doing treatment was later. What do you do in this clinical scenario as the baby is concerned before we start the therapeutic plan? How do you talk to the patient? Because you cannot give the longer chemotherapy or radiotherapy without discussing the patient. How you deal with the patient?
I'll discuss in MDT meeting with patients and along with gynecologist. So I will offer that offer that to deliver the baby early. Then we can start treatment as early as possible. What are the options? What are the two options here, and what will you choose? Yes, sir. Early delivery. One is early delivery. Yes, sir. Early delivery. How early can it be? She's 4 months pregnant. Yes, sir. How early are you speaking about? After the second trimester.
There can be two options possible. Either we can ask the patient to get it delivered early, or if the patient is willing to terminate the pregnancy, that we can also give.
Those are the options. Either you terminate pregnancy and start treatment immediately, or you wait and deliver baby. But early delivery is how? You have to commit to some answer.
Minimum 28 weeks.
Reaching 28 weeks in India is really possible for everybody. No.
The best option is
Terminate the
termination of pregnancy.
This is the first baby, the friendly young patient. They are first child, they are having balance. Secondly, another malignant disease. So you have to deal with this with the malignancy, and so it's advanced malignancy. If you wait for the pregnancy to continue, malignancy will disseminate and hopefully she will not survive. While the baby is delivered, possibly she will have ascites and disseminated disease. One issue. Second, if the baby is not precious, she has multiple children in the family, completed the family, then that would be another problem. So how will you discuss these various points? One is the life of the patient. Second is the quality of life of the patient. Third is the future family of the patient. So how do you tackle this issue?
Suppose patient says, okay, I'm 4 months pregnant, we can terminate, but we'll finish the treatment. What are my chances of having another baby after 5 years or 2 years or 3 years?
Going for short.
Answer the question first. Answer the question first. What do you think are the chances that this lady will become pregnant again? What are the chances of future pregnancy after treatment for CA?
When we plan for this patient, the chance of pregnancy might be less. So before that, I think we should.
You will have a radiated uterus and then you'll have chemotherapy. So chances of natural conception are very low. So you have to also discuss ovum preservation.
So once the now target the second pregnancy, possibly she does not survive 2 months to have a pregnancy. So one, if she wants to continue the baby, that would be one aspect. Or you will convince them to avoid and go for treatment.
For this patient, at least wait for 3 months. So we can advise about aborting and going for treatment because even already at advanced stage. If we wait for 3 months more, at least there is a high chance of this tumor to grow.
Ask the family to consider the of this patient for future family, then terminate the pregnancy and treat the patient.
So remember, this is nearly obstructive tumor. So if you wait long, sometimes the patient will go into full-blown obstruction. Okay, last question. You've given radiation, long course. When will you plan for reassessment and operation?
After 8 weeks. 8 weeks after.
8 weeks. Why 8 weeks?
Response of the TNT be shown in 8 weeks.
8 weeks you'll get response. What is the minimum time?
6 to 8 weeks.
8 weeks. 8 to 12 weeks.
12 weeks.
If you wait for longer than 8 weeks, what happens? Or longer than 12 weeks?
2 weeks, it will still show progression. I mean, the fibrosis will still continue to progress. So surgery might become even more difficult.
Tumor might regrow.
Yes.
So in non-responders, responders may continue to respond, but if they are non-responders,
The tumor will
tumor will regrow. Surgery becomes difficult. Thank you. Thank you.
Anyone from the audience wants?
The patient is having family history of managing breast cancer, and there is a high chance that she might have SGPGIMS and underlying genital disease. So, by knowing the MSI status and getting into the immunohistochemistry monitor and getting in, if the patient is having SGPGIMS, so should we do this hysterectomy and dilator salpingo-correctomy along with plan for lectures?
Side will help, but how to prove that this is Lynch syndrome?
Then, sir, immunohistochemistry and NGS, we can go for, if MSI high, then we can go for the immunohistochemistry and then NGS study.
There is,
MSI or that.
how do you say this Lynch syndrome and not sporadic?
One, then you have to say that BRAF mutation is present or MLS promethylation present or not. If promethylation is present, then it is most likely somatic mutation. If BRAF mutation is present, then most likely somatic mutation. Otherwise, if it is negative, both are negative, then you can go for genetic study. And if in genetic study you found that it is then anxious. The blood.
Yes. What we are talking about is tumor. Whenever you suspect family history, you will actually do a somatic check. So either it is from blood or they will take from saliva or from the cheek, and then only you can actually say this is Lynch syndrome. Otherwise, it can also be sporadic.
So usually go for the study in the discussion in our examination, or we should skip and just what should we do? In examination point of view, should we go for MSI status and then for immunotherapy and or not, or going to the genes genetic studies?
Next thing is you have to look at it. If this is Lynch syndrome, the current guidelines is that if family is complete, then patients should go for hysterectomy and salpingo-correctomy. Otherwise, patients can still be on follow-up, and they have to have an annual ultrasound and pap smear and follow-up. So that is the current thing that has to be said. So keep it simple in the exam. Family complete, patient has CA rectum, suspected or CA colon, suspected Lynch syndrome, prophylactic hysterectomy with bilateral salpingo-correctomy. Family not complete, keep on surveillance.
And sir, about colon, total colectomy or
that depending on the patient whether they are willing to come for follow-up. If patient is willing to come for regular follow-up, you can do a segmental colectomy and follow up the colon with every 2-year colonoscopy. If patient is from a remote area, cannot come, then you can do a total colectomy, and the rest of the rectum and little bit of sigmoid colon can be followed up just with a sigmoidoscopy.
So my second question is, sir, if a patient is, you said that we follow the NCCN guidelines in our institute, and in NCCN guidelines it said that if the MSI high, then we should follow, we should go for immunotherapy, the preferred choice. Yeah, then you said that this is not standard, so I got confused that if we say as a standard of care immunotherapy is standard of care as per NCCN guidelines, or we should not say. So as a neoadjuvant therapy in NCCN guidelines, standard of care.
It is not standard of practice in India. I don't think any institution is giving immunotherapy.
Okay, according to books, what should be the answer?
You give the evidence, also you say the guideline. So you quote the guideline, but then you see they're all evolving situations. This guideline says that, whereas the common belief is still not reached that level of care.
In the exam, you can say, as per the latest NCCN guidelines, immunotherapy is the first line of care. But again, it is not widely available. There are cost limitations. So these are the other options. So then you have actually shown your knowledge and you actually displayed practical application.
Another thing I tell you, as far as MSI is concerned, there are two things that this all data come from the Western population. usually they have MSI high, and the percentage of patient with MSI high is more as compared to the Indian data. For rectal cancer, it's only about 10%, and for the colonic maybe 25 or 20 to 30%. So possibly that is not the clinical scenario, because each patient has different based on the geographical area. So genetic makeup and even the kind of tumor behavior and histopathological characteristic is not same what they do and what we have. Possibly that is the reason we are not using practically, and in their set of guidelines come from Western population. They have
Thank you. Sir, you said that in this patient we will first give long course sedative followed by chemotherapy. But as you said that this patient has high EMJ status, sir, high risk of metastasis, sir. So in this patient, I will prefer induction therapy more than concomitant sir. Because
If you say that because of EMPI, I want to give induction chemotherapy and then bronchos radiation, that is okay. If you say I want to give radiation followed by chemotherapy because the opera trial showed that consolidation chemotherapy is slightly better, that will also be accepted. As long as you give a reason, both answers are acceptable.
Thank you so much, all the faculty members and the delegates for this wonderful session. Coming on to next session, I would like to invite Dr. Rohit Mittal sir for the lecture on current status of robotic colorectal surgery.
One of very few talks in this session. Asked to speak on current status of colorectal robotic surgery. I will start by saying I have no disclosures of conflict of interest. I am not a robotic surgeon. I am not a laparoscopic surgeon. I am a surgeon. I do open surgery, I do laparoscopic surgery, and I do robotic surgery. So I try to present some views on the benefits and disadvantages of robotic surgery versus laparoscopic surgery versus open surgery in a few slides. And then if anybody has any questions, we can have a discussion. We have a lot of faculty and delegates here. We know now that minimally invasive surgery currently is the standard of care in rectal resection. MIS has many advantages: less pain, shorter hospital stay, less blood loss, faster recovery, better vision, better magnification, and it does not compromise oncology. Now, the age-old question that everybody asks is, should we do laparoscopic or robotic surgery for rectal resection? Very often in this audience, when I'm sitting there, I always say, why not open surgery as well? Because all three are actually equally good when it comes to oncology. And now, with the robot coming in, we are extending that question to colonic resections also. Saying, should we do laparoscopic? Should we do robotic? Correct. Before we go into the evidence for it, just a few slides on what are the advantages and the disadvantages of a robotic platform. So, what advantages that come to mind? What is proposed is that stapling in a narrow pelvis is easier with the robot. Identifying correct planes is easier. There is magnification. There is stability. There is some literature coming up saying functional outcomes are better after robotic surgery. You can do an intracorporeal anastomosis more easily. And last but not the least, it's more comfortable for the surgeon because you can sit comfortably and operate. So yes, robot does have certain advantages. Stapling in the lower rectum is always a challenge. The staplers don't reach down in the pelvis, especially a narrow male pelvis. It's very difficult, and you're doing an ultra anti-resection. Very difficult to staple. You do multiple fires, and with every increasing fire, you have an increased reek. And then the angle is not really sometimes correct. You have fire at an angle, and then you have dog ears or you have margin, which is problem. So these are problems with stapling in the lower rectum. And now staplers are increasing. Not just the robot, even open staplers are becoming better. You have self-articulating staplers, you have powered staplers, which are giving us a better option to staple in the lower pelvis. However, the robotic staplers do have a little bit of advantage over here. They are powered, they offer 60-degree articulation, which is more than any other stapler. They have technology to sense the tissue thickness, and if the thickness is not right, the stapler will not fire. And it is completely an automated process. So there is no sort of multiple firings with the hand. With the robot, also the advantage is you can use a single staple technique. You are very low into the pelvis. You can cut the rectum, and suturing is easier. So you can take a purse string and you can actually do a stapling. So you might not have to actually even fire a stapler. And this step is also easier with the robot. Again, we say that magnification, stability, and identification of planes is easier. I've shot two small videos, one of laparoscopic surgery and one of robotic surgery, both from my unit. And then we'll have a little thought on how different they are. So this is a anterior section being done laparoscopically. You can see that the posterior dissection is being done. We are going in the mesorectal plane, and you can see the plane being created over there. And very soon you will see the nerve and the ureter, which we will push down. You can see that this is the nerve here, and this is the ureter. You will see peristals very soon. Here, the ureter is peristals in here, and now we are going down into the pelvis, and you can see the camera. If you see properly, you will see that there is a little bit of a shake of the camera, which is there. So now I'll go on to the next video, which is a robotic video. And very similar anterior sections, very similar view. And you can see here that actually the vision is very stable. And it's almost a lateral section. Here you can see actually I went into the wrong plane over there. You can see that little O that has formed. If there are sort of tiny sort of circular holes that are coming in the mesorectal fascia, then you know that you are not in the right plane. Move forward. So again, if you look at both, you could see that the robotic platform was more stable. It offered good magnification, but it's a difference of maybe 5 to 10%. By and large, both of them are very similar. Better functional preservation has also been said to happen with the robot. Earlier removal of catheter, lower bladder and sexual dysfunction, earlier resolution of biles. And a lot of this is attributed to better magnification, and you are able to see the nerves and therefore preserve the nerves better. And you're not using harmonic, but you're using a sort of a monopolar, and so there's not diaphragmatic damage is also less. But the biggest advantage which I feel is the ability to work in a deep narrow space. So that is where I think the real advantage of the robot is there, because you can actually get magnification, you can get stable vision, and you can work in a very deep narrow space. So especially the obese males, bulky mid-rectal tumors, you can actually go down, and when the space is like only 5 centimeters, you can get good vision and you can operate, which can be very challenging laparoscopically. Not impossible, but challenging. And some extended resections, which are difficult with traditional MIS, which actually the robot allows you to. And one such case is somewhere here, you can see there's a colorectal growth infiltrating the prostate, which is marked with the yellow star over there. So traditionally, we would have done an excenteration for this patient because there's a rectal growth post LCCRT and post neoadjuvant therapy still infiltrating the prostate. What we have done in this case is a APR with only a prostate excision, and we have anastomosed the bladder to the urethra through suturing. So that is one advantage that the robot gives us, that you can actually suture, you can remove only prostate, and urethra to bladder anastomosis can be done, and that's very, very difficult doing it laparoscopically. So there are some advantages, but the real advantage is actually in a deep narrow space. But how do you become an expert at operating here? We actually got to do the simpler cases with the robot, and then only you'll be able to do these kind of difficult cases. So there's a sort of an ethical conundrum there. Again, intracorporeal anastomosis is now being sort of promoted in many forums. There is some literature coming up saying there is decreased dialysis and faster recovery. And again, there is intracorporeal bodies are better. Better surgeon economics. We know that laparoscopy can be quite taxing. Surgeons have neck problems, back problems, sort of doing laparoscopy, and this definitely has better economics. But again, as with everything, we have got to balance these advantages with the cost. A lot of these advantages are fringe advantages, and whether they translate to hard outcomes is not yet known. You have to balance the cost of acquiring the machine, the balance of maintenance and AMCs, the cost of the disposables, and the recurring costs that come along with the platform. So it's essentially between the benefits and what it costs to the patient. So coming back again to the same question, should we do laparoscopic or robotic rectal resections? The ideal way to answer this question will be by doing a well-conducted, adequately powered, randomized controlled trial. And to date, the trial which has been discussed most, and I'm sure most of your general clubs would have discussed this trial at some point, is the ROLA trial, which actually looks at robotic assisted versus conventional laparoscopic surgery among patients undergoing rectal resection. But the key point here is the endpoint was conversion to open laparoscopy. They did not look at recurrence, they did not look at CRM positivity, they did not look at complications, they looked at recurrent conversion to open. Now you have to think to yourself saying, do you think that's a really good outcome for your patient? Is that what you want by using the robot? Actually, all the advantages, there is not one mention about conversion to open surgery, and conversion to open in laparoscopy is 5% or less actually. So finally, what it found was there's no difference of outcomes between laparoscopic and robotic arms. So these are about 400 patients done over 10 countries in Europe, and they didn't find any difference. Since then, many other studies have been published, mostly retrospective. There are 12 systematic reviews on laparoscopic versus open rectal dissection. So anything that has 12 systematic reviews, the data has to be quite broad for something 12 systematic reviews. But every single paper has finally said there is similar survival, similar conversion rates, and similar readmission rates. There is some evidence to say robotic dissections have slightly lower blood loss, shorter length of stay, and improved quality of life. And that data is coming, and lower urinary retention. So nerve preservation seems to be better with the robotic platform. Future trends, I think the robot is here to stay. It's not going to go away. We now have robotic platforms. Single port platforms will come to India very soon. And then I think over the next few years, we'll start having flexible systems into the country as well. There is a large number of robotic companies which are coming in. Intuitive has a major share at the moment, but every other company is making a robot. A lot of them are now coming into the market. And it's a very competitive landscape. You have the SSN, you have various other robots which are coming in. And each of them will find its own niche. The Intuitive is coming up with the DaVinci 5, which is the advanced robotic platform. There is Mintra, there is CMR, there are various other platforms, so the costs are definitely going to come down. The next step, I think, which we might see in the next 5 years is AI-assisted surgery, where AI will get integrated into the robotic platform, and you might be able to, sort of see differences, and it might guide you to what you're doing. Like, in this instrument, you can see the amount of force that you're using. So it will actually give you a guide on how much force you're using, and the force is too much. Because the robot can actually easily calculate it. So just to summarize, robotic platforms do offer some advantages, some of them being stable camera, elimination of hand tremor, better magnification, 3D vision, stapling technology. When it comes to 3D vision, I always say that open surgery also provides 3D vision. You should never forget that. Stapling technology, ability to work in narrow spaces, more complex resections can be done. Better surgery economics. But you have to balance the cost with the advantages and choose your patients wisely. So minimally invasive surgery is going to be the standard of care for rectal resection. The robotic advantage seems to have an advantage. There are many challenges to a good outcome. The surgical challenges and the approach that you use is just one of them. The biggest challenge we have is to tailor the treatment and approach to the patient so that that particular patient has the best advantage. So some patients might be suited for a robotic section, some patients might be suited for open, or some patients might be suited for laparoscopy. And I think as surgeons, we have to know all to be able to offer our patients what is best. Technology keeps changing. In 1883, Lord Kelvin, president of the Royal Society, said X-rays will prove to be a hoax. 1837, they said that the abdomen and chest and brain will never be opened by surgeons. And here we are talking about robots. So I'm sure whatever I say will change in the next 5 to 7 years. Thank you.
Thank you so much, sir, for the informative talk. Now I call upon Dr. Rajneesh Kumar, sir, for the next lecture on future in robotic technology.
Thank you, Davina. Thank you, Dr. Rohan, for an excellent talk. I think this talk is actually, both these talks are actually kind of misfits in the program in certain ways. Partly requirements, as you understand, of the sponsorship, but I think more importantly, a couple of truths of life before I kind of become very. Yeah. Yeah. That will come as a weird. Where's the look. So yeah, couple of fundamental truths of life applies in probably all fields. One, especially in surgical fields, and this kind of these are not very super pragmatic kind of statements. One is that technology will always move faster than we anticipate. It's always been the case. We're talking about X-ray, we're talking about robots, 100 years difference. The reason this statement becomes important is we'll never ever catch up with technology with regard to the proof of benefit of that technology. I don't know if you can understand the impact of the statement. But this will always be true in our lifetime, your lifetime, and then future lifetimes also. We'll keep on trying to catch up with the real benefit of what we have in our hands. So at the end of the day, in clinical practice, you will have to, with your own mind and your own knowledge and whatever is there out there in terms of understanding of that technology, make up your mind whether it helps you and your patient in a given scenario, in a given place of work. Robot is one of those technologies. It's moving much faster than the way we can actually assess its real benefit. I work with excellent laparoscopic surgeons, I mean, Ashish, Ashok, Rahul, and others. But I still have this understanding that when I was a resident, LabColi is just coming to being, and these teachers are there. They have seen that era, and that was the era when people said, "This is one fancy technology. It's not going to go." And today we have a point where if you do open cholecystectomy, you might have answered the code as to why you did it. You might go to the code and say, so there is no randomized trial supporting a laparoscopic cholecystectomy, and that is the truth. But your version will still not be accepted. The reason is, we know it's good. We know the benefits. We don't need to prove it. I think this is one of those technologies. In time, you might say that it is of this benefit or that benefit. One thing is certain, it's not going to go away. That is for sure. In different forms or different ways, it's going to impact your clinical practice, and you will have to ultimately adapt some form of it. Maybe not this, maybe you will adopt something else, but it will come there. So I think Dr. Mohit put up that perspective of an evolving field, which is very encapsulated because it changes so fast. It is already changing very fast. My job is to give you a little more flavor of the same. So it was basically the master shape concept. It started from your hands and instruments to laparoscopic instruments, which are the slave, and then to the robotic instrument, which became the slave, to do what your mind wanted to do with that patient. So the original designs were the earliest designs of the laparoscopic with the robotic platforms. And we are in this country at least more familiar with this design, which is the Excite platform. Most of us know this to be the epitome of robotics in this country, at least as of today. But obviously, not a static way of looking at things. Other companies caught up very fast. I think we give a very nice slide of other companies. Just 3 of them which are there in this country. There are a few more others only which have come in. And so, why these slides are important is that you have one market leader, like it or not. That guy has had an advantage of at least 10, 15 years of R&D work over these guys. So they will catch up, take some time. So whenever you see innovations coming in robotics, it's likely going to come from the person who's done it, started much earlier. And it is not going to be the fundamental tools always. It will be kind of working. The guy will always catch up. But you still have to look at that person who started 20 years earlier. So that's where, I might sound like a spokesman for Twitter, but that's not the case here. It's only because I started much earlier. This was the reason robotics came in. We thought that we could replicate human hand because the laparoscopic instrument simply couldn't replicate the human hand. They did what the hand could do, but they couldn't replicate what the human hand did. So hence, robotics and the issues of how we replicated the wrist and went inside the abdomen. And hence, it seemed that this was a good way of doing things. We are still trying to prove it is so or not. And in addition to that particular economical advantage, advantages just came in, which Dr. Rohan just showed you a couple of videos. We had much better, more stable visual platforms. We had those tremor filtering, which is bane of the world of laparoscopic surgery at times because you get such huge tremors going at the end of that long stick that you could see it on the screen that I have so bad tremors in my surgery, and so on and so forth. And hence, we came to a conclusion this may be a reasonable way of doing things. Expensive, but reasonable. Problem was it was not free of issues. And the issues, one of the issues we straight away came across was what we came across 30 years back when we started laparoscopy. And that was haptics. Haptics basically is a touch sensation. We are aware of all that. Laparoscopic surgery is indirect haptics. We have a long stick, we push the tissue, and we can make out something about the hardness or softness of the tissue. It is not as good as your hands, open surgery. So there is some haptics. Problem is, robotics takes even that away. You have no direct touch at all. So you just use your eyes to look at how soft or hard that tissue is. And when we started laparoscopy, one of the ways we were told to learn was to do these things on the turtles, and you guys also have to do this because it gave you an idea of what indirect haptics is all about. So you don't tear the paper, you will not tear the tissue, and so on and so forth. Suturing and so on. And that's the way it's still structured in laparoscopic training. Robotics, there's a problem because it does not exist. You can't have any touch sensation at all. This is what Intuitive was working on earlier, and the other companies are also working on it. Fortunately, Intuitive was brought that in the market, and they're still working on it. Hence, you can still only hear about haptics from Intuitive platforms so far. And this was the force feedback. What I'm going to give you in this next few slides is not R&D in the lab. It is there in clinical practice. Maybe not in our country, but it is there. It's just a matter of time it's entered this country. So that's one of the reasons the small tower schedule to basically make you aware of what is coming. Work is still going on. So force feedback essentially is to transmit that information which that instrument gets via electronic digital data to your hands to tell you the hardness or softness of the tissue you're encountering. And again, the first question which I told you we talked about was that benefit. Still long way for proving the benefit of this. So that takes years down the line to come. So by the time we come to the benefit of haptics, would have only there for the last 5 years in practice. Hence, pragmatically, we got to start learning about more information about this. These are all promotional videos, but they give you a clue of what really the DB5 is all about. The haptics has been incorporated with there. It's been already there in the European and US platform in their markets for the last 2 years or so. Cost expensive, but I guess it'll come. Even XF is very expensive, but the market leader has to have to listen to the real market. So the rest of the platform is so cheap now, but they will listen to it eventually. And the same will apply to this issue also. Other thing you need to be aware of is this AI and machine learning thing which keeps on batted around all over the place. What it really means is there's a lot of information generated when you're using open surgery, laparoscopic surgery, or robotic surgery. The difference is in robotics, there is a digital platform through which that information is going. So almost 100% of the information is captured. In laparoscopic surgery, capturing the information requires a lot of electronic and a lot of manipulation of data. In open surgery, that video has to be analyzed. So I don't know if Christina guys know this, but open surgery video used to be analyzed by AI and captured in ways which converted that information to digital data. Fortunately, robotics can do that straight away right at surgery. So kinematics, amount of instrument changes you to time to take to complete a step, all captured immediately. How the data is used is where AI machine learning is coming into being now. So huge amount of data generated, again, not really my slides, but captures what I wanted to talk about, data sets, analyze, and then how that information is given to the surgeon. Dr. Rohan showed a slide about how the information is transferred to the surgeon about advice from the machine to what you should be doing, could be doing at that surgery, in that step. Their AI has already entered and there thus is the show from statement. Actually, it's AI. Because the amount of information that the staple is gathering is not known by the surgeon. It's gathering a lot of information, and then is that tissue good enough? Should we be using a different cartridge? How much compression is being applied? So AI. It's all there already with us in India. What is coming? Well, this is what is coming. The data being gathered, for example, is converted into objective performance indicators. A lot of them, again, not backed by evidence so far, but this is what is coming. And all this will be transmitted and translated into a big, huge library, which again is connected to your machine. And after some time, or even at that surgery, you'll get advice about where you're good, where you're bad, and you might want to improve, including the kind of advice which Dr. Rowan showed a slide, where actually in the surgery, the robot is advising you about what can be done in a given step differently. The is actually which has incorporated all this. I think pictures of it shown. The second bit I wanted to show you was about single port robotics. It's been there for the last 10 years, nothing new, honestly speaking. Of course, the versions are changing. It's not been there in our country, but they brought it out essentially for ENT use and then now for breast surgery also. But look at the machine, how wonderful it looks. It's not science fiction. Unfortunately, the Western surgeons, I say Western surgeons because it's not in India at least, have not been able to find a niche beyond oral surgery or breast surgery. I had a kind of I was kidding with the two guys, give it to the Indian surgeons, they'll find a way. The technology is mind-boggling. The telescope is also articulating. The instruments, more than a wrist, they also have elbow. Kind of dexterity you can have you can actually imagine about what can be done. They have to give it to the Indian surgeons, they don't know really. So single port extraction is like single port robotic surgery, except here you have the robotic arms and no robotics. Wanted to show this slide because it gives you an idea of where we are, because evidence is there, bottom line of every single workshop CME that come. It seems some of the fields which we work in have gone much farther than others in terms of adoption in clinical practice. So urology is much farther than us. Gynecology is next on the line. We are slightly in the middle where we are using in mainstream, but still a lot of maturity is required. So rectal surgery seems to be probably mature data where we might come across in the next few years studies which tell you this can be the standard of care in certain ways. And then there are others which are kind of moving forward. Future, I wanted to show the slide, it's useful. We just kind of go this video. Those who are interested, this was launched 2024, January 24, to the space station. And in February 24, the first ever what should I say? It's not transatlantic. Transatlantic was 25 years back. This is transatlantic, I guess. Surgery, not really surgery, to simulated surgery. So what it tells you is where robotics is going, where it's headed. Of course, it's not what I want to ask you to do, but since the younger guys are here, it's a flavor of what is coming. And the years to come, your generation might want to get more information coming on this end. I don't think I'm going to conclude anything. Thank you so much. And I think Dr. Rohan might want to take some questions if you have any from the senior people or the younger guys. And then we can close for lunch. Thank you so much. Or we can have questions at lunch. Thank you so much. Yes, so same question I asked about 20 years back when lap pulling was the standard of care. It was already the standard of care. Very difficult question to answer. I guess because human beings require, it's not manufacturing cars where you can say this drive is better than this drive. It's about operating real patients and having numbers, and then you can't crash the car. You can crash the car, but you can't crash a human being. So I'm guessing that's the reason. It takes time. So thanks.
So if you look at a lot of people, they are laparoscopic surgeons, and the day the hospital acquires a robot, they become robotic surgeons. They will not go back to be laparoscopic surgeons. So yes. Yes. So again, there are a lot of soft endpoints that we choose. Nerve preservation, early catheter removal, quality of life, total number of nodes. But ultimately, if it does not translate to hard outcomes like either improved survival or significant improvement in quality of life, then does it really matter? That is a question we have to ask ourselves, and that is a question everybody has to ask themselves. And I don't think a lot of people have the equipoise actually to say we are going to do a randomized control trial and check both head to head, because it will take a huge number of patients, a lot of cost, and a lot of effort, and somebody has to fund that. Yes. So that's what my last. Ultimately, as surgeons, I think we have to be able to do all three. You have to choose the technology which is appropriate at that particular moment. So for some patients, some place cost is the major issue. You have to choose between robotic surgery or actually paying for the radiotherapy. So so you have to.
Yeah, but when I was very, very young, just entering to surgical practice, my senior resident, Koshin, used to tell us that was the time when, gymming and all this was kind of exotic things. He used to tell us, body बना ले, नहीं तो लंबे ऑपरेशन नहीं कर पाए. And then Dr. Piyush reminded me when I entered GI surgery, कि health होनी चाहिए तभी transplant करेगा. So that was the norm. You have to have good health. Otherwise, Ashish does Ashok does PD for 10 hours or 8 hours or 9 hours. उसके बाद you can't go back home and sit with your wife or your children. You have to just kind of back on fly. Robotics gives you that edge. You can go home and still watch the television and have a nice cup of tea.
Roland, I just wanted to point out one of the reasons that all this is taking time is also because the surgeon is still the most important prognostic factor. The quality of the TME cannot be simply, blamed on robotic or lack of robotic or laparoscopy or lack of. So it's a mindset. It's a commitment to ticking the boxes. So most surgical procedures have boxes. You have to tick the boxes, and you have to make sure you get there regardless. And that is the crunch, the whole crunch. And that's why this whole, regardless of what technology is available, there will never be an easy solution to this conundrum.
Absolutely. The ultimate answer is to actually get a good quality TME. Good open TME is still better than a badly done laparoscopic TME.
I think the change many times.
Absolutely.
When a change comes, many times when it's technical based, I think it's very difficult for people to accept. Why should I change? That's the concept. Same thing happened during laparoscopy. But the patients who forced the surgeons to change it, because the moment then they started coming, because I knew we've seen how laparoscopy evolved, they said, I want it to be done by laparoscopy. That forced many of the surgeons to learn laparoscopy and shift to laparoscopy. And same thing is happening now in robotics also.
Absolutely. But again, as surgeons, we have to be pragmatic in what cases we use it for and what cases we don't use it for, because there are definitely advantages, but it's not for all cases. I mean, you can use it for lap poly, you can use it for appendicectomy, but you really find a use there. We can always find the reasons, but we have to be true to ourselves on that. Yes. The technology will stay, it will keep improving. Laparoscopy is improving, robotics is improving, and for that matter, open surgery is improving. What the same operation we used to do for 6 hours, now we can do in 3 hours. We've got better, better exposure, better sort of sealing devices, better magnification. You can use loops. Open surgery has also come a long way. It's not the same what we used to do 10 years ago. that I will have to refer to somebody else because I don't do any coding operations. Yes. So if you're talking about conversion, an experienced team can convert within 2 minutes. You can actually disengage the robot within less than 2 minutes. You can actually disengage the robot. Yeah.
Sir, to young surgeons like us, what is your advice? How should we go about this field which is upcoming? How should we approach this?
First, this is a technology which you will have to adapt. There is no way you've got a long career ahead of you. There's no way you will be able to work without that. Having said that, there is a stepwise way to sort of learn. So if you look at anything, I wouldn't say just go and start doing. You've got to observe, you've got to find the niche, then you've got to go for training. Intuitive provides certifications, you have to actually get certified. And then in your mind, you have to choose which are the cases I'm going to use it for and which are the cases I'm not going to use it for. And that's going to be a very individual decision based on your practice. If you practice in a tier 2 city, it will be different. If you practice in a big corporate, it's different. And then you have to choose which platform you're going to use. And that again depends on where you're practicing. But you will do a mix of cases. But you have to have training and some certification before you start doing it. And in your mind, you should be very clear these are the cases where there's actual use and you will use it. Now, it's useful in very difficult cases, but you can't start doing the difficult cases first. So if you want to do rectal resections, you will have to actually do a few sigmoid colons first, get used to the machine, and then you will be able to do it on a difficult case. But if you want to do a difficult rectal resection, are you going to start doing, cholecystectomies with a robot? That is your decision. There are people who are doing it. I don't find any use for it, but that is something that you have to do. But the short answer is yes, get trained, observe cases, start with simpler cases, and then go on to more difficult cases. The platform is whatever is available to you or whatever is in the hospital you are working on, or if you have your own hospital, whatever you can afford to buy. Yes. That's true. I mean, ultimately, if everything fails, you have to open. Okay, thank you very much.
The vascular canvas. That time it is the vascular canvas. The time go ahead.
Is there any issue with this, sir?
Everyone from the labs could continue the event in this next session. For this session, I would like to invite the delegates for Dr. Kartik Sahani, Dr. Ashirwad Panda, Dr. Rahul Gautam on the stage. And for moderating the session, faculties are Dr. Muhammad Ibrahimullah, Dr. Biju Putakat sir, Dr. Chetan Kanharia sir, and Dr. Rajesh Gupta sir. for conducting the session, Dr. Yajnadar Sarangi will take.
Let's start, sir.
Yeah.
Good afternoon, everyone. The case is 49-year-old female, homemaker, resident of Lucknow. She presented with chief complaint of generalized pruritus for 1 month and yellowish discoloration of eyes and urine for last 1 month. Antecedent history: the patient was alright 6 months back when she experienced pain in the right upper abdomen. For which she was evaluated elsewhere with an ultrasound and diagnosed with cholelithiasis. There is no history of fever, jaundice, vomiting, or any history of admission for pain. She underwent open cholecystectomy 1 week after onset of pain and date of surgery 30th of August 2024. Details of the surgery: it was a nighttime surgery, lasted for 1 hour. Intraoperative difficulty explained to the attendant, but OT note is not available with us. A single plane was placed and specimen was shown to attendant and sent for biopsy. And in histopathology, there is no evidence of malignancy or informed to the patient. From day 1 only, from post-operative 1 only, the patient had yellowish green output in the drain amounting to 200 ml. And the output gradually increased to 400 ml over the next 5 days. And there is no history of blood in the drain, no history of jaundice or fever at that time, and no history of blood discharge on post-operative 30 with the 18 on 31st August 2024. There was an accidental dislodgement of drain and she developed abdominal distension. She was referred to another hospital and underwent exploratory laparotomy with drain placement on post-operative 20. Post-surgery, the patient was explained that the peritoneal lavage was done followed by drain placement. According to patient, exit site of drain was at the right lower abdomen. Post-operatively, the patient had yellowish green output from the dislodged drain site, which is amounting 200 ml per day, and serous output, which from the newly placed intraoperative drain. On 5th day of second laparotomy, the patient underwent an endoscopic procedure. The patient was discharged on post-operative 8. After removal of intraoperative drain, a bag was attached to the dislodged drain site, draining 200 ml of yellowish green fluid daily. Over next 2 to 3 weeks, drain output decreased gradually and stopped spontaneously, drain site output, and she was asymptomatic during this period and was colic stool. The patient remained asymptomatic for next 4 months. After which she developed yellowish discoloration of eyes, which was insidiously onset, gradually progressive for last 1 month, associated with high urine and alcoholic stool, associated with general pruritus, which disturb her day-to-day activity and disturb her sleep, associated with intermittent episode of fever, with chills and rigor requiring antibiotics. There is no history of pain associated with jaundice. There is no history of loss of weight or loss of appetite. There is no history of decreased vision, loss of eyes, bone pain, fracture, or muscle weakness. There is no history of vertigo or EG fragility. There is no history of GI bleeding, abdominal distension, and ulcers in shape. She was then referred to SGPGIMS. There is no past medical comorbidities. Family history is not significant, and she's a non-smoker and no alcohol or tobacco chewing. Bladder and bowel are normal and regular, except now she is passing alcoholic stool and she is taking a mixed Indian diet.
So we'll start from either end. One is, so how do you analyze this history and what do you think has happened? What is your name?
Sir, my name is Dr. Asirvad Panda.
Datta.
Asirvad Panda.
Okay, good.
Sir, there has been most likely there has been a bile duct injury during.
Most likely. What is unlikely about it?
Yes, sir, there has been a bile duct injury during open cholecystectomy. And on POD day 1 patient has been draining biles around 200 ml. Further, the drain was there. It was a controlled fistula. biliary fistula, but on POD 18, as they have said,
Can you characterize that bile duct injury?
sir, on POD day 1, it was 200 ml, and it gradually increased to 400 ml next 5 days. I don't know patient was in NPO, but still I think, sir, it might be a complete bile duct injury, sir. I'm not running around 400 ml.
In the history, if you see that they have mentioned that the patient passed colic stools, is it important?
Yes, sir. Yes. Some amount of bile must be going.
So then is it a complete bile duct injury?
Biliary continuity, sir. Some patients having bile leak.
It is maintained.
So what type of injury?
Sir, it might be partial injury, sir. Not completely transecting bile duct, sir.
And then after second this, they put it over a period of some time, the bile output decreased and they suddenly stop. So what do you make out of it? What must have happened?
Sir, though, but patients are continued with colic stools.
Colic stool.
The patient had stenting probably and endoscopic stenting.
No, that is later on. But she went about this. So she had colic stool. So what must have happened now that it has stopped and stented? She's been stented, but still, in spite of stenting, she's bringing out 200 ml of bile from the previous drain site. Is it?
Yes.
So we don't know about how much time it has been drained. We don't know the exact duration of that drainage period. Therefore, 1 day or 2 days or 3 days, it has been draining been fluid. And after that, it has become serious. That next slide.
No. The first, where the first drain was put, from there it continued to drain yellowish fluid. From the new drain which they had put, it was draining serous fluid. So basically, a track must have formed there, and she is draining out from there because that must be the most dependent site. So what can you make out of this now? That now it has stopped. It stopped means after stenting, they removed the drain, but still persistent. So how do you characterize?
So
Can you characterize based on history the injury?
Yes, sir. That means there was a biliary biliary continuity was there. The stent has decreased the pressure. As a result, bile has been going into the enteric, sir.
But she is still draining 200 ml.
There can be a ductal injury. That can be a
sectoral duct which is not connected to the system.
That after the putting the stent, there is less pressure from the main side.
Had this patient come to you primarily the second time, how differently would you have managed?
I would have investigated properly.
Meaning?
Sorry.
Meaning what? Investigated properly? You cannot answer like I would have investigated. What we would have done?
I would have characterized and grade the injury. What is the type of the injury that has happened actually?
How will you do that?
So either we can go with the fistulogram or we can
go with anything. What do you want?
The MRC. MRC, sir.
You would do an
MRC. That second time. There is a controlled fistula.
Prior to taking up the patient for surgery,
yes,
you would have taken done the MRC.
Yes.
You also agree to it? There is a collection. She's come with distension of abdomen. And
gone for a CT scan and the drainage of the collection before we get
what is the purpose now? What are you trying to target now? What is the aim of it? At this stage, when the patient is coming, aim is to avoid mortality. Okay, that is the first your entire investigative approach. Because if you avoid mortality, these patients can be finally salvaged. 99%, that is the concept. They should not die. Now you tell what is required to avoid mortality. Is it MRCP is required to avoid mortality in this patient? What is required to avoid mortality? First tell that. Drainage of the collection. Once the drainage of the collection happens, then at what stage you have to be very clear that at what stage you have to assess the type of injury. Is it required at this stage?
No, sir.
What is your target now? Inside the patient is stable, patient is sepsis free, and there is a controlled fistula that has been there. Then we will at that stage It happens in the second, after few days, she was having controlled fistula. At that stage, we could have staged the disease.
So
If the
patient
patient
came
is
with
sepsis,
a
then no.
patient came with a open bile duct injury leaking inside. Okay, then they made it external biliary fistula. Again made it to a leaking inside but contained. Now what is your target? You have to make it again a external biliary fistula or internal fistula through stent. That's what. So this is your aim. So your investigation typing is important only if you approach the pathway 2. Okay, you want to make an internal biliary fistula through ERC stenting at that point of time, then you approach with the typing. If not, there is no point in doing a typing when you are planning a external drainage for this patient. This patient, you want external drainage or internal drainage at this point with a large collection.
At this point, sir, we
Pick out of this. So this is a bile duct injury which has occurred on table, and most likely because she is passing a colic stool and there is still drainage, it's most likely a sectoral duct or an aberrant duct which is leaking could be there, or there may be a partial this. But the very fact that even after endoscopy it still persisted, more likely that it could be a sectoral duct or an aberrant duct which is leaking. Now she has come after 6 months. How do you manage?
No, I think I would agree with you that despite stent, if there is fistula, then it will not heal. It will not close overnight. As soon as you put the stent, this fistula will not close. It will take some time to heal, this particularly the side injuries or the cystic duct leakage.
6 months.
So,
She's come back 6 months since.
with a persistent fistula. Okay, in that case, it may be a different story.
Yeah, there's no fistula. She can jaundice. Jaundice and toxicity, the patient had leakage in the output from the slow screen side. What is the next step?
It was stopped and now patient present with jaundice.
What do you make out of it? Why it has stopped and what is the condition now?
The patient might have developed stricture and then followed by, and they have put the stent in the.
So if a fistula stops, there are two situations you land up. One, it can form a collection. It can form a
stricture.
So there are specific symptoms and signs for each of these. Analyzing this scenario, what you feel?
She's asymptomatic, like.
No, is it a collection or a stricture? It's a stricture.
The patient is asymptomatic. She's come to my OPD with the history of jaundice for the last 4 months. 1 month.
1 month. That patient for 1 month.
Last 1 month with high best provided and intermittent episodes of fever.
So what was happening these 4 months when she was asymptomatic?
She was asymptomatic.
So what did they do?
I've created the injury, sir, by doing an MRCP since she's asymptomatic.
No. What was happening in this? See, a patient had a collection, then fistula stopped, then became asymptomatic, then became symptomatic.
Yes.
That is the history. So, sir was asking you what has happened then asymptomatic. Yes.
Take for a longer time, that is why she develops symptoms now.
The stricture need time to develop. Then when there is a fibrosis, then it leads to the stricture formation. Till that time, we don't know. One point is I want to ask that what is the status of the stent that they have put? Is they have removed the stent or it's still there? Because that can be the source of cholangitis and the patient is having symptoms. So
The stent is
still. So it's not the history exactly what has happened. So I would like to ask.
So this is the ERC finding. After multiple attempts, CBD could not be cannulated and procedure operated. This is
no.
This is the first.
The interventions that they tried appear at patients were not successful.
Yes.
What happens to an external biliary fistula? What is the natural history of an external biliary fistula? There are basically 3 things that might happen. Can you just
either it can be stable or the fistula output continues. If it is increasing,
the fistula continues. That is one possibility. Second possibility,
it heals and the output stops.
By forming a stricture. Heals with stricture. Third possibility, internal biliary fistula. That you have already mentioned. Yeah, it could be any of the 3 that might have happened here. So
Presently, she is symptomatic in the sense she is
having some cholangitis, probably with a prolapse.
what would you advise?
So I would like to investigate with. I would like to examine first.
Examine is done.
Except for incision side, energy side. Is there? It is there. It is written. Next what? Next. Next slide. Next. Go ahead. If you want to examine, what you want to examine specifically?
So I would like to know the status of the patient, WHO status of the patient.
Status of the patient is, that is the whole purpose of
the WHO status, physical status.
In a patient of biliary, suspected biliary stricture, what exactly things you look for in a clinical examination and subsequent investigation?
The jaundice of the patient is
Jaundice done.
jaundice.
Then
And that's the dehydration status of the patient. And
any fevers, cholangitic features, cholangitis.
Anything in the abdomen?
the abdomen, the drain output. What is the drain output? What is the color of the drain?
It's not a case of stricture, it's a case of stricture. Maybe a longer stricture, long duration stricture. Yes.
Next surgery and the presentation of the 6 months. Need anything else?
Probably secondary biliary cirrhosis.
What would you look for in the abdomen in that case?
What is the thing which you are looking for? You have this thing in mind. So you suspect that this duration is going to lead to secondary biliary cirrhosis. So in examination, what are the things you are trying to look for?
So we will start with the
abdominal finding.
So, on clinical examination, sir.
Or general also.
Sir, if you go for ultrasound abdomen, sir.
Palpation, would you look for?
Sir, in there might be ascites. There might be ascites might be present.
More importantly, splenomegaly is something that
Size of the
So next.
So essentially examination is normal.
Equalics.
Okay. So will you like to do rectal proctoscopy in this question? This is digital rectal examination.
No need.
Okay.
I'd like to have a complete blood picture along with renal function test and liver function test.
Say, in what order you said? First is?
So complete blood picture.
What's your plan now?
Sorry, sir?
What's your plan now?
Sir, I'd like to see the general condition.
What is your plan now? Plan. For this patient coming to you 6 months after having a stricture.
Provide surgical drainage to the patient. Type of injury. The type of stricture that the patient.
First, we have to identify
Characteristics.
Let it come from sir from
So telling surgical drainage, there is no such term in biliary stricture surgery. Have you heard any surgical drainage? See, specialty practice, you should be very clear. Don't tell I am going to examine the patient. These are all MBBS. Just leave it. You tell what exactly you want to do now.
The broad term you can say you want to disturb a biliary continuity, or you can say vertical.
So do you know this patient doesn't need liver resection at this stage?
No.
Why you are telling it is biliary drainage?
No, sir. We will stage first. We will.
Do you know bile duct is available there or not first? Let us say completely all the systems are structured. Do you know this patient doesn't require transplant at this stage?
That's likely, but sir, yes.
All these surgeries are possible in biliary stricture. So without that, if you jump into conclusion, that means it's not a correct approach, no? So now you tell what you.
The idea is first, try to establish what is the injury, what is the type of injury, and then you plan for that injury. So investigations should also be targeted like that.
Yeah. First, I would like to general condition with the help of hematology, and it's within normal limits. The INR is.
So how is that going to tell you about the injury?
Or the injury I will come later with investigation. First, I would like to look at the complete blood picture, renal function test, and NFT. Then I will go to the
investigation.
First, you will establish the diagnosis. Then the planning surgery, then you do all this.
The ultrasound, the first investigation, ultrasound. But before that also, I would like to do the LFT examination.
Show the ultrasound.
So what do you make out of it?
So the distal CPD and the proximal common hepatic duct is not.
Don't read the report. What do you make out?
Yes, sir. So likely the injury part is just below the. We cannot make out that it is at the hilar or, but surely CVD is not visualized in the ultrasound because of gaseous distension or because of.
What things?
The intrahepatic biliary channels are mildly dilated. Probably it is at the stricture at the hilar.
Is there something which is clearly written here?
Yes, sir.
What is
Probably later. And the
protection of the level is more than so, but there is no biliary cell also.
No.
Yeah.
And the time period is also 1 month, so it's less likely to have section.
After this.
So after this patient is having no collection, sir, I would like to see the renal function test, and after that I will look for MRI with MRCP.
So after ultrasound, you want MRI and MRCP.
MRI with MRCP, yes.
Okay.
LFT, I would like. Total bilirubin is 11.9. The direct bilirubinemia of 7.5. SGOT SGPT is mildly raised 82 and 53. ALB is raised significantly 507, but from January 14th there is a decreasing trend in 527 ALB and total protein 7.2. Albumin is within normal range.
So what do you mean?
The patient is having obstructive jaundice with with cholestasis pattern, raised SGOT, SGPT, and ALP.
It's the obstructive jaundice,
Obstructive
extrahepatic cholestasis and unlikely.
Yes.
Right. Matter ends there. The next.
The next is MRI with MRCP.
Keep reading.
So these are axial scans of the MRCP.
Go back. Yeah, please stop.
So these are the axial scans of the MRCP done on 30th of December 2024.
No, that's not right. This T1 is a T2 with trans enhanced without
I'm coming.
complete.
Yeah. So these are the axial scans of non-contrast T2 weighted images of MRCP. Yes. So there is mild biliary dilatations, intrahepatic biliary dilation on MRCP. The right side and left side.
No, what is seen on the right side?
The segment, there is mild dilatation of the intrahepatic dilation on the right side.
Which is you are seeing here?
Right posterior sections.
Right posterior second.
Okay, go.
But this.
Yes. What are you seeing now?
There is a.
Other people can also, it's only not for numbers.
Just go up and down. So there is dilatation of the left hepatic duct also, and cross dilatation with we are just coming to the hilar area, and the next slide will show there is a hilum, right and left hepatic duct. Next picture, please.
Which is the left hepatic?
What are you seeing here?
Sir, there is a right and left hepatic ducts are both not able to make the hilum, and they are disconnected. And the distal part, we are able to see the distal CPD.
First of all, when you evaluate a biliary structure after 6, okay, please assume that your biliary anatomy may not be normal. intraappendicular anatomy. Okay, so you please see the entire liver and then see whether your biliary anatomy interpretation is correct or not. So your liver is normal in this patient. Before interpreting any biliary anatomy, your liver has to follow the normal anatomy. Is it normal here?
Left hepatocyte is
Okay, so where is the you see where is the segment for duct here?
that's the segment.
So that point where mouse is there, which is it umbilical fistula or midplane? You see the entire, just play everything. What is that? Way to right side. Correct.
Would be on the right side.
So that is segment 4 duct.
That is segment
Is right. And to the right is the shadow which you are saying, that is the ligament of penis. And to the further right is segment 2. And in that area, what you are saying is the left duct. And come down. Come down. Up.
What do you want to see in the seat?
What is it? Seating?
Sorry, what you want to see?
The research.
Okay.
I am in Yes. Continuity but not discharge. Simply loss. Not discharge. Just go up. Stop there. Yes. Confluence is the sun is not discharge.
It's just form.
Permanent.
But
So we have to rotate.
what are the other important things which
We
you
have to rotate the images also for the reconstructed images. We have to rotate.
there are other important things which are visible in the right side.
Covering of the right side. What does that mean? Atrophy of the hepatic artery injury would happen in the initial childhood.
Right hepatic artery. Which is the, why you are telling right hepatic artery injury? So atrophy.
Or portal vein, right portal vein.
No, please don't talk just like that. Artery causes atrophy, arterial injury.
Okay.
What is the incidence of arterial injury in bile duct strictures?
That 5 to 10%.
Not 5%. Prospective study showed more than 30%. So when you get a atrophy is correlating with the portal vein injury, not arterial injury. Artery can still recognize. So did you see that portal vein injury in the original MR?
So there is no contrast given in that MR.
You explain the full scenario. What are the things you want to see? Are you just okay with the structure level?
So we want to see the MR contrast also, that we can make out the vascular
So your aim of imaging is atrophy, hypertrophy, vascular injury, level of structure, atrophy, hypertrophy, portal hypertension because of this, okay, and aqueducture of the liver, and internal fistula, external fistula, stent below or above the structure. All these things you have to see in this patient.
No, the diagnosis.
Sir, we are not able to find out the vascular injury. So if there is an MRI available, then we can go.
Biliary stricture I'm talking about.
we have to rotate the reconstructed images so that the overlap will not confuse us.
What is type 3?
When there is a floor is not where there is a injury to the flat floor is not.
See, say again.
So floor
So classification of type 3 then should stop at that. Then we can classify into A, B, and all that.
Type 3.
Is there any type 3A and 3B in this
Yes, sir.
village strictures?
Yes, sir. There is type 3 type 3. Yes.
So now you want to do.
Since there is a atrophy complex, I would like to do a CT.
So we can do the MRI with MRCP also. If there is not available, then we can.
MR with MRCP to hai.
That there is no contrast is given. MR is not there. It's only MR. MR angio with MRCP.
Contrast.
Yes.
CMR.
Yes, so we can do that also. Unlikely because there is no blood transfusion, there is no any findings. Transfusion is not.
Assuming that there is injury, is it going to alter your management plan?
Right now, this stage
not going to alter your management plan. What do you want to insist on that? Just for documentation.
Just for documentation for a medical legal purpose.
Also, these patients.
What is medical legal purpose?
So because if we can also injure the injury.
What you want the procedure? Okay, right. Say again.
So we can also injure during the procedure. If we go
which artery you are likely to injure? Left hepatic artery. Right. While duct injury, which artery you are likely to injure?
Right here, the versus and dissection part.
Cholecystectomy, which artery you are likely? How many percent right hepatic artery is absent in that area? Normal population.
Absent.
So this patient who underwent cholecystectomy, who doesn't have a right hepatic artery in that area, are going to sue you that I don't have right hepatic artery and you are injured.
But we don't know that he don't have right.
These are all soft point. These are all not very important.
So you will sit down with this history that there is no blood transfusion. Will you still go on to the MR?
Sir, yes. For documentation, yes. MR angio or CT?
We did have a CT.
CT. Can biliary stricture alone also cause without?
Yes, secondary biliary cirrhosis can also occur, but the time period also less. 1 month of jaundice, less likely, not less likely. 1 month of jaundice cannot cause with secondary biliary cirrhosis.
Sure.
What's the earliest period reported for secondary biliary cirrhosis?
So 6 months to 12 months actually.
Do you think when this patient said I was asymptomatic for 4 months, they were
Sorry,
patient was asymptomatic for 4 months. Do you think there was nothing happening in the biliary tract? And suddenly the stricture has developed. So what is the basis of saying it is just 1 month history?
Jaundice
surgery occurred 6 months ago.
The second,
you think in this intervening period nothing was happening in the biliary?
It was happening, but it was possible.
Patient was symptomatic for the last 6 months, probably not showing up.
It is statement. You think that atrophy is related to jaundice duration. That's not. Okay, atrophy is related to injury duration. Okay, 1 month has nothing to do with it.
Yes.
Okay. This is non-contrast, sir.
So this is the non-contrast Excel images are done on 7th of January 2025, and so we would like to see any collection is there or not. So there is till now there is no collection, and there's
do you suspect collection 6 months after that?
No, sir. On NCCT, I just like to know that if there is any less volume collection is there or not.
Residual collection. 6 months.
Unlikely, but sir, on NCCT, I would like to see that only. Otherwise, I will just watch. Sir, is there a calcification is there?
Was it required?
No, not required.
This is a
part of that. Yes.
So now
arterial phase. There is the arterial phase contrast in CT scan with the Excel images showing. We like to see the celiac acid and follow it up. Yes. The celiac axis with the common hepatic artery branching from the celiac axis, and from the common hepatic, the breeze goes down. Yes, the common hepatic there is left hepatic and the right hepatic is going. The type 1 arterial anatomy, and there is no arterial injury suspected in this. And I would like to see the left gastric artery also, and from the there is any arterial abnormality there. There is no left side. I like to see the SMA artery also. If there any apparent artery there on the SMA. Please go. SMA also did not have any branch from the branch for the hepatic liver. The type 1 arterial aneurysm is there.
How does the liver appear here?
The
Liver.
liver is slightly hypoxic as compared to
It's not
hypotension.
hepatomegaly, that's all. Otherwise, grossly this looks normal to me.
With respect to spleen, there is
The arterial failure, portal
venous phase. Yes, sorry. The contrast portal venous phase of the same scan and showing the normal enhancing liver with the yes. There is no portal vein injury also. So there is no portal vein injury also. The both are right and left hepatic vein are normally enhancing. The posterior portal veins just show is normal in diameter. And there is mild, there is a ISBRD and yes, please go down.
Isn't it too far-fetched to think that there is a portal venous injury which is manifesting at this stage? Arterial injury, understandable, but we are just having a portal venous injury and which is manifesting 6 months later. Is it not a little far-fetched?
So we just confirm.
Just overstretch the things.
Okay, so now we have done this. You have confirmed that there is no vascular injury. Give me your final diagnosis.
Type 3 benign.
How are you taking a complete diagnosis?
Type 3 benign stricture with surgical obstructive jaundice post open polycystic.
Portal vein anatomy. Just see the portal vein anatomy. See the portal vein anatomy. The duct you are seeing segment forward. The segment forward. So see the portal vein anatomy.
Segment 3 portal, segment 2, segment 3 portal.
So all these branches which you are saying are from which side? ये जो दिख रही है ऊपर branches ये कौन सा segment है?
This is the top first line.
ये इधर इसके में ये this one.
There is a right, this right posterior
right.
So it is right angle.
Training. Will that drain into the rectal portion of the portal vein?
No, sir. No, sir.
So what's happening here?
So no, it's just there. So can you see the right posterior portal vein here now?
Yes, sir.
Going down, and the right anterior portal vein there.
Yes, sir.
So that is your both branches were of
Second.
So what's happened?
Sorry.
So what does it tell?
There is no injury.
No, there is no injury.
So why segment the right side
See, the retropy complex is from hilum has turned anticlockwise.
It's because of biliary problem.
Would you like to see middle position of middle hepatic vein? Not interested.
No, sir, we should select.
Why?
So if you are planning for, you don't get it out.
Middle hepatic vein.
Middle hepatic vein is less likely to be injured in the.
Is that for the purpose of
Not for injury, but to define the right lobe and left lobe, we'll have
yes.
to see it.
That's right. Okay.
So you said your diagnosis is type 3 injury
with collagen.
Yes. So now what is your plan? How do you want to do it?
So we will like to first this patient is symptomatic with cholangitis. We will like to give antibiotics which resuscitate the patient with fluid and antibiotic broad spectrum antibiotics. The patient will not respond to the antibiotics within 24 to 48 hours. We will like to go with the treatment of cholangitis, the RCP instead.
PTV.
Sorry, sir. Not DRCP, sir, PTVD. No, sir, sorry. PTVD, sir.
We consider PTVD for treatment of cholangitis in this video.
No, is cholangitis an absolute indication for preoperative drainage? Supposing the patient has a count of 12,000 and occasional fever, 1 or 2 spikes, mild cholangitis, I would say. Does that become an indication for preoperative drainage? No, sir. Unless it is the permanent cholangitis, toxic cholangitis, it becomes an absolute risk for surgery, then only you think of preoperative drainage. Otherwise, it's quite natural for these patients to have once in a while fever, fever.
If the patient did not respond to antibiotics, we will start with the broad spectrum antibiotics. If the patient did not respond within 48 hours, then only we will mild cholangitis.
For mild cholangitis.
Okay, the patient has responded to your antibiotics. The counts have come down 8,500 to 14,000. Do you want to drink preoperatively or want to go upfront surgery?
So upfront surgery.
Why you tell upfront surgery? This patient needs right appendectomy, then
if major appendectomy is planned, then only will.
He's planning. You have to tell no.
What
is our plan?
So we are only planning a enteric drainage.
Restoration of biliary continuity.
So you're not planning appendectomy.
Yes, no, not planning it.
How do you know it is required or not now?
There is no, sir, there's no cross atrophy of the right lobe of the liver. There is no.
This CT is done on 7/11/2024. Okay,
The first,
correct.
yes, sir, around 11 1st January.
Then when is the MR done? MR done. Show the MR. Which is the date of MR?
Jan, sir. No, sir, CT actually we have trained 7 January. It was missed like 11.
I think I'll ask Vijay on this. Does resection become a first stage? First stage also
we have to train by doing it.
That is what. So why think of resection at this stage and for a type 3 structure that too? You would plan a particular diagnostic in this patient.
Straight away.
Unless this is a right duct retracted type 4 stress where the right duct is retracted well into the liver, when you cannot achieve the pediatric anastomosis, then you think of knocking off the right lobe and then
So, suppose your plan, you said that you want to do reconstruction. You being a good surgeon, you will plan your surgery. What difficulties would you anticipate in this particular patient after having gone through the scans?
If there is atrophy, hypertrophy complex, it will be difficult to reach the high level percent. So in that case, the intraoperative ultrasound is.
So you anticipate that intraoperative will be very difficult for you to
reach the high level. To reach the
right side of the
patients to identify the intraoperatively, then you can look at it.
So preoperative PTC can be done.
That is such software
on table intraoperative.
So now intraoperatively, how will you identify that?
We can follow the calcium ligament and keep going we can go to the high.
So tell me to that, how do you identify, how do you isolate that duct? I mean, there are some 3-4 defined steps.
So there will be adhesions over there in the ball adhesion. We have to dissect the ball adhesion.
No, in section around the quota.
Yeah.
Talk about those steps.
So lower the handle plate and follow the.
So first you will like to see the segments or the base of segments. Then
lower the handle plate.
Identify the
left duct. First we have to identify the left.
No, first you should try to listen. Yes, sir. First you try to listen and then
speak also.
Yeah, that would be one of absolutely. I will that.
The question was, when will you put a pre-operating catheter into the system? Cholangitis is only one of the indications. Okay, so if you have a difficult structure, even if no cholangitis, for identification you have to put. Even the mild cholangitis, it may be possible to control. After seeing the biliary structure, still you may put a catheter. That should be your answer. Okay. It's not only cholangitis, because this is a here we are dealing with a difficult situation. Okay, because atrophy is there. Okay, and second one for a very precarious question.
At the right, anterior posterior tabs would be further posterior because of the atrophy.
No, something more on the intraoperative approach, like identity. Hilar dissection, lowering of the hilar plate. You are not still not able to find the duct. What more?
We try to. Then we can maybe do needle aspiration test to correct.
You're talking me here.
Cystic bed, sir. The GBP.
At the second. On the corner, second.
That one both yes, you can excise that. Yes, you can excise that base of the segment so that you are still deeper into the island. So still you cannot find. I mean, it should be that procedure tolerance. There's a reason why.
When you partially do resection of segment, what is that procedure tolerance? Don't. Anybody from these students against they want to say? My God. Who said that?
Okay, lady over here. What is that?
Any other investigation in this patient now?
Speed.
Available.
So PTC we can do for identification.
Tell me just the 4 criteria of a good hepaticojejunostomy.
This patient was one is that we
Correct.
second is what the optimization we use for this patient.
Correction of coagulopathy, sir, with vitamin K and increased frozen plasma, sir, if needed, followed by rehydrations.
Preoperative antibiotics, as we've already told, and then we'll try and monitor the urine output preoperatively, and we'll see if there is any
How many hours before surgery?
24 hours antibiotics. 24 hours before the surgery will start. Patient is having cholangitis, so we start with the antibiotics only.
So you will operate when the patient has a cholangitis, no 24 hours.
No, the patient is having patches, it start by antibiotics.
Optimization. And you can take care of the sepsis part of that. Before you start planning, patient should not be in sepsis.
It should not be, yes.
So by what incision do you operate this patient?
Inverted L. So Cockers incision, palliative Cockers or inverted L? Inverted L we follow inverted L. Generally, in our institute, we inverted L incision.
We do it by right subcostal with midline.
Bilateral subcostal, right subcostal, wide subcostal, extended.
What is the
You can start from the first candidate here.
Sir, the stoma size should be 2.5 centimeters. The anastomotic side should be 2.5 to 3 centimeter at least. Should be doing it with multiple interrupted sutures. Because, sir, it will contract later on, and it may
contraction?
It may nearly contract to 1/2 of it. Sir.
So do you need 1.2 centimeters of stoma? What is the size of the papilla? Of papillary opening? The bile drains to papilla?
Yes.
Right?
But sir, it will drain.
What is the size of the opening of papilla?
One line has fixed structure. It's not as steep as the narrow anastom of it. One thing you can go by the size of the papilla.
So basically, yeah, so 2.5 centimeters because it may narrow down to
any other terms.
So that is then one is wide anastom. Second,
anastomosis should be done on the interrupted switches.
That is not the correct. Second is
well maximized time.
It should be well maximized. Third,
to duct approximation.
Because to be
Tension free.
And more important,
Tension
how to ensure it should be tension free and how to ensure that you get a wide anastom.
Extending into segment 3.
How do you ensure a tension-free anastomosis?
Reinforcing suture.
At least fast, this thing should be taken.
What technique do you think for
Sir, railroad technique. Sir, railroad technique.
It's a little difficult. Before going to surgery for patient, there's a 6 months post injury. This patient should undergo an upper GI endoscopy to see varices. This patient should undergo fibroscan or RP scan to see the liver architecture. You are not seeing this spleen enlargement, which is, I think, mind spleen enlargement is there in this patient. You also have to see the count. Okay, all this taken into consideration. Then you want to do a hepatic endoscopy 11 bilirubin. That's what the bilirubin is. 11. Please think whether you want to enter directly or not. In a rotated hilum and an atrophied liver, a lot of crowding on the right side where you are expecting a difficulty on the right side. Okay, that's what you have to think in particular this patient. I would straight away go with a percutaneous drainage.
Now, by definition, would this injury be qualified as a complex?
Yes, it will be able to be complex. It is a complexity.
How do you talk to this patient post-operative? Will you put intraoperative stent in any scenario where you put intraoperative stent?
It's a transanastomostic stent.
Don't indication of stenting.
So both the ducts are discontinuity and both the two anastomosis.
Difficult anastomosis. Difficult anastomosis.
Anything else?
Very small size ducts. Very small size ducts.
Undilated
ducts. And sorry.
Whose technique is that? Mingus technique. How do you follow this patient? The institute which where they have defined the criteria of post-op, criteria for follow-up of Bile treatments.
Second weekly liver function test.
Okay, hold on.
Initial 6. 3 to 6.
No, at this stage, it's very clear now. What? Is there any benchmark to follow patient with biliary structure?
To assess the patient clinically, biochemically, and radiology.
What is the criteria you follow?
What is your concern? Two things.
The development of cholangitis are concerned, development of any stricture in the long follow-up with the stricture formation, and in the recent early follow-up when the patient is admitted, the development of cholangitis can happen. Like that.
How you are going to follow is you first mention the components of the follow-up, then you tell the frequency of follow-up. So, what are the components of the follow-up?
Clinical, radiological, and
radiological examination. Radiological examination.
If a stent is already placed, then we can put stent is already transanastomostic stent is planned. If not placed, then we can go with the USG and followed by MRC.
Follow-up include clinical examination and a liver function test. Okay. Imaging and nuclear scan and other imaging modalities are only in patients whom you found any abnormality on clinical and liver function. Now, how do you categorize these abnormalities in clinical and liver function test? What are the criteria? What are the categories?
Development of jaundice.
The outcomes are same day of
excellent response, good response.
What is the
criteria for this? Okay. Sir, how do you get it?
So it's excellent, then good, excellent, better, good, and poorer, sir.
No. It is McDonald's criteria. Okay, it's not what is said. So you please go and what is McDonald's criteria? What is poor?
So poor is radiological.
So basically, you are trying to categorize patients who are asymptomatic.
Yes.
Okay, symptomatic. Okay, only with the biochemical abnormality patients and those who are going for reintervention. These are the 4 criteria.
Symptomatic biochemical. That is now, not forbid. Last question. This patient comes to you 3.5 months back later with again history of jaundice and fever, and you do his her bilirubin is 7. How will you manage this patient?
So we'll then also like to see the dilatation of the bile ducts.
There is intrahepatic dilatation.
Then we will go for the stenting, PTC stenting and dilatation.
This patient, sir has told you, this patient is coming with jaundice.
Yes, sir.
You know about this patient. What is your concern with this? This patient can come with jaundice only with biliary stricture?
No, sir.
What else can happen?
Sir,
Secondary biliary cirrhosis is not reversed.
How you assess? She comes to you, but she has done some her family physician has done bilirubin, LFT, and UST, and she said
so there is intrahepatic biliary dilatation, and most likely it is stricture. Then
If there is pneumonia, then the sector is not there. Probably she's having second features because of the rise in bilirubin because of the second business cirrhosis.
so we'll again do the RCP and MRI, and we'll look for the any complex atrophy, hypertrophy complex, and cause of the bilirubin is there. Then caudate lobe also, if there is any hypertrophy is there, and then accordingly we will look if there is dilatation. If there is only dilatation, then we can go for stenting and dilatation. If there is only stricture, then we can go for PTC stenting with dilatation. And if there is
how open will you
sir every six every 6 weeks for 1 year. For 1 year we have to dilate and again
that is a given thing every 6 weeks for 1 year.
every 3 months for 1 year. Every 3 months for 1 year. And if they after
so till then you keep the PTC cap in place?
No, sir, only internalization or
Keep it in place.
keep it in place and then stent.
Is this SBC reversible?
Sir, it is in 70 to 80%. It is reversible.
In the initial period.
Broadly speaking, it is not reversible. But there are reports, isolated report that where secondary genesis has reversed after.
Any questions for sir? Other faculties want to ask any questions? Chandri sir, the residents. Huh?
Faculty.
Also ask about India.
So you mentioned pneumonia is not a criteria to success of failure. Okay, that's not included in the criteria. With pneumonia also there can be stricture. Stricture is measured by clinical symptoms, LFT and imaging.
Yeah.
What would be the time interval for follow-up the exit practitioner?
Usually we call them post this we usually call them every 15 days initially. And we do the first LFT we do at the age of 1 month. And based on then from that we take it over after the
See, 90% of the strictures would manifest within first 3 years of so at least follow up to 3 years is definitely on, and beyond that maybe 5 years, 7 years. Thank you, sir.
Thank you all the faculty members and delegates for this intellectual session. For the next session of 2 post-op scenarios, I would call upon Dr. Anivit Dev, Dr. Sanhita Panigrahi, and Dr. Gajendra Dantotia on the delegate seat. And for faculty members, I would call upon Dr. Ruby sir, Dr. Chetan Katharia sir, and Dr. H.S. Nag sir for chairing the session. And for conducting the session, I will call upon Dr. Anuruddh Goyal.
It's a case of 35 years of female without any known medical restriction. Underwent second stage of the elective open completion proctectomy with IPA, that was J-pouch, without any covering stoma. Indication was steroid refractory ulcerative colitis. That was for 2-stage initial proctectomy. Uneventful intraoperative course. Drain was placed in the pelvis. Post-operative course from day 1 to day 4 was uneventful. On post-operative day 5, she started complaining of fever and chills, maximum 102 degrees centigrade. Fahrenheit, sorry. and plus lower abdominal pain with distension. On examination, her tongue was dry, she was febrile, BP was 90 by 60 millimeter mercury, pulse rate was 125 beats per minute, chest bilaterality was reduced, per abdomen distended, and rebound tenderness was present in the lower abdomen. On wound examination, there was circular discharge present with one pad soaked. Inducing so CVP was day 6 and per unit was day 6. Last day intake was 2700 ml. Orally, she has took about 200 ml. Total was 2900 ml. Urine output was 400 ml and drain was 40 ml per bit. Balance was 1600 ml positive.
Yes, KG. So, what do you think is happening to this patient?
So first possibility is a PA leaks and most probably with BOD5 she's having complaints of the signs of sepsis with the new onset of fever and abdominal signs and symptoms as well. Most probably an IPA leaks.
What do you think has leaked? The main anastomosis or there's a pouch future line?
Sir,
What are the overall places where a leak can happen in a pouch? So this is post-op day 5, we're suspecting a leak.
It's on day 5 itself. Huh? So what do you think?
The islet pouch anastomosis or the J pouch staple line.
Okay. One more. So the anastomosis, the circular anastomosis can leak. Yes, the pouch can leak. Then
Tip of the
the tip of the J that can also leak. There are 3 potential points for leakage in a J pouch.
So in order to confirm that it is not the pouch in an anastomosis which is leaking, what will you find out from the operating surgeon? What would you like to know from the operating surgeon?
During filing the staple, was there any misfiling or
1 second.
Was the donut complete?
The completeness of donor. And third is?
air leak test was done?
Yes. What leak test?
Air leak.
Air leak. How do you do that?
So we place a catheter inside poly catheter and then inflate it with air. And prior to that, we clamp the proximal limb of the J pouch and then we inflate air. And
no, and what do you do? No, you put instill water, saline into it, and then you push in air and see whether there are bubbles or not. In case, suppose you are doing this, you find it in some bubbles. You find that there is some bubble, and you see that there is a small leak, and your donor at one particular area is little not complete, little deficient. So how will you manage this patient? You are operating surgeon.
So
how do you manage this?
So intraoperatively, if we identify and it is a minor one, we can reinforce with sutures around table itself.
So you want to reinforce it with suture, yes, and then again confirm whether it's okay. Now this coming back to this patient, how will you manage?
What else before that? Once you reinforce with the suture, when you have a doubt, what else will you do in that case? Definitely you will do a stoma. If there's any doubt about the anastomosis, even after repair, you must do a stoma.
Ask for intraoperative part. So now what will you do? That's intraoperative.
There was no requirement.
So nothing of that sort was there. But anyway, this has happened on day 5. So what will you do next? You are from your name?
Sanita.
So what will you do?
Patient has signs of peritonitis, so I may need to explore.
Is it a generalized peritonitis, localized peritonitis?
So rebound tenderness is there for localized peritonitis.
So you would want to straight away explore, or you want to do some investigation for it?
After the resuscitation is fluid, I'd like to get a CCT done. Then
Okay, so you resuscitate with fluids. What else will you do? The one thing that you also have to do before you do all this, you resuscitate with fluids and
the CCT contact.
for that
start antibiotics.
Start antibiotics. Okay. First thing when you suspect sepsis is resuscitate and give antibiotics.
Step up the antibiotic because the patient may already be on it. Another important thing in your presentation, clinical findings, what was most striking that this patient is in sepsis?
Tachycardia was there.
And
on the lower side.
And Urine output was on the lower side. It was only 400. Okay. So now you do a CCT scan. You have CCT scan? Okay.
That is static image only, which is showing the air level plus this one is collection.
So it's only at that particular place. Third person, what will you do? What is your name? Name. Gajendra. Okay, Gajendra. Gajendra, what will you do? Localize action. So now you have to figure out the trend of that. Basically, how the it's on localized collection we can do here. So the counts are steadily rising. So you would want to do a USC guided brain exams. You all agree to it? Or you want to do differently? Is there a way to do the Sangeeta? You only take up first. What about you?
So we can first try for a percutaneous. What will you do? Sir,
You are the only surgeon there on the
percutaneous intervention and see how this patient is responding.
So you will first want to do a percutaneous ultrasonography guided percutaneous
Drainage with NPO, fluids, and antibiotics and
Okay. So suppose a percutaneous drainage was done and it is draining now every day around 150 cc of feculent material. Now what will you do? Till what point of period you wait and before taking up the patient was no, now in case you have done a proximal diverting ileostomy and you still now you are getting this around 150 for first 2-3 days it's 150 cc. Actually, this patient there is no ileostomy. Okay, then patient with saline lavas take out that Moses and took the proximal. On table, you find that there is only a small area which is given away. Are you tempted to reinforce it by taking sutures, or you still want to take away, do away with the anesthesia? So there's collection. It is draining, but it's a controlled collection. And we can do the proximal stoma. And
What cases you will do proximal stoma? In what cases you will do just proximal stoma? Any cases where you will do some additional procedure? What are the additional procedure?
Cases, one third. Yes. And in such case, we can preserve that. There's a long term. Such case, we will do the stoma. There's more than that. Section that we have to take down.
More than 1/3 or more than 50%? More than half. So what are the, it is less than 50%, what are the options you have to deal with this? There are any other options also? Are there any endoscopic option? What is that?
Endovac therapy. That type second case? Yes, okay, and so you can do endovac, okay. And what are the other factors which will dictate whether you do reinforce it and do this, do a proximal stoma, or straight away do a dismantling of the anesthesia? Apart from the extent of the patient
vitals, hemodynamics,
and patient on the second, third, you're doing very good. First is the extent of the deficit. Second is the hemodynamic status. Third, sepsis. Sepsis is there. It is controlled fistula. The counts have come down
in 3 days time. What else will help you to? What else will you put?
Local contamination.
Local contamination is controlled fistula now. Then
So the nutrition is a big
the age, nutrition of status, comorbidities. So these are all these factors which will help you to take a decision whether you will want to reinforce that proximal stoma or you want to do dismantle. Now, suppose you dismantle this. Yes. Right. So suppose you have taken down the anastomosis. Now, how will you manage it subsequently? You've done a problem, you've done this, you've taken down the anastomosis. How will you manage it further? How will you counsel the patient and what will you do later?
Then we get for a redo pouch, but
How do you counsel the patient first? Very important, right? You have to talk to the patient and patient's relatives. So how will you counsel them?
we'll explain that the success rate of a redo pouch is lower and
First you have to tell him what is happening, why it is happening. And then you say that we may try subsequently. So what will you want to do subsequently? And at what interval will you think of doing it?
expertise is there to pouch.
Stabilize patient, patient. Can counsel the patient that after very last surgery and they have to explain the chance of that this surgery may not be possible. That intra operative maybe permanent stoma that perfect. Because you have already done an item pouch single anastomosis. You are going to dismantle it. It's going to be very, very difficult to do it. If at all, you may do a straight ileo anal anastomosis, but the mobility is going to be in question. It won't reach there unless the patient is very young and it reaches.
You have to assess the anal canal also. Sometimes the anal canal strictures off, so you don't have anywhere to anastomose. If you leave the pouch and do a proximal stoma and then reverse it later, what do you think will? How will that affect the pouch function? Do you think it will come back to normal, or what happens?
The chance
So you put in a drain, patient you pull out a proximal stoma, patient becomes better. So now when you're going to reverse that stoma, how will you counsel this patient? What will you tell the patients about the chance?
there's just no pouch failure. So that we need to explain. The frequency may be higher even after.
And why is that?
The motility function of the pouch is lost.
So the compliance of the pouch goes. This pelvic sepsis, the pouch becomes rigid, and so the compliance decreases. So the functional outcomes are always worse if there is pelvic sepsis after pouch.
Any investigation which can suggest a problem after restoration? Endoscopy, manometry, anything.
So the bronchoscopy can be done to look for the mucosa and
Moderate to move. Next case.
It's a case of 40-year-old female without any comorbidity. She has underwent open ultra-low anterior section with covering loop bileotomy. Indication was moderately differentiated adenocarcinoma of lower rectum, status neoadjuvant chemoradiotherapy. Drains are placed in pelvis. On post-op course, post-op day 1 to 6 was uneventful and drain was removed on post-op day 5. On post-op day 7, she started complaining of persistent lower abdominal pain along with high-grade fever with chills. On examination, general condition was fair. BP was 110/60, pulse rate 105 beats per minute. Chest bilaterally rate reduced, lower abdominal tenderness present, but no guarding or rigidity. Stoma was healthy, no mucocutaneous disruption. 800 ml ventricular fluid noted in the stoma bag, and wound was on wound examination, erythema around the site was present. Last day take output was total was 2200 ml and total renal was 1200 ml with stoma effluent of 800 ml. Balance 100 ml positive.
What do you think is happening?
Diagnosis. Start with diagnosis and then why you think the diagnosis. Okay, one anastomotic. Any other options? Seventh post-operative day after lateral anterior resection, patient has lower abdominal pain, high grade fever.
UTI is
Pardon?
UTI is a possibility.
Urinary infection, okay. Very good. Anything else? Pardon? Thromboembolism will okay, it's a distant possibility. Very low down on your list. What else? Other common things. Any other intra-abdominal pelvic collection? Was this one, I don't know whether it was in lap or open. If it's lap, this is open. Okay, if it was lap, you have to also consider other small bowel injury. Other thing is colonic ischemia. You can have conduit ischemia, pelvic hematoma with infection. So all these have to be considered. The most important is anastomotic leak, but you have to think all the other causes as well.
So how will you confirm your diagnosis?
Leak, I would like contrast in a CT scan of the abdomen and pelvis with rectal leak.
When you do IP contrast, oral contrast, or rectal contrast? Rectal contrast. Suppose it shows that there is a small streak, but it doesn't explain the collection, amount of collection. There's a collection, it's a very small streak.
We need to drain the collection already. There's a stone in situ. So to control local infection to drain the collection.
So you will drain the collection and you will monitor the output of the collection. Over at the end of 4th or 5th day, initially it started draining 100 cc and it comes down to around 20 cc on post-op day 5. Then what next you do? And the fever has also come down. And obviously you have stepped up the antibiotics, the counts are measured. Now what we do?
So we can continue conservative management with the drain and the stone.
How long? When will you remove these? It comes to 20 cc at the end of day 5. When will you remove your peritoneal drain? Basically, it's the function. You have done a proximal stoma. You could remove the drain. Now, what do you anticipate when you are following up this patient on regular follow-up to your OPD? What do you anticipate in this patient to happen?
Stricture at the leak site.
So you anticipate that this patient may develop a stricture because he has a small leak and it may heals with fibrosis. So what important investigation otherwise also you would do, but in this patient you will definitely do prior to taking up this patient for stoma closure. Distal lupogram. What else?
Colonoscopy is it?
You will do colons. You have done a low AR.
Stomoscopy. Distal stones.
You can do a rectal examination and come to know.
Yes. Very important. You wait longer in these patients.
Let me ask you, in these patients of when do you usually remove Cohen's catheter? At what post of day? 5 or 6. Why so late? Because of Pelvic. So what happens? There occurs neuro. At what points of your dissection are you likely to damage
the nerves. At which particular points of your LAR are you likely to damage the nerves?
Posterior resection.
So first and foremost,
So they take over the one time the IMA
which medical?
ligation of
So what nerve does get you get? What plexus do you damage? Hypogastric, superior hypogastric. Sympathetic or parasympathetic? Sympathetic. Sympathetic. Then second, lateral pelvic vortex. Third, when you are dissecting anteriorly at level of fascia denominal.
Where does all of it finally go? Towards the denonvillus and into the prostate and bladder. So that's the point where you can mix this up.
This you should. What is LAR syndrome?
So persistent increase in stool frequency.
It's a syndrome. So it's multiple symptoms. So what is LAR syndrome?
So perineal pain with increased lower abdominal pain with increased stool frequency.
Based on the history of this patient, do you think this patient is more likely to get LAR syndrome? What? Post-neoadjuvant chemotherapy, ultra-low resection, and sepsis. So what are the various advices or methods of reading LAR syndrome? Which do you know? Wexner's or
How do you grade the severity of LAR syndrome? You have to the last score. LAR is last score. So very easy score to do. You can say whether it's mild, moderate, or severe.
how can you intraoperatively predict that this anastomosis of mine is not going to leak at all for sure?
We cannot predict.
Huh?
Definitely we can predict.
Especially if you're doing laparoscopic surgery or even open surgery. The ICG link test will tell you
What are the question is what intraoperatively what steps can you take to decrease the anastomotic leak to the minimum possible? What are the steps which you will take? So how do you check vascularity? One is visual inspection. Are there any other techniques which you can use? So what is ICG test and how does it work? So bowel perfusion. Okay, but ICG is used for many things. So if you test it for bowel perfusion, to look at bowel perfusion, what is the principle and how do you do it? Just in a nutshell, just in 2 lines. We don't inject it half and half before doing it. No. Anybody?
So we inject ICG and then with the, look for the vascularity at the cut ends of the anastomosis.
Okay, so when do you inject the ICG? Intra, but when? Within how long of giving the ICG do you assess perfusion of the bowel? The bowel should light up within less than a minute. Okay, you give ICG and immediately you can see within few 10 to 15 seconds you will see the perfusion, which is always less than a minute. Okay.
Last question. How do you ensure that there is a tension-free anastomosis? Ultra. What do you do?
complete mobilization of the splenic flexor transverse.
Realize this splenic flexure for sure. And when do you do high ligation of IMA?
The lymphodal bodies.
You always do, but at what level?
Just after the left colic artery has been testing.
Is it high ligation or low ligation after the left leg? High ligation is just flush to the low ligation is after the takeoff of the left leg.
Okay, third case. हो गया? खत्म?
2 cases are there.
Done. Thank you very much.
Anyone in the audience wants to take any question? Thank you all the faculty members. For the next session, I would like to call upon the delegates, Dr. Toga Hemant Sai Kumar, Dr. Rajiv Joshi, Dr. Rahul Kumar, and Dr. Tarun Sutravid. And in the faculty members, I would like to call upon Dr. Piyush Sahani sir, Dr. Avinash Supe sir, Dr. H. Ramesh sir, and Dr. Peter Potakar sir. And for conducting the session, Dr. Ankit Sahu will take over.
जब बात होने गए थे तो सबको इंडिविजुअली लिखना पड़ा था उनको इंडिविजुअली
Very good afternoon to one and all. I welcome you all to the 8th session of the day with the permission of the faculty members with the pre-op case scenario. This is the case of a 26-year-old male who is a student from Bihar, presented with the chief complaints of recurrent episodes of pain abdomen for 3 years and passage of greasy stools for the last 3 months. He was apparently asymptomatic 3 years when developed pain abdomen in the epigastric region, which is insidious in onset, then aching, radiating to the back, mild to moderate in intensity, aggravated by heavy meals and relieved on stooping forward. The frequency initially was once every 2 to 3 months and now occurring at an interval of every month. Gradually, the intensity of pain has been increasing, requiring injectable analgesics. The patient also gives a history of passage of greasy, bulky, and foul-smelling stools for the past 3 months. Pain is associated with multiple episodes of vomiting, which is small volume and non-bilious. There is also a history of loss of weight present of 10 kg over the last 3 years. There is no history of fever, abdominal fullness, lump, or distension. No history of jaundice, high colored clear stool or pruritus. No history of hematopoiesis or melena. No history of decreased nitrogen, bone pain, bleeding on trivial trauma. No history of prior alcohol intake, gallstone disease, blood trauma, abdomen, drug intake. There are no medical comorbidities in the patient and no past surgical histories. Family history is not significant. Normal sleep apparatus, consumes mixed diet, is a non-smoker and does not consume alcohol. History, initial pain episodes are managed with oral analgesics. Now, patient is requiring IV analgesics for the last 5 months. Last episode of pain requiring hospitalization of 3 days, managed conservative. Move on to the discussion.
Would like to begin? First person.
Just like summarize what you've heard just now. Nice to say a teetotaler, 26-year-old man
who has been symptomatic for a certain period with certain symptoms which are like that. Yeah, better perspective.
And what is alarming symptoms have to come into your statement? What is alarming in this patient?
He's passing bulky greasy stools, likely suggestive of an exocrine insufficiency.
Are there other causes of greasy stools? Is chronic pancreatitis the common cause of greasy stools? I'm concerned that you have chosen to choose chronic pancreatitis on the basis of greasy stools. Because as far as I understand, it's one of many causes of greasy stools. It is not even the most common.
So GI surgical form probably it is.
He's a 26-year-old teetotaler, male patient with complaint of pain abdomen in the epigastric region for the past 3 years and complaint of passing bulky
pain, continuous pain.
Sir, it's episodic pain, sir. Sorry. It's episodic pain. And he has a history of admission in the last 3 days, which for pain for which was treated conservatively.
He now last one. Yes. He had admitted for 3 days, but before that he is shifted from.
He was shifted from oral to IV analysis.
That talks about severity of his pain, which cannot be controlled with oral. What else you thought was important in this history? Last with so do you think there exists history of other effects of any diagnosis other than what you said, exocrine deficiency?
Sir, there is no history of any endocrine insufficiency or diabetes. There is no history suggestive of portal hypertension, sir, in this patient.
So what is the history of endocrine deficiency that you were looking for, which you did not find?
He was not yet diagnosed diabetic. He was not using an anti-diabetic.
Before you get diagnosed, you get some problems. And those could be indicative of the fact that the person is developed diabetes. Weight loss, for example.
Sir, weight loss
happens in people with diabetes or no diagnosed diabetes. Doesn't happen?
Can happen.
So you see, I think this is a constant refrain. You can't forget your MBBS and you can't forget your master's in surgery. You can't suddenly jump to and acquire an MCH and DNB and start surgery.
Just if you had a patient space, what is the most sort of important aspect to get it, understand the severity of the patient symptoms. Somebody will say, I've got a problem for 3 years. Then I need to know severity. What are the parameters you use to assess anybody's severity of symptoms?
One is the change of medication, sir.
Okay. Change of medication, yes, from oral to IV. What else?
And affecting the quality of life, sir.
What's the quality?
In terms of?
In terms of their working hours, sir.
So, livelihood, ability to carry on their normal lifestyle, whether their day and their work lives is affected. Yes?
Yes.
Sleep. Whether you're able to sleep quietly.
Sleep.
Anybody else wants to add from this, or you're okay with what he said? Okay. Any other differential diagnosis you have in your mind? This is a very classical history. Therefore,
It could be even a chronic gastritis case. Chronic gastritis, 3 years, loss of weight.
IBMNS6.
Peptic ulcer disease, yes. It could be, sir. Peptic ulcer. What kind of peptic ulcer will cause pain? 3 years requiring IVM.
So patient having a neuroendocrine tumors like gastrinomas, so this might present with features of chronic gastritis.
And anything else? Anything else?
Pernicious anemia, sir. Chronic atrophic gastritis.
The first thing is quite okay. Second, I am not very agree with what you said.
The pancreatic division.
Yes, let's go to the physical examination.
On to the general physical examination. Patient is conscious, cooperative, and well oriented. Has a BMI of 19.3 kg per square meter. ECOG score 0. Breath holding time of 30 seconds. No pararectalous lymphadenopathy or edema. Vitals were stable and the patient was afebrile. On per abdomen examination, abdomen is flat with umbilicus in central position and inverted. All quadrants move correspondingly with respiration. No visible scar, crystalline sinuses or engorged veins or mass. Final faces and external genitalia were normal. Bilateral renal angles appear normal. On palpation, the abdomen is soft and non-tender. Liver and spleen are not palpable. No other mass was palpable. On percussion, the liver dullness was the upper one was from the fifth intercostal space. Liver span measuring 13 centimeter and the flanks were tympanic. On auscultation, normal bowel sounds were heard. On distributal examination, sphincter tone was normal. Glove was stained with greasy smooths and there was no palpable growth of pelvic deformities. Rest of the systemic examinations are essentially normal.
So the examination that you decided.
Very greasy stools on PR, that's all, nothing more than that, right?
So other than that, there was no any complications, sir. So this was a case of a chronic pancreatitis without any complications, and with the exocrine insufficiency and weight loss, it might be a endocrine insufficiency also.
Provisional diagnosis or confirmed diagnosis based on this?
Provisional.
So I think there is no complication. This is we don't know whether it's calcific. It's probably a case of chronic pancreatitis.
Yes.
Has recurrent episode. It's a recurrent kind of a penny episodes with probably exocrine deficiency, but no endocrine deficiency. That is what you feel. So how would you rate? What is how do you proceed further?
So I would like to investigate some complete hemogram, pancreatic function test, and function test. What pancreatic function test mean? At present, serum amylase lipase.
Serum amylase and lipase are pancreatic function test.
No, sir. It rules out if there is any acute or chronic pancreatitis.
So normal pancreatic amylase and lipase would rule out acute or chronic pancreatitis.
If it is elevated.
If it is elevated, does it
This
confirm?
patient, it comes to you today and it's all normal. Will you still rule out chronic pancreatitis in this case? He says today was a good day.
Because of exocrine insufficiency, amylase lipase may not be appropriate.
So you want to diagnose the chronic pancreatitis? No, it is like how to diagnose. Or do you want to?
First, we will get an ultrasound.
Your ultrasound, I presume?
Yes, sir.
So please make it very clear what kind of ultrasound you want to do.
Ultrasound shows liver 12 centimeter with normal liquid texture, no space occupying lesion or IAPT. Gallbladder distended, no calculi in the lumen with normal wall thickness. Common bile duct dilated, measured 9 mm at the porta. Pancreas shows ectopic parenchyma with the main pancreatic duct showing irregular dilatation measuring up to 11.2 mm with multiple parenchymal and intrarectal calcifications noted, average measuring 11 mm. The portal vein was normal in caliber and there was no ascites.
Can you comment on the ultrasound findings?
Sir, there is a grossly dilated MPD along with dilated CVD, along with dilated pipeline, sir.
Are you happy with our irregular dilatation?
Yes, sir. Likely there are strictures. This can be caused by strictures in the tortures.
Picture like that. Significance of the common myopathic dilatation. Is it biliary obstruction?
It can be due to an inflammatory mass in the head, which is causing
this. It's due to biliary obstruction. Is it a biliary obstruction?
Sir, there is no HPRD, so likely not.
So IHPR.
Sir,
what are the implications of such an observation?
it can be a choledochine association. MRCP.
What would you expect to see at MRCP?
So it could be cystic or saccular or fusiform.
Is that the criteria?
Crossly dilated CVD.
What is the MRCP criteria for establishing or something that has to be there to say yes, this could be a choledochal cyst?
There could be more external obstructions.
Yes, distal obstruction.
Sorry.
What is it?
With secondary cholelithiasis, choledocholithiasis.
Sorry. Yes, MRCP to confirm is quite in order, but what about
in absence of IAPR?
I believe in abnormal pancreatitis duct healing is the basic basis for diagnosis. What are the principles since you are simply
the length of the common canal is more than 10 mm, then it is considered as anomalous pancreatitis.
Explain this. Law.
The pollution is outside the duodenal wall.
What is outside the duodenal wall?
So if it is within the
outside the duodenal wall. So what implications of such a thing outside the wall?
So there could be a reflex of the pancreatic juice into the biliary system. Then it leads to choledochal cyst formation.
When does
the bile gets thinned off.
Doesn't happen. When does it get to happen?
Early 20s.
Sorry?
Teenage.
Oh, so this is earlier than that. Grow.
When do you see choledochal cyst? At the age of 20? No, I'm asking a question based on what he asked you. He said a little earlier. So it has bimodal presentation, sir, in childhood or in late adult stage. Yes, so the bimodal, so when does it occur? You pick it up at the age of 40 or 30. When has it occurred? Isn't it a congenital malformation? Okay.
Begins very early.
This patient has a biliary diameter. What do you presume the reason for that? We know no intrahepatic biliary dilatation. What is the difference between the biliary dilatation, let us say biliary carcinoma malignancy compared to chronic pancreatitis?
So even we need to look upon ALP, alkaline phosphatase. For cystic dilatation. There is in periampulary there is a sudden narrowing of the CVD distally.
In this patient, you have a dilatation, so you also have to consider it can be due to chronic pancreatitis. Okay, may not be so evident like a periampulary cause. That also has to be considered. What do you want to do next?
I want to get a complete blood picture done, sir.
What you are looking at CT and you got all the information.
You have done sonography, so I'm happy with this information. Or do you want more information about this morphology?
I want to know about get a Doppler done and know about the status of total veins, sir.
Thing is splenomegaly.
Splenomegaly is not mentioned. So presuming the spleen is normal in size.
At the medical examination, they said spleen is normal.
Yes, presuming the spleen is normal in size, what next do you do? Is this information enough for you to decide your plan of management, or do you want more information? If yes, why is it enough? If no, why is it not?
Say something.
That's fine. If you get KFT done and followed by kidney function test to.
So this is regarding you.
Yes.
So this is not enough for you to make a diagnosis. So why is it not enough? Make a diagnosis and plan your management. What additional information do you wish to gain by doing a CT scan? You wish to do a CT scan?
Yes, sir.
You want to do a KFT because you want to do a CT scan. Contrast enhanced CT. Correct?
Yes.
Okay. So what is the additional information that you wish to gain from that CT scan?
For the status of the pancreas, whether it is atrophied or status.
Can we have that report up, please?
Even we can look out for other causes of chronic pancreatitis. Are there any similar pancreas?
Just one. Let's have the ultrasound. Okay. Now tell us what is the additional information you're going to get. Atrophic pancreatitis, they've already said. What else do you
Sir, in CT scan, we can know about if there is any pseudoaneurysm, sir, or if there is any mass lesion in the head of pancreas.
So in all patients, you need to know whether there is pseudoaneurysm. You can't manage a patient without knowing whether they have a pseudoaneurysm or not. What proportion of patients with chronic pancreatitis have a pseudoaneurysm?
Why you want further imaging in pancreas? Because chronic pancreatitis causes certain complications. So you have to look for any mass incidence wise. And there are some rare complications which has huge implications. Can be rare, but these are the two purposes. No. What are you looking for? Pseudoaneurysm is a common problem.
Pseudoaneurysm is rare, sir.
Pseudocyst is common.
Pseudocyst is common.
What else?
No, sir. Sorry.
Pseudocyst then?
Pseudocyst, any mass, sir? Splenic thrombosis.
Mass of significance. Because if you look at it in a different angle, you have an open mind. Can you call this as double duct obstruction to the bile and pancreatic duct? Would it not be worthwhile asking oneself the question as to whether there is a pathology close to or in the portion of the pancreatic head which is causing the obstruction to both ducts? It's a worthwhile thought.
Yes.
You want to keep an open mind. So therefore, that category information be better served by a cross-section CT imaging. That's something one.
Looking for mass, structure, evidence of
any pseudocyst, sir. Splenic vein thrombosis.
And what else? Patient is alcohol?
No.
Splenic vein thrombosis. And evidence of what more? Acute pancreatitis.
Okay. We're talking about chronic pancreatitis and splenic vein thrombosis. What are the kind of scenarios you see in these two conditions? How should they, what is the likelihood? Does chronic pancreatitis produce splenic vein thrombosis? Or does splenic vein thrombosis produce chronic pancreatitis? What is the relationship between these two?
So chronic pancreatitis leads to splenic vein thrombosis.
Yes. Can. The other thing that can happen is they can coexist. You can have vein thrombosis on which chronic pancreatitis also supervenes. Yeah.
You also like to see the extent of the portal hypertension, know that what is the
gastric varices.
Do you prefer CT or MRCP or MR in this patient?
Since there is simply dilatation, MRCP.
Answer, would you prefer? Then you explain.
Yes, sir.
MRCP. Everyone has to have their hand up. But we will not start because after this wrong. That's not that's all you need to say. So please say that never again.
Yes, sir. MRCP needs to be done. Since we don't have any radiology ruled out in this patient.
MR plus MRC versus CT.
Is it? Because CT there is also said MR plus MRC. So I'm just asking you, why not just do MR and MRC would have been enough, or you still want to do a contrast?
So to look for aneurysm, we need to go for CT aneurysm.
But all that experience with aneurysms. Because you've seen many, and personally, when you're obsessed with aneurysms, I mean, you're well, you're quite being obsessed. Maybe in your practice, you've seen so many of them that they haunt you day and night. But here I've seen one. Most of us see it very rarely. So that obsession with aneurysm anyway.
So what will the target of process imaging? No, just now. Now you tell which is better.
MRI can detect early changes, sir, but
please explain.
So the answer that you're looking for is a justification to do either a CT or an MR. Whatever you want to do is perfectly fine. You say which one you want to do and then why you want to do it. That's all. That's all that we're looking for. Clear answer. I want to do a CT because 1, 2, 3, 4. I prefer to do an MRI because MRI and MRCP, if that is what you want, because 1, 2, 3, 4. The 4 of us, so 1, 2, 3, 4.
And then we can ask one of us to say what you prefer if you want. You just say two things in perspective.
So calcification and pancreatic stones in the pancreatic can be seen in CT scan, not in MRI, sir.
Can be seen as well in MR.
So why do you want to see stones? How is that going to make a difference to the further management of this patient? Whether he has 5 stones, whether he has 25 stones, whether his duct is full of stones, whether his duct is not full of stones.
Low calcium stones can be seen very well in MR, but they cannot be seen on CT. I'm just telling you, adding to this.
So Dr. Piju made the answer very easy for you, but you still don't want to accept it. He's giving you such a broad hint. Everybody understood that. You don't
So what will do? The pancreatic hydras can be vertiginous.
You want a CT or not?
Yeah.
And then you say why that's it. So your answer cannot be wrong because maybe your preference, maybe the timing for it, maybe your preference. You understand that there are different preferences. We have no problem with that. But you only want it to be reasonable in your statement. That's all. You cannot be an unreasonable statement.
One of the things I wanted to know.
Which one will you prefer?
First say we have
all of you seen patients with chronic pancreatitis. You dealt with them in the outpatients in the wards. In your center, do you do a CT or an MR? Each one of these. CT scan, CT scan, CT scan, CT scan. So the problem. Just say no preference. Now say why. अरे अब किस दिन डराया कि यहाँ पे
ये डरने का नहीं है और आपके
okay. Now each one of you, starting from the rightmost person, give us one reason why your center prefers to do a CT scan.
We are well versed with reading CT scans, sir, and CT scan can detect pancreatic head mass, complications of chronic pancreatitis like pseudocyst, any biliary obstruction or GI obstruction.
CT scans, it's investigation both to do and both to interpret. Okay, post surgeons. This is one of the main reasons why. Okay. Then when you want to really or badly want to evaluate the ducts, you go ahead with the MRCP. In this situation, do you need that much critical evaluation of the duct?
So dilated duct, we need to go for
No, actually, the other way around. What he did, he's giving him the answer. Most of his questions have the answers linked with it. What it was, if the arrangement was complex, if there were multiple stenosis, if the duct was not seen adequately, if the side branch, stricture or something like that, then he wanted more refined information in the form of a pancreatogram. Also, high quality CT scan can actually produce a pancreatogram today. It is totally agreed that CP would quote over the CT pancreatogram. In such instances, yes, there's a magnitude diffusion, for instance, as a prelude to doing an ERCP intervention, you would like a roadmap at this MRP provide you information as to where the disruption is from, etc., etc. So the answer away, he said, in those complex situations, they would ask at MRCP, but when you have which validation with multiple pictures and chain of dates or something like that, perhaps not.
Most important point you should tell your radiologist to do for that of thing, the pancreatic protocol. Once you do a proper pancreatic protocol, CT scan, and a high quality, many of your answers will be there. And only in few situations like this you get a answer.
If you had a portal question, we have investigation. If you had pancreatitis, Peter and the history of pancreatitis, and you wanted to evaluate MR, mammogram, active CT, what's your
CT angiogram.
Anyway, go ahead.
Contrast CT can develop the portal hypertension. Like the portal thrombosis is also a status.
Do you have a CT scan?
Yes, sir, we have CT and MR both.
Would you like one of them to evaluate this?
Is the non-contrast phase of full phase CT. You can see multiple calcifications in the pancreatic region.
What factors you want to done? Which one lab test?
He said it.
He said he will ask.
What you see here, calcification. The pancreas appears atrophic. There is central HPRDs. On a non-contrast,
On a comment on it. Use plain CT for calcifications, calculi, devout parenchymal attenuation, and density compared with the
Please go to contrast. Which phase you want now?
The body connection with the mid body near the top of the pancreas, I'm not sure.
So please, somebody describe.
Okay. So just quickly describe what you said, what are you looking for?
The pancreas is atrophic with multiple hypertense lesions, likely calcifications and stones in the head, body, and tail, unfinished process of pancreas. and without any vascular complications. So it is photovenous phases, so no thrombosis. Anastigmatic.
What else is special diagnostic? Bile duct
Central CBD is dilated, sir. The pericholecystic fluid is present, sir. So likely acute cholecystitis is also present, sir.
Really, I think it's not very significant. It's just folded actually. You can see the CBD dilated anyway up to the lower end. Is the calcification in the duct or is also there intrapancreatic calcification?
So in the parenchyma and even in the gut, sir.
And answer to that, the acute reaction that is impossible to determine. Most of the stones which have been described in apparatus side branches because they are away from the line of the main pancreatic duct are in fact in the side branches which are dilated and they could be difficult to comment.
Any other places though? So what is the diagnosis of pancreatitis?
So chronic calcific pancreatitis with exocrine and endocrine insufficiency and with so we need to again evaluate, sir. Yes, with exocrine insufficiency and without any major complications.
Painful.
Painful, yes, sir.
You know that this condition can be
painful
to say that the patient.
What do you want to do next? Somebody else?
Sir, an upper ear endoscopy, sir, to rule out any esophageal mass. Esophageal gastric mass.
It is normal. They have not done it.
That's the priority here. You've got pain, you've got exocrine insufficiency. You don't have any evidence of
No evidence of portal hypertension.
and then you want to do a TD, it's fine. And you have a endoscope.
What is the priority? What are the investigations you need?
Sir, HbA1c, sir, HbA1c to check for endocrine and RBS to check for endocrine insufficiency.
So stool fat and fecal elastase test.
Fecal elastase test, how do you do it? If you want to do it, so you'll have to tell me how to do it. Because the woman starts and I have no idea.
The estimation of stool fat is done for continuous collection of 3 days of fecal matter and quantification of
total standard fat diet.
On a standard fat.
The patient who has abdominal pain, if you give them a 75 gram, 100 gram fat diet, it's going to be impossible. That means really creating torture for the patient. You have to probably collect all the stools. Remember, it's greasy, it's large, smelly. You have to collect it for 3 days and then subject to fecal fat testing, which is not available in all the labs. So I don't think anybody does it except research. So
So fecal elastase is a small diagnosis. A small
priority here. Is that critical CAT is important or you are Desperate to establish fecal elastase 2 as a, what do you expect in fecal
So
elastase?
clinical diagnosis.
No, fecal elastase. Come on. What is the relevance of fecal elastase 2 in chronic pancreatitis?
So it points out severe insufficiency, sir. Yes.
Less than 20 units per hour is not. So it's got a very limited value. So you are aiming to treat the exercise insufficiency or to quantify it?
Treat.
What are you?
See, the only important is to counsel the patient saying that okay, after giving any kind of a treatment, this may not happen.
What do you want in this patient? He has given the value. Is the patient diabetic?
No, sir.
Can you have a 6% HbA1c and be diabetic? Yes or no? The answer is
Borderline.
Borderline.
yes or no?
Yes, sir.
Yes.
Control.
What do you need to do to know blood sugar, glycemic or hyperglycemic values? What do you need basically? A fasting
BP.
The post-pancreatectomy estimation that would tell you exactly. If you have diabetes in chronic pancreatitis, what type of diabetes is it?
Type 3.
Type 3?
Type 3C.
Type
3C.
So in the other type, so what is the patient?
LFT we are not seeing. Like the total bilirubin difference.
It's normal. Next, what are you
ALP.
ALP. So what is the test you want to do? It's important to do anything more to establish the histology of this condition. Dense calcifications or calculi or whatever you said. So genetic testing. So genetic testing, sir. If it is what genetic abnormalities are you expecting? Sir, there will be pancreatitis. Pancreatitis. Have you seen a patient that has pancreatitis in India? No, sir. Again, it's just like that. So even autoimmune pancreatitis needs to be removed. What is the pancreatitis? Chronic autoimmune pancreatitis for a long time with glucose dilatation, no masturbation, no pancreatic halo, better difficult even type 2 pancreatitis blood like this. Would you like to test for calcium level? Yes, sir. Why do you want to do that? So even a hyperparathyroid can present with chronic pancreatitis. If your calcium levels are high, and if your if you do the calcium level, you would be prudent to advise the pancreas so the doctor to take good contact before doing the calcium testing. What would that be? Take a sample with the hand, dependent rather than exceptional pumping the possible or value. So you do a random that comes up, then what next? So suspected hyperparathyroidism. Now, what phosphate levels? Phosphate levels are low. Next one. Scintigraphy, sir. Is it a single adenoma or is it multiple adenomas that is causing hyperparathyroidism? You find that as already as well uptake. What is the treatment? Excisions. Would it mean that you would not touch the pancreas next time? Or would you address the pancreas and the pancreas separately? First parathyroid followed by pancreas. This patient has a chronic calcium pancreatitis, raised pancreatitis with exocrine sections with the colorful SPO. So what you sir, since this is a case of a painful chronic calcific pancreatitis, I'd like to step up the
usage of analgesics, and if it is tolerable and continue the same.
Is there a script for drainage in this patient?
No, sir.
No. Endoscopic or open?
Since it is a calcified pancreatitis, it is very hard, and ERCP stenting and all doesn't work.
Could you attribute the pain to? Can the patient's pain can be due to severe pancreatitis?
So they have a loose stool, sir.
The patient has absorbed it. It's because of that the patient has bloating and abdominal discomfort, and then after
not severe pain, sir. No, sir. No, sir. So IPM could be CI of pancreas. So because it is a chronic pancreatitis is a risk factor for pancreas.
Are you suspecting it?
No.
Still there is a possibility. Okay, so what you do in this patient now?
Tumor marker.
Okay, thanks. Not that it is normal. No.
The patient has an intractable pain.
What next is you have to know what is next. Okay. So let's just explain to you. Again, see, if you try to explain fast, you think that you are trying to lead us a bias. It's not going to happen. Okay, please don't go to that false ideology where you explain so first. So when we take mind ourselves and your answer is going to come out will be correct. No.
So I would like to plan for surgeries.
You have a reverse effect that you are confused, so you are trying to mislead us.
I would like to plan for surgery in this patient, sir.
What? Plan for surgery?
Yes.
What is the reason why surgery? What kind of surgery?
Sir,
What is the main purpose of surgery?
So the main purpose of the surgery is to relieve the pain, not to remove the stone. And drainage procedure can be done in this patient, sir.
What procedure do you plan to do?
Drainage procedure, sir. Lateral pancreatic duodenectomy of the nose.
And you will not take out the stones, you leave that.
No, sir.
You said just now exactly what you
So it is not indication for surgery, sir. I meant it is not indication for surgery. Stone is not indication for surgery.
You want to take out the stone, but it is not an indication.
So since the patient has a pain and the cause of pain could be because of rectal hypertension or abdominal hypertension, and so this pain.
Neurological pain also, right?
What he's asking you is earlier you had mentioned to stones per se may not be the cause of pain, and you don't. I don't know why others seems to want to use the word pain when actually you don't know. There's a lot of opponents saying may, it's not saying that. So it is what you said, it's not the cause of pain. And then later on, he rightly asked you, you're going to do a radial procedure, radial the pancreatic duct, but no need to remove the stones because it's not the cause of pain.
It needs to be looked at.
So would it not be prudent to now address whether the patient does? How much the patient has under supervision? Whether the patient has supervised analgesic use, whether the patient has adequate counseling as to the type of disease they are suffering from, and the amount of diet they are taking, the calories they are taking, and to see also whether this greasy stool is really steatorrhea by doing at least a fat globules test, because it should not be that it's something else and you bark up the wrong tree completely. And to give a try at the pancreatic enzymes, which may not only good at general well-being, also hopefully release some of the, and then make your own assessment rather than to plunge into a procedure or something. That is the right thing. But not trying to period, in any case, it's so I just wonder whether it may not be a good approach to tackle this problem like this. I don't know.
So even enzyme replacement can relieve the pain, sir.
It may not completely relieve. See, the main question here is what are you thinking is the main cause of the pain? Is it because of the kind of food he's eating is not proper, or is it ductal hypertension, or the stone, or it's a neurological pain? Because your whole management is going to change according to that. You have to be very clear what you're doing. So as Dr. Ramesh rightly said, you would try first many things and see if you counsel him, give him proper diet, give him supplements, whether his pain gets reduced. Then you have to really decide whether the ductal because you have to also tackle the biliary kind of in dilatation also, right, simultaneously. So
I've done an MR. Let's see the MR.
yes, sir.
Why do you think they did the MR? Or do you think it's a superfluous investigation? They shouldn't have done it. So you think the MR was justified? They've done an unjustified investigation. Would you like to justify it on their behalf?
Because there was CBD dilatation, so
Okay.
to look for that etiology of.
So I think Dr. Biju asked you, do you want to do anything? You said no, you don't want to. Now for the same thing, you want to justify doing an MR.
So even to rule out other causes of chronic pancreatitis, sir, it could be a case of pancreatic divisum or annular pancreas.
Pancreas divisum causes chronic pancreatitis. Is that the
So it causes recurrent pancreatitis, recurrent acute pancreatitis.
Sorry, say that again.
So it causes recurrent acute pancreatitis.
We're not talking about that, are we? We're talking about chronic pancreatitis. Ductal irritation, liver elevator. Are you suggesting that pancreas divisum produces chronic pancreatitis and ductal irritation? Then why are we going into that subject? If chronic pancreatitis affects patients with pancreas divisum, it often affects the distal or the dorsal annulus. That's all. So the renal annulus may be normal. That's the only implication of wisdom.
So how will you assess pancreatitis in this patient? How will you assess? Where are you trying to look at?
So it's cross sign.
Where are you trying to?
So we need to look
which sections or which images you see to determine.
so, thick slab reconstruction of
You want to see pancreatic head. Pancreatic head, what is it?
Classification.
So you'll be able to see. So in chronic pancreatitis, when you tell anomalous junction or about the ductal anomalies in the head, they will be extremely careful. Okay, you will not even see which is the main duct or other duct. So your knowledge is not up to pretty. Prefrontal theoretical just for a sake of thing.
You have any consultant, just cut down time.
So we do 3 months of observed analgesic, dietary advice, enzyme replacement. At the end of 3 months, he comes back to us and says he's got 10% relief in his pain. What do you want to do now?
So is it affecting its daily activities, sir?
You tell me.
So if it is, then
You tell me whether it's affecting his daily activities or not. He's got 10% relief of pain. You know the history. It's 3 years, progressive increase, moved from oral to IV analgesics. And now you've given him whatever you wanted, whatever Dr. Ramesh suggested. He's come back to you after 3 months and he says 10% relief in his pain. What do you want to do?
this is a failed conservative management, so we can.
What do you want to do? Then say why do you want to do?
Surgery, sir.
Just endoscopic stenting, both biliary and pancreas. It would really increase ductal hypertension as well as his duct. What it really is pain.
So ERC stenting can be done in isolated single solitary and for pancreatic stenosis, but not in
To say, I would not wish to choose endotherapy because of the presence of multiple structures and large stones, which despite extra corporate lithotripsy will be difficult to extract, and where there is an additional biliary obstruction also to be dealt with. And considering the fact that there are no risk modification conditions that I can change, I mean, like alcoholism or smoking, which I can persuade the patient to abstain from. Therefore, I have to provide the possibility of lasting relief, and therefore I would choose surgery.
Give a good reason. I mean, if somebody asks you like this, why not do endoscopy? These questions are many times asked. You give a valid reason. Why won't you select endoscopy in this patient? Give these patients parameters. What kind of surgery you would like to do in this case? You would like to tackle biliary duct at the same time? You would like to do only pancreatitis, or you would like to do phase, or you would like to do anything further? How would you really select a surgery for particular this patient?
So phrase procedures. So I would like to go on with the drainage hybrid procedure where head coring with drainage of the main pancreatic duct is done with the removal of all the stones.
Which way in terms of the intersection?
Head coring and
what about the biliary obstruction? What is
so
the
it is
You
not
assess on table biliary whether you have decompressed biliary duct adequately or not.
Is it possible to determine?
Or possible to determine, or will you just allow it to happen?
Suppose it doesn't spontaneously come,
so we would like to pass a tube into the biliary system and look for a two clear places,
which
extra and CBD, sir.
how do you put tube in?
So usually in these patients, even a cholecystectomy is planned, sir. And through the cystic duct, infant feeding tube is passed and patency into the duodenum is shut, sir.
By that stated that explains why there is no jaundice. Therefore, catheter will in all probability pass without any difficulty.
Same drop cholangiogram.
What do you expect to see? This is the situation. This is the picture you will see if you do an operative cholangiogram before your head coring. At the end of your head coring, what might you expect? This is not a dynamic study. MRCP is not a dynamic study, unfortunately. If you are doing operative cholangiogram, what would you expect to see? Is that a stricture? Stricture in Latin means just a narrowing. It does not mean what type and all that. Just a narrowing. Is there a narrowing or not? Yes, in fact, the alveolar
Yes, sir.
normal.
There is.
There is a narrowing. Yeah, the narrowing is seen there. You are not going to get the question beyond this. Okay, now please tell me what you are going to consider the disease process long stone load and the patient's and you are going ahead with study.
You are going with see, doing that will really this.
Sir, biliary drainage procedure doesn't help, sir. And if so, it is not planned in first in phrase along with the phrase procedure is never
Controversial statements. One, that a cholecystectomy is necessary in these patients. And the second statement that you've made is that a biliary drainage is not going to help these patients. Where do these two statements come from? Can you provide a reference, a study, a large study from India, from the West, anywhere? Or your experience?
So it is not done, sir.
So this is very difficult. If you're in an exam and you take a step forward and then immediately take a step backward when the examiner asks you a question, you're in difficulty. Just tells me that you have, you're taking a chance. You're guessing all the time, and you want to get away with the guessing approach. And that doesn't work.
Most of us will not rationalize cholecystectomy in a patient like this unless there is some indication.
So if you're, why don't you want to do a biliary drainage procedure in a person who has a raised alkaline phosphatase and has chronic pancreatitis and has this picture on an MRC? Give me a good reason for that.
So persistent elevated ALP for more than 1 month is an indication for surgery. But surgery
without pain. If you have persistent ALP beyond 1 month, that be an indication for what type of surgery? Will that do pancreatic surgery or just
pancreatic procedures?
Why would you operate the pancreas the mind?
And so,
Patient has no pancreatic pain.
so if you go for a drainage procedure, organ hypertension decreases and biliopathy resolves on its own.
It may resolve. Is all that is described in the literature as far as my knowledge goes. It may resolve. So, if it is, for example, the patient is a brave person who will put the contact on brain.
And what you were really trying to come out with that this primary pain is biliary and not pancreatic, which doesn't go well actually. It's main, the way pain is looks more pancreatic rather than biliary. Ask any other questions?
Any questions of the but I'd like to just point out from our organizers that we can't have one person giving all the answers. Not a switch. No, but I think they are. Yeah, some of them they don't want to participate in that. It's not fair. I mean, it's a reflection of your human abilities because you need to repeat these things.
Sir, in this patient, how would we manage this patient?
I would do it on angiogram. I would categorize the length and the time, the length of narrowing. In fact, with a normal bilirubin and raised alkaline phosphatase, one would be surprised to find a substantial number where even contrast doesn't go easily into the duodenum in spite of raising the head in. And then just leave the catheter there, complete your pouring, and take another look. Repeat the cholangiogram, and often times it does flow into the duodenum. Since it's only a raised alkaline phosphatase, there is no jaundice, there is no cholangitis, I am happy to allow this to be the only procedure. But if there is jaundice or there's been fever or cholangitis to suggest, then I would definitely add an additional biliary drainage procedure, either a duodenostomy or hepatoctomy or some selected cases given an internal biliary drainage. So this would be my strategy.
Question of doing CTs in the mass, usually do both. So, is both exam or
for theory purposes, MR is a one single stop shop. It has got everything in it. The problem is it takes time to, it's not available everywhere, and it requires more expertise in interpretation because most surgeons have now acquired their own expertise in interpreting CT. One thing around is that you must be very good at reading MRs also. It's not difficult once you put your mind to it. So that can be removed completely. The availability of a good MR is another challenge. Having said that, either it is just, I do not recommend both unless in specific situations as said, you want additional ductal delineation because all the dangerous complications of chronic pancreatitis such as mass, cancer, abscesses, uricus can all be evidently seen in a CT scan, and they are not ductal communicating. Chronic pancreatitis, there is no question of non-ductal communicating pseudocysts happening. It's not like acute pancreatitis. So therefore, there is no real need to do an MR delineation, MR delineation. So I would be happy to follow their part of CT, but again, it's an individual. But I recommend with definition of sources, global approach to having both in the case, and I'm not the approach.
See, most of the time people say it's complementary, but you should justify why it's complementary and what in practice you will do. Even economically, it's a lot of load. Justify it. Complementary, you can justify what you want to do. About the whole thing.
Yeah, being conversation is quite okay. It's okay to say, I understand what you are saying. I think it may be advisable to break the bile duct. I'm not quite sure. Or whatever you say is acceptable, but it is not acceptable just to put out your views all the time, especially if you don't have the data to support it. That's clear of the reference. Then we need to meet.
This law of adaptation of CBD can be a purpose start with the chronic conditions that CBD has
Unlikely, actually, the way it is seen, it's unlikely that in products, this is probably the compression because of the edema of the duct.
LFT and made us possibly that seems actually to be a wrong channel. In spite of the stones, we can see that. We just said you can't see, it's very true that you can't see, but you can just get that image back. The wrong channel seen of the MRC.
the cross dilatation of CBD, the LFT was not that there. So
it has a significance because then you may have to excise the bile duct. You are assuming that the building structure is also 3 years. There's so many aspects.
Also, no, is gradually. So, ischemic stricture will be a sudden cut.
Yesterday, the building obstruction that happened last week. Shows the lower.
this is mostly dilated with normal LFT.
A little bit, the next color. No.
The common channel is
no, I don't know.
No, one of the important things, we are surgeons are not taking the maximum number of pancreatitis. Okay, it's even medical gastroenterologist. So unless you are clear about the data produced by the money, you read it prospectively. There are many centers. I'll tell you one center, CMC Weldo, Department of SPP surgery, hardly do 5 to 6 body pancreatitis surgery per year. Okay, it's not because of their expertise. They are shown data. Conservative management works. Okay. No, why you are going to explain that when there's an Indian center, I'm telling you.
So that's the problem. You don't want to read Indian data.
Large center in experience is there.
NCCL is what is gospel truth. Your own reality is stares you in your face. Immunotherapy will do. How much does it cost you? You're not aware.
What's your name, please? So the question is simply that before that was data is that a substantial number of patients are manageable by conservative therapy. It is also it's not the doctor which is the disease aggressively. It is actually those patients who will not improve in either in ARG or in CMT will probably gravitate to Lakeshore or to Jitpa. So if you take a bigger picture, you know that substantial number do not resolve with medical management or endoscopic therapy, and a good number improve with medical management. And they may delay intervention or not at all. So this is not for us to make a prediction like that. All patients who as soon as they come in like to abstract them into surgery. There is no data for that. Escape trial said that don't let them become pancreatic cripples because you will sensitize the pancreatic nerves that even after the pancreas is completely removed, they will continue to have pain. That's a very extreme situation. Doesn't mean today you do operate immediately.
And whatever we are discussing, we don't know the etiology of the disease even today. We are doing all the discussions are about a palliative care. Okay, we are not managing the disease, we are managing the symptoms of the disease with pure palliative care. So don't put too much science today, tomorrow into this. We are not into that.
Thank you so much, all the moderators and delegates. For the next session, I would call upon the delegates who are Dr. Mohammad Yusuf Bhatt, Dr. Gilbert Samuel Jivakumar, Dr. Siddesh S. Taskonkar, and Dr. P.J. Sanjeev. And for moderating the session in faculty members, I would like to call upon Dr. Rohin Mittal sir, Dr. H.H. Nag sir, and Dr. Vijay Chandra sir. And Dr. Amin Sahu will continue to conduct the session.
So for this session, can I make a request that all four delegates on the dais are supposed to rotate the questions to the moderator, please, and ensure that everybody participates, even though some of them are more reticent, some of them are vocal. Basically, our exercise of trying to have equal experience kind of goes away. Thank you.
Thank you, sir. With the permission of the faculty, I would like to begin the next session. Start with the case capsule. A 58-year-old lady, homemaker, mother of 6, resident of Fatehpur, presented to us with chief complaints of chronic constipation for 10 years, marked descending perineum for 4 years, and intermittent bleeding per rectum for the last 2 years. She was apparently asymptomatic 10 years back when she started complaining of constipation. Hard stools, Bristol grade 1 to 2, frequency was once every 1 to 2 days. History of chronic laxative use was present for the last 8 to 10 years. History of straining at stools was present and required evacuation 1 to 2 times every 15 days. There is also history of sensation of incomplete empty present. She noticed a mark coming out for a 4 year, which is initially small in size, reducing spontaneously, which gradually progressed to its present size and requires manual positioning normal. She also gives a history of pathopathic mucus and fresh blood, not mixed with stools, intermittently for 2 years, which was painless, around 5 to 10 ml quantity per episode. There is no history of pain, discharge, or incontinence. No, there is no history of peanut distension, nausea, or vomiting. No history of tenesmus or spurious diarrhea. No history of significant loss of weight or appetite. No history of hemoptysis, jaundice, or new onset bone pain. There are no medical comorbidities or surgeries in the patient. She has normal sleep appetite and consumes mixed diet. Family history is not significant. Coming to obstetric history, she is a mother of 6 all vaginal deliveries. There is no history of prolonged labor or forceps delivery, and there is no history of episiotomy. The patient is menopausal for the last 8 years. Move on to the discussion.
Let's start. What are your differential diagnoses at this point? We'll start from that side or this side. Okay, we'll start with that.
I'm a 58-year-old female. I'm a female. I was considered with constipation for 10 years and presenting with mass per rectum for 4 years with history of bleeding period for 2 years. So probably and the mass descending per rectum is gradually increasing in size, which requires manual repositioning right now. And there is a sense of incomplete evacuation after passing stools. It could be
When you summarize, do not repeat the whole history. You have to summarize in 2 lines and then give a differential diagnosis. It's very important.
It could be rectal prolapse, hemorrhoids, internal prolapse, internal hemorrhoids, or carcinoma of the rectum.
Which one will you put first? Which one will you put second?
Based on the history, age, and sex, prolapse is the symptom. first
Somebody has feeling of incomplete evacuation, rectal bleeding, mass descending per rectum, mucus discharge.
Rectal prolapse is more common than hemorrhoid
in a 58-year-old person.
The mucus discharge and sense of incomplete evacuation as
If the session was not on rectal prolapse, what would you have considered as a differential diagnosis?
prolapse.
Prolapse. Something else more sinister? Next question.
So what do you feel are the alarm symptoms here?
There is a mucus with a stool. So there will be underlying malignancy that can present.
First differential should be malignancy, rectal cancer or lower GI cancer. Only after that you will consider as a benign possibility. There are enough red flag symptoms here to think that this could be cancer.
What do you think are the possibilities of grade 3 hemorrhoids?
Possibility of grade 3 hemorrhoids, prolapsing hemorrhoids, grade 4 hemorrhoids can also be kept.
Is that more common or rectal prolapse? You kept rectal prolapse to the first
age of the patient, then multipara, so and plus assured history of tenesmus and so maybe rectal prolapse in this.
What else? Any other differential diagnosis? You don't get biased by the session. You have to think of what is going to happen in a practical scenario. Any other thing that is on the digitation? Somebody with chronic constipation, annual evacuation. ODS with
mucosal prolapse.
Solitary rectal ulcer.
Sorry.
SRE. Okay, so all these are the differential diagnoses.
So due to internal intussusception, continuous staining will cause the rectum to impinge on the pelvic floor. That is one reason that can cause ulceration. People who use digital evacuation can cause trauma to the anterior rectal wall. That can also cause ulceration. Two reasons for ulcers in the anterior wall of the rectum. It can coexist with rectal prolapse.
Keeping all this in mind, what are examination findings that you expect, or what are specific examination findings that you will look for?
We'll do first digital rectal examination on that inspection. On inspection, we'll see any mass coming out of the rectum. Then on digital rectal examination, we'll see the laxity of the sphincter, the laxity of the anus. Then we'll ask the patient to do a squeeze. We'll see the squeeze pressure. Also, we'll see any mass palpable per rectum, any bleeding.
Yes. Any specific thing, one of the differential diagnoses, prolapse or prolapsing hemorrhoids or full thickness rectal prolapse, any specific maneuver you will do?
Strain, we ask the patient to strain and the mucus concentric rings.
So you have to ask the patient to strain. And sometimes it is not possible in the left lateral position. You have to make the patient sit and squat and then strain to see if something is coming out. If you don't do that, very often you will miss the prolapse.
Multipara female. Any other thing you would like to examine?
Bimanual examination, anterior rectocele might be there.
Other prolapses.
Cardiac examination should also be.
How common is coexistence of other compartment prolapse, especially in this age group?
30%. On third of.
It is common. So you have to do all that examination. So when you, before going in itself, you should look for all these particular features.
How can you proceed further?
Clinical examination.
Yeah.
Can we?
Coming to general physical examination, patient was conscious. She has a BMI of 17.86 kg per square meter. Vitals are stable with good performance status. No pylorictinous sinuses, clubbing or lymphadenopathy. The abdominal examination was essentially normal. There was no acromegaly or mass. On perineal examination, on straining in lying down position, there was no prolapse seen. However, in squatting position, on straining, there was a 5 centimeter full thickness rectal prolapse with concentric mucosal folds present. On DRE proctoscopy, the NS was found to bacillus, anal tone at rest and during squeeze was reduced. Rectal mucosa appeared erythematous. There was no present. Blood staining of the blood film was present. On per examination, blood is appreciated of the posterior vaginal wall on stream.
So what do you think is the provisional diagnosis here?
Rectal prolapse and intrusive.
But yeah, what?
Rectal prolapse and intrusive.
Okay, rectal prolapse. What kind of rectal prolapse?
Complete full thickness.
Full thickness. So always in the exam, try and give full answers. Don't wait for half answers and ask for a second question. Okay. The full thickness rectal prolapse
with
intrusive.
Intrusive.
Why are you saying intrusive?
Because the posterior vaginal wall. Feel the bulge in the posterior vaginal wall.
Bulge in the posterior. So is that an intrusive? What do you mean by intrusive?
So basically, this rectum prolapse is in the posterior vaginal wall.
That's not intrusive.
Intrusive is a small bowel penetrating through the pouch of abdominal side.
Then intrusive is?
So you rectocele and
Yes,
it will slip up.
yeah. So you mean rectocele, but what you're saying intrusive. So you often see you get confused. So it's very important to stay on point. It's rectocele. Okay.
Maybe associated with rectal syndrome.
So
There's also a possibility of malignancy, which is the selling point for the syndrome.
Maybe you proceed further to give this diagnosis.
Yeah. So very important point that we still cannot rule out cancer with all the symptoms. So okay, how do you go forward now?
I'll get the blood investigations to see the hemoglobin levels.
Okay. That's there. All normal.
No, so you do rectal examination. What else do you think the rectal examination doesn't it is complete? What else would you like to see for
Further, you want to do examine the rectal examination.
So proctoscopy to look at the anterior distal wall.
And before that, what do you see for squeeze, anal pressure,
the tone.
and yeah, and what else? Proctoscopy, what else? Proctoscopy, what do you see?
Serenity group.
You can rule out hemorrhoids also.
Yeah, and you mentioned there's a bulge, right, in the posterior vaginal wall. Would you like to see anything else on vaginal examination?
If there is any uterine prolapse.
Yeah, so you receive the vaginal apex, right?
Yes.
Whether they are able to descend or not. That is also important.
On perineal examination, is there anything else you can see in patients with prolapse?
Episiotomy.
Okay, you can see for scars.
You can look for seepage of stools and perineal
Skin
excoriation.
around.
History of
Perineal skin excoriation.
Skin. Anything specific? When patients squeeze, you can look for perineal descent. So the whole perineum can sometimes come down if there's laxity of the pelvic floor, especially in postmenopausal women. So you can look for perineal descent. Yes, so clear.
Further examination.
Okay, hemogram, you said that's normal. What next?
And I want to get a colonoscopy done. Rule out all or
You would like to screen the entire colon since the patient has a history of bleeding. So I would like to, most important, the age of the patient. I would like to rule out the malignancy or any. Still, if there is any mass descending per rectum, chronic constipation, still I would like to do a colonoscopy.
We have a short colonoscopy report. Evidence for descending colon and sigmoid colon found to be normal. Rectum shows patchy loss of vascular pattern, circumferential with erythematous and penetrated mucosa, few small caliber vessels were seen which were flammable.
So what next?
difficography.
What difficult? Again, fluoroscopy. Your answer. Don't say one word answers and expect the examiner to fill.
Fluoroscopy or MRI.
Which one? You have to choose. MRI. MRI. You have to choose and you have to justify why.
So, in your opinion, if you have a full thickness rectal prolapse, MRD program is mandatory.
In a multipara woman, old aged woman, there may be associated other pelvic floor defects. So to look for any other pelvic floor defects, we might go for robotic.
What pelvic floor defects are you looking for?
Associated rectal cystosis.
So you already know there is a rectal.
Elderly female patients, MRI difficulty is better than X-ray difficulty.
Male patient.
Male,
Still go ahead and do MRD.
no, sir. Male patients, young patients, we can manage with the X-ray difficulty.
Okay. So what is the advantage of a MRI defigogram over a conventional barium defigogram?
The MRI difficulty will help you to assess in the straining sequence, you can assess the descent of the bladder neck and the uterine cervical lower extent where it stays with respect to the peak of oxygen line and the rectocele as well as the anorectal junction, and can be quantified also, sir.
Okay. So what you can see, this is there is some contrast there. You know what that contrast is?
Sir, usually ultrasound gel is advised to give
Ultrasound gel. Okay.
Would you do this in a spine position or a squatting position? Will that make any difference?
In normally it's better doing in a sitting or squatting position, but the coils are not available. So most of the places it's done in supine position only.
Yeah, so there are studies to show that, if you have standardized protocols, spine position doesn't make any difference.
MRI deficogram suggests there is a descent of the urinary bladder. Also, we can see anterior rectocele and rectal prolapse.
Can you describe these lines of reference?
The red line is coccygeal line.
Okay. So what does that indicate? Red line, hypococcygeal line.
Anorectal junction.
That is normally the pelvic floor.
Normally at
okay, that is normally at the pelvic floor. Then
what is this purple? What are the angles?
not sure. Anybody?
The orange line is the M line, I think, sir. It's the lower part of the canal to the anorectal junction. I mean, perpendicular line joining the hypococcygeal line.
Okay.
That will show how much of the rectum is anorectal junction is descending.
Okay. Good.
The purple line is also known as the H line, I think, sir.
Look at the name of it. What does it indicate? It's more important to understand what it indicates.
Extent of the prolapse. Like descent.
What kind of extent?
Whether it's like internal intussusception or it is complete full thickness rectal prolapse beyond
that is made out of clinical examination. Okay, if it comes out, it is complete. If it stays inside, it is internal. So that the defigogram won't tell you.
What are the other methods, other dynamic methods of assessing? This is again static. See both these images. These are still static, and you require a specialized suit, to do this part of the program. To know other less expensive modalities to evaluate prolapse, dynamic healing, and also see other compartments. Can be done bedside also.
Transrectal ultrasound.
Transrectal ultrasound, transrectal. Yeah. What about transperineal? Do you have any idea of use of transperineal ultrasound to assess
multi-compartment prolapse, be done bedside. I can actually see the dynamic descent also simultaneously.
Okay, so transperineal ultrasound can also be done. So from MR deficogram, what are the take-home messages that you get, or even from a conventional deficogram? Quickly, what are the few things that you're looking for? Yeah, here's the report. So you're looking for prolapse. Okay, how much of the rectum is prolapsing? Okay, whether the whole pelvic floor is coming down, or whether the pelvic floor descent is there or not. And then you're looking at whether the anorectal angle opens up or closes. And then you're looking at rectocele and enterocele. So what does this say?
The MR defibrillator report, M line measures approximately 2.8 centimeter, mildly increased, that is mild descent of the hiatus during evacuation phase. There is diffuse circumferential thickening involving the anorectal junction and the iliac nerve. Contrast with outgoughing of the anterior rectal wall is seen measuring 2.8 centimeter. On dynamic imaging, in the resting phase, the anorectal angle is approximately 104 degrees. H line measures approximately 5.1 centimeter. M line measures approximately 10 mm within normal limits. Squeezing phase, the anorectal angle decreases to approximately 94 degrees within normal limits. Straining phase, the anorectal angle increases to approximately 102 degrees. In the evacuation phase, the anorectal angle is approximately 190 degrees. H line measures approximately 5.1 centimeter. M line measures approximately 2.8 centimeter, mildly increased. There is no evidence of no evidence of dysynergia.
So there's a lot of evidence there, a lot of jargon is there. So what do you make out of this? So what should happen to the anorectal angle during squeezing and evacuation?
It should straighten, sir, become more obtuse during evacuation.
Yes, it should during squeeze the angle should become acute. So
Acute, but
there is stool does not come out, and during evacuation it should become obtuse. So is that happening?
Yes, sir.
Yes. So that is normal. Normal. Okay. Then there before that like contrast filling outward of the anterior rectal wall 2.8 centimeters. What does that tell you?
If it's whenever the bulge is more than 2 centimeter, it's a significant
That's a
rectocele.
rectocele. We'll come up to that question later. What is significant? But there is a rectocele, right? And there is descent. You already know that there is full thickness prolapse. So there is prolapse, there is rectocele, and the angle is normal, and there is no prominent overactive thing. Okay. So these are all important findings. Now what next? So you have this finding in somebody who has got a full thickness rectal prolapse. What will you do next?
To identify the cause of constipation, colonectomy studies.
There are no studies on this study in the management of rectal prolapse.
The patient is having constipation for 10 years. It may be a cause of rectal prolapse. Without correcting the primary cause, the prolapse may recur.
How will it affect your management? What finding will how do you change your
If it is due to pelvic floor dyssynergia, we may have to give patient biofeedback exercise before advising surgery.
So you mean to say that in every patient have full thickness rectal prolapse with constipation included in the colonic study? In other words, what are the causes of constipation in a patient with full thickness rectal
Before you jump directly to think colonic transit study, what normal things will you do for constipation? Common tests that you will do for constipation.
What are the causes of constipation in patient with prolapse? Rectal prolapse.
Interception.
What is more common, constipation or incontinence?
Incontinence is more common.
What are the causes of incontinence and what are the causes of constipation?
Direct cardio may maybe incontinence. Constant pressure on potential nerve may cause external sphincter atrophy, causing.
How will the nerve get pressure on the nerve? How will that happen?
The prolapse segment gives pressure on the potential.
Any other thoughts? Anybody?
Stretching of the nerves.
Stretching of the nerves. Whole rectum prolapses, nerve stretches. So therefore it can get damaged. Okay. But other common cause for constipation, which you must rule out before you do anything.
Rule out drug intake, sir. History of
Okay.
opioid abuse, tricyclic antidepressants, antipsychotics.
Okay.
Rule out hypothyroidism.
Hypothyroidism. You find a lot of people are suffering from hypothyroidism and have some constipation. Did we do cases?
No, sir, we do not have a team.
What next? So suppose all the blood tests are normal. And there's no history of any drug abuse.
So, why do you think colonic? You would like to do a colonic transit study in this patient? Is it routine that you do for every patient of rectal prolapse?
No, not really. Just that the patient is having constipation predominant symptom. I have just to identify the cause of constipation. I was telling about colonic transit study.
So what will you do? How do you do colonic transit study, and how will you interpret it?
20 radiopic markers are taken orally and serial X-rays taken for 3 days. More than 80% should come out in 3 days.
Okay. So what happens if more than 80% doesn't come out?
If more pellets are the pellets are diffusely seen all over the colon, it may be due to slow transit. If it is mainly due to concentrated in somewhere near the pelvic outlet, it may be due to peripheral.
So you think the cause of constipation in this patient prolapse is some other like slow transit constipation? Would you, again my question, would you do this as a routine? In exam, would you say that in every patient prolapse, you will do a colonic transit study? How many patients would improve in their constipation after you correct their prolapse?
Just depends upon the procedure. So again, same question. So what is the indication for a colonic transit study? Is it every patient with prolapse or is it a different indication? You yourself said colonic transit study. If the transit is slow, you can say whether it's diffuse, then it's slow transit, or if everything is in the pelvis, which means there is outlet obstruction or ODS. So therefore, colonic transit study is done to differentiate between outlet obstruction, which is ODS, and dyssynergia versus slow transit. It is not done for prolapse. So in patients with constipation, where you are suspecting ODS, you can do transit study. But in this case, you need not do a transit study.
This would be done
because your MR also is showing that there is no dysynergy. You're clinically not suspecting dysynergy. You're actually clinically suspecting prolapse. So therefore, transit study is not required.
I would say that if constipation doesn't prove the correction of prolapse, then maybe you can investigate. So not done routine.
Alright, what next? So suppose, did we do a transit study? No. So transit study, even if it is done normal, then what? What next will you do now?
What about management? Is again done as routine or in special circumstances?
It's not done routinely, sir. If the incontinence component is significant, if you are suspecting sphincter injury, sphincter defect.
So this patient clinical examination, what was the finding?
Laxity of the anus.
Laxity of the sphincter. So do you suspect that this patient may have incontinence?
May have, sir. Yes.
Yes, likely to have. So how will you assess the incontinence? Quickly, there are 2-3 methods to assess incontinence.
Yeah, before that, how do you explain constipation in terms of class sphincter? Said the patient has constipation and he has lax sphincters. Do they go together?
Yes.
Answer my question. What are the causes of constipation in the patient with rectal prolapse?
Constricting ring of the prolapse segment may cause the constricting ring and causing constipation. And one of the anatomical variation, one of the anatomical cause of prolapse is maybe a redundant sigmoid column. So it may be a cause of constipation.
First question: can constipation and incontinence coexist? Yes or no?
Can coexist.
Can coexist. Okay. So constipation can be with various causes, and like you said, some of the things, no? Long sigmoid colon, habitual constipation. Constipation can be a leading cause to prolapse. But once the prolapse develops, patients can have incontinence also. So it is possible to have both. Okay. So now you suspect that this patient has incontinence. What are some easy tests that you can do to quantify the incontinence? Yes, there, number 5. Manometry. So how does manometry work? Anybody?
It is using sensors, you assess the pressure inside the anal canal when the patient is at resting state. Then you ask the patient to squeeze. Then you ask the patient to cough and look for. And it also assesses the functional length of the anal canal.
Okay, very good.
It gives a, you can assess the rectoanal inhibitory reflex also.
You can assess rectoanal inhibitory reflex. Okay. So here's the results. So what does each of that tell you? Quick interpretation.
Resting pressure is low, sir, but the squeeze pressure is good.
Okay, so there's normal range there, and the anal resting pressure is low. What does that mean? How do you interpret that result? What does that mean to you?
The internal sphincter is.
Okay, next question. Yes, come.
There might be defect of internal sphincter.
So resting pressure is because of the internal sphincter. So there might be internal sphincter defect. Okay.
So what is the cause of incontinence in a patient of prolapse? How does prolapse lead to incontinence? What is the mechanism?
It forms a conduit, direct conduit. Second, the seepage of the mucus.
What happens to the rectoanal inhibitory reflex in prolapse?
In the given study, it is less than a normal.
We have prolapse coming, going across the dentate line. What will it lead to? Lead to abolition of
Yes, sir.
and that will lead to incontinence.
There will be loss of sampling reflex. Yes.
So next, what does the squeeze pressure mean?
The squeeze steps up the tone of the sphincters.
Which sphincter?
Internal sphincters.
External sphincter. In a resting pressure is internal sphincter. That is, and what about the RAIR? What does that test?
Rectoanal inhibitory reflex.
Yeah. So if it is present, what does it imply to you? Or if it's absent, what does it imply to you?
Present.
It implies that the pudendal nerve is functioning. You are worried about stretch of the pudendal nerve. So it implies that actually the pudendal nerve is functioning. So here you can see that there is low resting torque, nearly normal to low normal squeeze pressure, and RAIR is present. Okay, so what next? Any other methods to assess incontinence without use of, suppose you don't have manometry in the hospital?
Yeah, and do you think manometry is mandatory? All patients of prolapse.
Depending upon the
What do the guidelines say? Are you aware of any guidelines?
Incontinence component is the manometry.
Ideally, if available, all patients should have manometry. Okay. Any other methods clinically you can assess incontinence? Do you know any clinical scores?
You can do clinically water holding test.
You can do water holding test, okay. But clinically, without doing any test, just asking the patient some questions. Do you know these scores? Wexner's incontinence score.
Incontinence.
And CAM incontinence score, or the Vasey incontinence score.
Yeah, St. Mark's.
St. Mark's incontinence score. There are only 4 questions, and it gives you a value. And it's very important to have them before and after an operation. Okay. Okay. So now you've got all this information. How will you proceed here? How do you want to manage this patient? What are the other tests we have?
Scoring that, the constipation.
So with MR defibrigram, you think this has any value, barium defibrigram?
You can assess the sigmoid if it's if you have a redundant sigmoid or not. Can be assessed and using barium difficograms.
Barium defibrigram gives you the anatomy of the sigmoid polyp, and essentially very similar information.
And of course, it only tells you about the posterior compartment.
Yes.
Whereas an MR defibrigram will tell you about all compartments. In somebody who suspect multi-compartment prolapse, MR defibrigram is better. Okay, what will you do next? Now you have all the information. How will you manage this patient?
Surgical management.
Surgical. So what operation?
For
abdominal operation.
You mentioned about initially you mentioned about biofeedback. That has any role in management of this particular patient or management of rectal collapse per se?
Post surgery follow patient might need biofeedback, say, because the sphincteronics lacks.
Or even physical rehabilitation. Do you think that there's any role of physical rehabilitation in a patient of rectal collapse or multi-compartment collapse before surgery? Any evidence to support that?
So in the time period we wait for surgery, some measures can be taken with patients.
Is there any role, strengthening the perineal muscles?
Pelvic floor strengthening using Kegel exercises can be taught to the patients. And
is there any evidence that will improve your results following surgery?
Not sure, sir.
Yeah, there's no role for isolated collapse. Maybe if we have associated vaginal collapse or especially in females, what is known as pelvic organ collapse, there might be some. There's no direct evidence as such. Basically, it's a surgical disease.
And in patients for biofeedback in patients with dyssynergia, even if they have an anatomical defect, better to give biofeedback therapy first, followed by reassessment, then plan for surgery.
Yes, very good. So what's the final diagnosis here? Now you've got all the information. What is the final diagnosis?
Full thickness rectal prolapse.
Okay, full thickness rectal prolapse
With rectocy. With rectocy.
With rectocy. And
with no dysynergia.
With no dysynergia.
With constipation.
Constipation. With chronic constipation predominant full thickness rectal prolapse with anterior rectocy and some minimal incontinence. Right? So now what do you want to do? Do you think the rectocele is significant or not significant?
It is more than 2 centimeters.
Okay. Is it only more than 2 centimeters important, or is there something else, some other criteria you can use?
And
every rectocele more than 2 centimeters should you treat?
The symptomatology of the patient also.
Patient has one prolapse.
That's what I wanted to ask you. So this patient has constipation, right? You think this could contribute to constipation?
Yes, sir. Rectocele can contribute to constipation.
So what surgical?
Abdominal perineal are available, sir. I would prefer abdominal approach for this patient as ECG score of 0 and patient general condition was normal. And yeah, post rectal dissection with suture rectopexy.
You have to do posterior suture rectopexy. What about that enterocele? Sorry, rectocele. Abdominal procedure will not address that. No, instead it's significant.
Posterior rectopexy will not address the rectocele.
So again, in the exam, you cannot change your answer just based on one question. What Dr. Piyush was saying previously. So you have to think and say. So the first thing, is that rectocele important or not important? It's 2.6 centimeters. Is there any other way you can say it is significant or not based on the deficogram? Any idea? You can look at it whether it's empty or non-empty. If at the end of the deficogram it empties, then probably not required to treat it. But if there's residual barium trapping or ultrasound gel which is trapped inside, then it is probably significant.
The symptoms.
And that's a very crucial bit to decide what treatment you're going to do. Now, what do you want to do? What operation would you like to do?
The ventral mesh rectopexy, sir.
Ventral mesh rectopexy. Anybody else? Anything else? Any other options? Suppose we say that why do you want to say ventral mesh rectopexy?
So we can correct the rectocele as a part of the procedure, and constipation component is less after doing a ventral mesh rectopexy. Whereas in posterior rectopexy, there is a chance of more constipation post procedure.
What is the reason?
One is there's a chance of nerve injury in posterior rectopexy as we do lateral dissection. Another component is the since because of extensive mobilization of the rectum, the angle also gets.
Which angle? Rectal angle. It's not actually the epicogram report. No? Finding of the rectal angle. Okay. So you want to do VMR.
Yes.
Any other options at all? Suppose we say that the rectocele is not significant. There are any other options? Would you choose a perineal approach?
What are the best advantages of perineal?
Loudly. Recurrence. So recurrence is higher in perineal operation. Okay. When will you choose the perineal approach?
The patient with otherwise low performance status.
Okay, so in poor patients with poor performance status, agreed. Anybody else?
Young males whom family is not completed and is anxious about sexual dysfunction.
Young males choose the perineal procedure.
Some books will say that, but practically will you ever choose a perineal procedure in young male?
So why do you think recurrence is higher in procedure?
In recent studies, they are telling that there is selection bias in the most of the recurrence rates based on retrospective studies. Most of the old and frail patients are subjected to perineal procedures, and most young patients are subjected to abdominal procedures. But during the in randomized controls, there are very few randomized control studies are available.
Which India also apart. Although that has license.
American Society of Colorectal Surgeons guidelines for rectal prolapse.
Study.
Okay, so what operation do you want to do?
The single most important thing to prevent recurrence is fixation of the rectum. Okay. That is not basically addressed by perineal approach. So PEXI is very important, despite all the biases, all the heterogeneous comparisons. I'm talking about what usually fixes the rectum, either in the sacrum or otherwise, which is not achieved in a perineal procedure. That is why theoretically the recurrence is more perineal operation.
So again, coming back, why would you choose a VMR ventral mesh rectopexy? And where will you put the mesh? And what mesh will you use?
Since the patient has a both component,
Yes, not talking about VMR. Why VMR? Which plane will you put the mesh and which mesh will you choose?
The mesh will be between the anterior peritoneal reflection and the posterior pulmonary valve. The length of the mesh will be 15 centimeter, 15 into 3 or 4 centimeter. Anteriorly, we'll fix the mesh to the anterior wall of the rectum, muscular sutures, and then
How distant?
up to the pelvic floor, up to the pelvic floor, and then one end of the mesh will fix to the sacral promontory, safeguarding the ureters and the vessel, and followed by closure of the anterior peritoneal reflection. Ripsting sling rectopexy. In that, the mesh is fixed posteriorly to the sacrum, and the sling of the mesh is fixed anteriorly again to the rectum. Advantage of anterior mesh rectopexy, there is less dissection posterior to the rectum. Also, there is decrease in chance of injury to the lateral ligaments. So, decrease injury to the nerve plexus. That is the main advantage. And posterior mesh rectopexy increase risk of constipation, increase risk of injury to the presacral nerve plexus.
Too much some cycle. Fix them with cycle. That is just fix it with cycle. Point A.
Okay, in this patient, can we, which came first, the prolapse or the rectus? Where does the prolapse begin? What is the apex of prolapse?
Anorectal junction.
So the ventral mesh rectopexy usually addresses the trigger point. You know, usually the prolapse begins in the anterior wall, right? And if the length of the prolapse is more than 5 centimeters, you know, then in the ventral mesh rectopexy, you have the opportunity to fix the mesh higher up also. You can actually go to the mid rectum, you know, before fixing to the sacrum. So you would address the apex of the prolapse depending on the length of the prolapse. The higher, the bigger the length, the greater the chance of recurrence, which is not addressed potentially in a posterior mesh rectopexy.
Quickly, some other exam questions. If you are doing a posterior rectopexy, suppose this was a male patient, young fit male or older male, and you are doing a posterior rectopexy, what rectopexy will you do? Mesh or suture? And why? Why not mesh?
Erosion.
Again, in the exam, always speak in full sentences. Don't throw one word and expect everybody to fill in the blanks. Complications of the mesh. What complications? Erosion. Erosion. Okay. The mesh causes mesh erosion. What else you're worried about? Mesh can erode. Other common complications with mesh?
Mesh infection.
Mesh infection. Okay. Mesh infection, mesh erosion are worrying. What happens if you don't use a mesh? Why do we use a mesh? Fibrosis. Why do people use the mesh?
Fixes the rectum because of fibrosis.
Because of fibrosis. So then if you don't use the mesh, does the recurrence increase?
Actually, studies have shown no increased risk of recurrence.
So there is no increased recurrence, but increased risk of complication. And that is why people have moved away from the mesh. Alright. You're doing a posterior suture rectopexy. Will you do any additional procedures? If yes, why and in which patients?
If we have redundant sigma, then we will do resection rectopexy.
Only redundant sigma? When would you consider doing resection rectopexy?
Constipation.
Constipation predominant prolapse. Okay, so you do a posterior rectopexy with sigmoidectomy. Practically, not many people do it, but it is described in the books.
Altometer.
Goldberg.
Oh, spaghetti.
Up to the perineal lobster.
perineal body.
How do you know that your lower limit is in cheek? The term reduced levator which
So suppose this patient was old and debilitated and you decide that you want to do a perineal procedure. Which perineal procedure will you do and why?
Up to 5 centimeter. Allow me now.
You use the mic.
5 centimeter. We can delay me.
So this is 5 centimeters, so you will do DeLong's.
Yes.
So what is DeLong's procedure?
So basically, we strip the mucosa and do plication of the muscular layer.
Okay. Then what is the other procedure?
There is Ultimates proctor.
Ultimates procedure. So when would you do Ultimates and when would you do DeLong's?
So maybe more than 5 centimeter, and if there is component of this incontinence, so levatoplasty may add to proctor.
Okay, you can add levatoplasty, but what is the brilliant difference?
Redundant.
So longer prolapse, you will do Ultimates. Shorter prolapse, you will do DeLong's. Any other procedures you know of, perineal procedures?
Three-shway.
When will you do Cheshway?
Short life expectancy.
Extremely moribund patient. Okay. Otherwise, there is no room for TH. I think we'll finish. Thank you.
Thank you, Secretary. Thank you, members and delegates.
Question.
In resection rectal can you use mesh because there can be a gap. So we need to estimate the time they can do transit insection. If we do resection rectal along with the posterior mesh or resection rectal should be done alone.
Mesh is generally not needed for VMR, where the whole mesh is extraperitoneal. Posteriorly, most people will do suture ectopexy. They will not do mesh ectopexy.
But advent of LVMR generally even for redundant sigmoid, it does well when you do LVMR because the constipation is significantly improved because the use of resection ectopexy has not done now.
So the practical answer to your question is now most people will do suture ectopexy. So if you want to, so there is no question of mesh with resection. And most people will not do resection because it has a added morbidity of anastigmatic leak. And for a benign disease, you don't want to do it.
Either ventral or
So common operations that are done are posterior suture ectopexy, VMR, otherwise perineal procedures. Those are the commonest ones.
Thank you.
That's what, yeah, so 5 centimeters DeLong's. 5 to 7 centimeters DeLong's is enough. But if you have a very long prolapse, then Ultimates.
So I hope all the delegates are still there in the auditorium. We are having a small quiz. Today we are holding the qualification round.
Please, all of you sit a bit apart so that don't try to help everybody. And the quiz first round, this is the first round, and there are 30 questions. I'll repeat the rules. There are 30 questions. There are 30 questions. Each question will have positive for 4 marks and negative for 1 mark. हाँ कर लो. Please question दिख रहा है. Question दिख रहा है. So please settle down. I hope everybody has written their names and date of birth clearly so that we don't have any problem in sorting out कि किसको कौन सा prize मिला है. And this is the first round. This will not, you will not be awarded prizes for this. We'll select 8 top people for the quiz second round tomorrow. So don't try to help each other because maybe it's soup. Okay.
you go to one side. The second thing, you will pass the board. You're not going to have this one. Yeah.
And I repeat, each positive answer is 4 marks, negative answer is -1. If you attempt the same question twice, I'll consider it as wrong. Yeah. Yeah. Please fill in your names. I hope everybody has your OMR sheet. And only residents to participate, please. Definitely. And if there is a clash on marks, it will be decided based on the date of birth. So we'll definitely check your identity card if you're written the right date of birth. So be careful. If I find any discrepancy, you will be disqualified. So can we go ahead? Everybody's ready? 30 seconds for each question. 30 questions for each, 30 seconds for each question, and we'll change on its own. Just you have to fill it. You have to fill it. Don't take it. Please don't take it. You have to fill it. You have to blacken it. Black pen or blue pen. No pencils, please. And if you answer you select two options, I'll consider it as wrong. Okay? So let's go ahead. All the best. Please start the quiz. Negative लिखा है. Negative बता दें. Okay? Let's start.
please you collect your answer sheets and then we'll distinctly write that.
Coming to the correct answers. First question was regarding Makuchi ligament. The false statement is it usually connects segment 6 to IBC. That is the false answer. Sorry. So it is also known as hepatic ligament. In up to 50% of patients, it is replaced by hepatic parenchyma. That is why during infusion, it may cause some troublesome bleeding. And usually it connects segment 7 to the IBC, the opposite side. Next question is least variation is seen in portal vein. There's the incidence is around 5 to 10%. Rest of the abnormalities are around 20% in the biliary and hepatic artery. Next question, ligation of all of the following arteries usually cause significant hepatic enzyme abnormalities except it is ligation of hepatic artery proximal to the GDF because there is collateral circulation from the SMA if you look at it. Next question, all of the following form boundaries of the caudate lobe except the ligament in hepatic. This was an easy one. True about pancreatitis cells. The correct statement is that it arises from the submucosa. So heterotrophic pancreatic tissue, most of the times it is asymptomatic, so it does not cause bleeding. Bleeding is a rare symptom, but being symptomatic is a rare issue. It usually arises from the submucosa, and most common location is the stomach. All are true regarding ramps except the false statement is that the dissection proceeds from left to right, but usually from the right side to the left side. All are the components of the forms this score except. So answer is A. These the interval left side element the correct answer. Forms critical used for prognostication of metastatic colorectal cancer. That too metaconus metastatic colorectal cancer. FNH like lesions are seen in all of the following conditions except. So FNH like lesions are histological mimics of normal FNH, which is seen in an abnormal liver in conditions which cause abnormal blood flow to the liver. Nodular regenerative hyperplasia is distinct pathology. The liver spontaneously, the cause is still unknown, undergoes change which causes diffuse nodularity in the liver, and the nodules are micronodular. So there is no fibrosis which is seen in this condition. So FNH-like lesions are not encountered in this condition. Optimal phenomena for sacral simulation is S3 level. For the guidelines, which are also now known as the PRISMA guidelines after 2009, it's for meta-analysis. So supraduodenal artery of Wilkie is most commonly a branch of GDA. GDA bifurcates into two branches. One is the pancreatitis. From there only it gives the supraduodenal artery to Wilkie. Neclarius B sign is obvious, the seen in esophageal perforation. Pneumomediastinum. This is a spotter, and the image shows feline esophagus and normally it's of GERD. Feline is classical of GERD. If it's Shackleton, you can cross check Shackleton. If it's wrong, we'll give you the marks. You can show me the reference, but according to my GERD. Muir-Torre syndrome is a variant of HNPCC. And the additional feature which is seen in this syndrome is there are sebaceous gland neoplasms, so cancer is common along with the Downey Lynch syndrome, what is seen. US characteristic of a metastatic lymph node in CH so pigs, all except this was an easy one. It is hyperechogenicity is the wrong one. Normally the node is hypoechoic. So these are the features. Particular node shows hypoechoic feature on US. PELD score includes all except this creatinine in male, creatinine is in PELD, it is hemoglobin which is included instead of creatinine. Liver laceration involving segments 5, 6, 7, 8. The grade of injury is grade 5. So in a single lobe, if more than 3 coinor segments are injured, it is grade 5 according to IASG classification. Small pore syndrome, all other measures which are used except that's photoK with heavy transposition. This is used in case of vein thrombosis. Identify the type of achalasia. This is type 3. On the scale, you can see that it is hypercontractile, all premature contractions you see. Type 1, it is completely blue. Failed peristalsis 100% of the times. Type 2 is panesophageal pressurization, which shows pressurization, but the constant column is seen throughout the swallows, and it premature contractions, which are in the red zone, which is seen. So this is grade 3. NCCN criteria for borderline resistant pancreatitis, all except solid tumor contact of 180 degrees with SMB with regular contour. That is the catch. Irregular contour makes it borderline. Regular contour is front resectable disease. This is Professor Masato Nagito. He's a living legend and has contributed great amounts to the field of cholangiocarcinoma. So, anybody who's met him in the previous APHPBA meeting, which was held in Bangalore, would have recognized this answer. Identifying this robotic system. So this was there, Dr. Rajneesh's PPT. This is the data sheets in the report. What are the components of global switch surgery, which is a pediatric procedure, except the false fracture is 100 square meter for the anastomosis to the Pancreatitis. So in duodenal switch surgery, we perform a sleeve gastrectomy. We disconnect the duodenum at the level of B1, which is before the ampulometer, and then from there it is anastomosis to the ileum, and then an ideal anastomosis is performed distally. So the limb before the ideal anastomosis is 150 centimeters in length. Which of the following hereditary syndrome has the maximum lifetime risk of developing gastric malignancy? That's Peutz-Jeghers syndrome, which is the incidence is 29%. Identify the label spot C. This is a common defect which all residents close while performing a general diagnostics. This is the space of Brolin. So Stabber hernia is site A, which is the transverse mesocolon orifice. Peterson's defect is between the jejunum which goes and between the leaf of the transverse mesocolon, and between at the jejunum, this is the base of Brolin. This is the most common type of fistula in ANO. So it is, according to the Bach classification, it's intersphincteric. That is where the cryptogenic theory of the fistula in ANO arises. So it's the most common type. All the following are parts of Alvarado score except. Yeah, so basically, sorry, there is in the answer key, but the answer is option A, pain. Tenderness is included in the criteria. Pain, it's mandatory pain. Which of the following is true regarding lymphatic drainage of esophagus? So the answer is muscularis mucosa has longitudinal lymphatic drainage. This is the diagram where you can see longitudinal lymphatic channels in the muscularis mucosa. In evidence-based medicine case series and well conducted case control studies would fall into which level of evidence? So this is the level of evidence pyramid. The studies stand at level 4. Pancreatitis trial was designed for comparison between two types of PJ techniques, that is Pancreatitis was duct technique. This trial was published in 2016 in BMJ. That's it. Thank you.
So we'll select 8 top candidates, and they will be apparently in the second round tomorrow. We'll decide the team based on chit system. So once the 8 people are selected, we'll pick up the chits and decide the 4 teams. So there will be no pairing amongst yourselves. We'll decide who will pair with whom. And tomorrow at 6 a.m., 6 p.m., we'll have the second round of the quiz. That will be fun for anything. So over to Dr. Lavina for the next session.
For our last session, that is radiology and surgical gastroenterology.
किसका है डॉक्टर दीप्ति होने का है सीआरसी करके होगा सीआरसी करके होगा कौन सा ये बताइए सारा निकाल ये तो डॉक्टर रजनीकांत है जैसे ये वाला ये बताइए सब निकल के लड़ते हैं ये आपका नहीं मिलता इसको रजनीकांत से रिजेक्ट कर दिया निकाल बेटा निकाल it is not that it is hard to do CRC first
These radiology sessions are again for residents only. So in case of like after presentation, just make your notes, and if you have any doubts at the end of every presentation, you can have questions from faculties.
So for first talk, that is radiology and CA rectum, I would like to invite Dr. Tushar from the radiology department, and for chairing the session, I would like to invite Dr. Arish Shastri sir, Dr. H. Ramesh sir, Dr. Rohit Mittal sir, and Dr. N.R. Das sir on the dais.
Good evening, everyone. It's Daniel mitochondrial radiology in CA rectum. As we all know, the CA rectum is an emerging health challenge in India. Because of the incidence is increasing day by day, because of the dietary changes, sedentary lifestyle, hypertension, early diagnosis and accurate staging are very critical. For the effective treatment of the tumor, and imaging plays a major role in this process. When the tumor is advanced, so beyond the T1, T2 staging, the treatment is totally changed. So basic focus is on the how we can do early diagnosis or how we can diagnose the tumor in the early stage. We can provide the better treatment to the patient. Otherwise, when the tumor is advanced, so we cannot do the lower tumor.
very advanced, so we cannot do that split testing. Basic focus would be there for early diagnosis for the lower tumor. Because the high tumor, we can still do something study after locally advanced tumor. Among the areas, now coming to the imaging modalities, various imaging modalities, CT have a major role in multi-rectal cancer. Right? A major हमारा in local staging. And for the early diagnosis, we are picking the early T1 T2 tumor. A CT is mainly used basically for the distant metastasis and the open disease and the restaging of the tumor. So all of the MRI currently the rectal MRI plays a major role in the pre-planning and the post-treatment planning also. For the assessing is selecting the patient for which are the patients which we can primarily go for the surgery, which are the patient which differentiating even tumor locally tumor, which need neoadjuvant chemotherapy, radiotherapy, then followed by reassessment by the primary, then we can go for the surgery. Primary has major role. So what are in the primary staging of the rectal MRI, but we have to have the reduced to the describe the tumor location and outcomes. Second thing is that provides its tier and categories. That's very important. Whenever we do the it's very important just look to describe the tumor. So you have to get the tier and stage of tumor by MRI or the MRI. Identify the tumor surrounding structure, including the sphincter complex and involvement of the visual aphasia. These feature helps in diagnosing the locally advanced cancer for which the treatment totally change. Because locally advanced cancer, if we have to go for the neoadjuvant chemotherapy followed by reassessment by MRI, we can go for the surgery. In restaging after CRT, in addition to the reassessing the feature noted during the primary staging, rectal MRI has can be assessment of the treatment response. Sometimes the treatment response is such that the don't need of surgery. After the chemotherapy, what tumor is more. Surgery might not be needed to give the patient of MRI. The CT scan I actually told you basically for the planning of the surgery, radiation therapy planning, particularly when the local extension of human digestion or distant metastasis are there, the CT scan comes time. In addition, periodic CT scan provides the baseline finding for the comparison during the post-operative period. So the scan we can after we can also the CT scan to reassess the MET also. Now in the advanced therapy of the particular we can do the treatment for that treatment can be done by RF laser. You can play the 1 or 2 or 3 minutes by the unpaid that will be provided by the art. And then by CT scanning needed to assess those elements also. So CT scanning is not suitable for the TNM staging for the parts, but it's response to treatment. Either the chemotherapy, either for the intervention by doing RF laser or okay, additional laser procedure here. Now directly coming to the protocol. So this is very important to know the exact MRI protocol and gastro to know which protocol the MRI is, which plane the MRI they are doing, which we are taking, because that totally changes the focus of the stage of the tumor. If you are using the smart FOB, when to large FOB, basically patient should be spinal cooperating. So high standard, preferably 3 dimensions should be there. Up to 1 dimension, okay. Until we have to use the which sequence should we use. Only best sequence is the effective sequence without best situation. This is the only sequence needed to evaluate the primary TNM phenotype. We don't need any other sequence. So only this is very good because at a so certain because हमारा lot of difference by T1, T2, T2 fracture, eastern edges, T1 post contrast. So it becomes very difficult to evaluate MRI. So many sequences are there. We will confuse, suddenly confuse how to see which sequence is which is T1, which is T2. So only sequence needed for planning the tumor T2 fact, T2 sequence. We can do the MRI during the we can apply the smart body tumor is high line tumor is there. We can provide a smart body agent. What can be done? Endorectal filling by channel can be done. Tumor is within clear. If we are confusing with the rather stool, adhered stool or something is there,
then they get pancreatitis filling. Microinvasive and T2 is needed for the staging after treatment. A 3D to 2D imaging can be done if when we have to look the visual fascia for the final fluoride. Contrast is in T1 images only after response to the diagnosis is the diabetic contrast imaging. So only sequence needed is the 220 images for the primary DNA stage. This sequence are mostly for the stage for a higher values. Now हमारे प्रोटोकॉल इसी small aptly 220 images सजाए axial and coronal. The sequence this is a high resolution T2 to oblique axial. This is the one of the most important sequence. This should be as I see this is the plane. If we are on the axial plane only, the this is what to explain. So the tumor is going beyond visual muscular the visual fascia. But when we are looking at the oblique axial plane, we can see the entire muscular a tumor is lying within the muscular This is a T1, T2 tumor, not going beyond the muscular but if plane is not oblique axial, so we can miss stage tumor at high stage tumor. Get T3 tumor, T3 tumor, T1 tumor. So plane is very important. First. So just few words about the relevant anatomy of the tumor. So this is the only term you have to remember is the T2 sequence, nothing else. For the primary tumor staging. So in the T2 sequence, one is the major rectal, rectal particles, and the anterior petrine vessel. These are the four things that one has to remember when looking at the T20 MRI. So what is the visual application? This is the outer diagonal piece. This outer diagonal is the visual face that is surrounding the rectum. It's around 3 to 4 centimeter approximately around the rectum. So this is the hyperintense area appearing hyperintense zone because this is the fat appearing hyperintense zone imaging. Any hyperintensity for the extending the rectal tumor indicates the tumor division. So coming to the because this is visual application is very important. Because all the cervical based on this visual application because this is the CRM which is talking about. This CRM is measured from the total distance between the tumor and the MRI. MRI is visual application. So this is the visual application. So when this is a tumor, when this is excised tumor, the tumor excised to total visual application. CRM is pathological and surgical term. So this is circumferential resection margin. So if the tumor is less than 1 millimeter, invaded by pathologically, less than 1 millimeter, the CRM is considered positive. It is 1 to 3 millimeter, it's considered hidden. If it is more than 2 millimeter, that CRM is negative. It indicates the bladder tumor, follow the tumor response. And the patient may also no need the new after the chemotherapy or anything after that. So CRM is surgical margin of the TME. On CRM is strong print of the local cancer. So positive CRM is tumor other locally diagnosed. We are talking about locally advanced one. So vision of the the rectal can easily pick by this diagram also. This is the mucosa, this is the mucosa, this is the mucosa here. This is the internal hypertension apparently starts in the rectal tumor. Inner hypertension line is the rectal mucosa. This hypertension lines remove the mucosa and this muscular is the mucosa. And this is the muscular rectal muscle layer. These are the visual factors. These are the levator muscle. Just further go down to make the acceleration to complex the lower. So these are the anterior pattern factors that comes in the V-shaped manner. This is known as the sign. So these anterior pattern muscles are involved in the higher tumors. So if a tumor is you can see that the tumor is there. If thickening is involving this anterior pattern reflection, the tumor considered T4A. This is very important. In the mid-rectal tumor, if we are going into the mid-rectal fascia, it's considered T3, not T4. But in high-rectal tumor, if it's inventing this anterior pattern reflection, then it comes into T4A stage. So this is very important between the places and the mid-rectal tumor. The anterior pattern reflection is involved, it comes to that T4A tumor. If this anterior, I will show the next slide, how this thing is this is the standard. So these are the three sequences we are obtaining the axial plane, oblique axial plane, and these sequences are obtaining the sagittal plane and coronal plane.
In the sagittal plane, we have to look for the from the angle towards. We have to look for the whether tumor is low, mid, or high rectal tumor. From the distance, it is within 5 centimeters. The angle towards is low. But tan it is mid rectal tumor. A tan 15 is the high rectal tumor. So if you this is the if you got in the sagittal plane, we have to look for the retrorectal space that is between the septum and posterior wall of the rectum. This is after ring area and anal wall. These are things we have to look for within the sagittal MR images. On the contrary pages, we have to look for anal sphincter complex. This is everybody knowing this as there are certain mucosa that was tuning as a sphincter. As this is the sphincter. This is the external sphincter at the continuation of the levator and eye muscle, and this is the middle. This is the intersphincter complex. So this is important for the lower tumor. Now comes the we have seen the lower tumor from the sigmoid where the rectum ends and the sigmoid colon start. Now this initially we have to take a virtual line between the promontory, upper part of the promontory. The beyond the now because that is a arbitrary line we are drawing. Because of the posture of a patient, some anatomy changes of patient, that may change. So it's better now to standing the sigmoid take a point has been taken as a standard point. Take the one sigmoid point. See anatomy that mark the imaging of the identifying the sigmoid junction. And distributing the rectum was a good how the sigmoid point is seen as MRI. So I'm back to the image. This is the back. This is sigmoid. This is identifying the inflection of where the sigmoid colon turns away from the rectum and attract anteriorly from where the sigmoid colon rectus supertension where the from the rectum acts where the sigmoid goes anteriorly. This is the lower upper rectum. Now this is going anteriorly. This is the concept of the sigmoid junction. If we take the arbitrary point, so that misguided sometimes the rectal junction. This is the how we define the upper rectum and the rectal junction. This is the way. Now to the next thing, I am going a little bit because time is less. This is the anterior fascia. This is the visual fascia. Regular tumor. This is the minimally extending little fat standing in the visual side. This is the mid tumor. This is the how we do the coding of this tumor. We have to add local tumor. It's a channel means that they go mid high distance from the inferior bottom of the channel like that. Then the tumor high rectal cancer, ignore codal cancer location. These things should be T category, T1, these are the reporting protocol for the right. Therefore, low rectal tumor, whether that transmitter only involved intention claim is involved, EASG is involved, length of the extraocular vascular agent is there, these are the T3 tumor, suspicious tumor, these are now I'm looking how to do a better can measure the digital tumor of the rectum. This is the tumor in the rectum more than centimeter. This is the tumor in the lower rectum. So from that we have to see the distance from the tumor. Tumor we have to see whether it's a mucinous non-mucinous tumor. So mucinous tumor will be a hypertense on T2 based or non-mucinous appear on the hypotense. Mucinous tumors are the prognosis. So we have to find it from neurology also. Here it's a basic into interesting. Even if the T1 is a submucosa, going to submucosa, T3 is the subserosa periactus soon less than 1 millimeter. It's going to a visual fact, but it's less than 1 millimeter. 1 to 5 to the T3B. T3 is 1 5 to 15 millimeter. T3 is 1 millimeter. T4 is T1 is T4 is at least doing the micrometer. T4 is the assistant. Okay. So this is the tumor in the tumor. Here we get no entire setting of anatomy preparation report. This is my store and there. After there is no fact standing in the visual facts, the visual practice here, that is and तो इसका मतलब T1 T2 चेंजिंग तो on MRI we cannot differentiate T1 and T2 so basically it's T1 T2 on MRI this is the understanding the mutual fact so this computer it is going is not more than 5 millimeters the T3 C2 basically going to the T1 fact understanding is there this is the high level tumor which is these are the peritoneal reflection are there so these peritoneal reflection are involved but tumor size not big because these are the tumor. This is the annual tumor. Here there is a little bit tumor product into the mesoderm fat. But if tumor has been in the mid rectum, it should be classified as a T3C or T3B. But because it's a high level tumor, it's going the peritoneal infection becomes the T4A. Now the CRM section, MRI CRM can be occupied with the social extent with the inner outward part like MRI I that millimeter more than 1 to 2 millimeter. So CRM is basically for the mid lower and mid of the high level one. So the keyword is the actual vascular utilization. We have to look for the basically actual vascular comes in the interspace area because as in India where calculus is there. If they go up a low signal density, well here, but the view also, if any understanding is there around the vessel, control is lost, that considered acceptable vascular division. And it's checking for effect of oncology extract. So anesthetic is a medical process that you're looking for. If you don't find it at a 5 millimeter, if it is at 5 millimeter, we have to look for the tumor. Tumor will have erupted single changes top saving. It is less than 5 millimeters, सबसे कुछ भी. 5 millimeters and acceptable. However, it is abnormal single density and top saving. Less than 5 millimeters is equal to 5 millimeters. Only 2 millimeters is more than 9 millimeters. If you want to totally total, then it is question over sting. These are over sting for the cancer. So, low rectal cancer, middle rectal cancer, low sting is right. So these are the method considered the upper rectal, upper rectal, one to other clear lymph node. This original outdated. These are the node. These are the extended. These are the present one. These are the internal one. These are the molecular. These are the robotic. In the upper mid rectal tumor, node max extended lymph node max positive amount disease, but in lower rectal cancer, this lymph node and this extended lymph node considered as an disease, not an disease. So this is the difference between lower rectal tumor lower rectal tumor difference goes into this superficial lymph node and extended lymph node. So these two considered as and this is for the high and mid tumor and this is in the lower rectal cancer. The sensitivity of lower and middle and this disease. So I'm saying everybody knows about this. So MRI was a little bit different from the middle high tumors. And I think all the understanding about part of that. How we differentiated because the equivalent of the interaction of classic interaction word. Now I'm coming back to the primary layers. I'm coming back to this. This is the tumor. This is the tumor. How the mesodermal fascia is going to the this mesodermal fascia is actually the sphincter fat plane. This is the sphincter. This is the axial sphincter complex. This is actually the fat plane. This is the basic anatomy. Local anatomy. This is the basic anatomy. This is the basic anatomy. These are the axial complex. This is the complex. This is the fat plane. This is the levator muscle. Continue as a axial complex. This is the rectal muscle of the rectal contain internal sphincter. This is the axial sphincter. So one has to know how to basic axial complex and internal sphincter complex. So when you put the lower rectal this is the T staging. T staging is the state is like T1, T2 where it's going to the even to the T3 is the when it's going into the it's going into the printer, but not affecting, not infecting the external accelerated speed of complex. But the tumor is getting the accelerated complex parameter CT41. This advancing in the multidisciplinary course. Recently, we considered accelerated speed as T4BC. Now, the accelerated is considered T4BDC rather than T4A. Initially, it was T4BC. Now because of local, now external spindle complex is considered local, not as structure. The external spindle is considered T4BC nowadays. Initially, it is considered T4A. So this is a given of the lower abdomen. Nodal lower abdomen, I will put see how it is. This is the lower abdomen. This is the lower abdomen tumor. And this is the how to fit the extension of that. These are the position node. These position node are considered as and this is node activities. Now the lower abdomen response. So हमारे आज पर पूरा we will happy. So that is one is again mucin response. Mucin response is when the tumor is hypotense, generally we should have hypotense more tumor, when less tumor is tumor mucin tumor. So when hypotense tumor turns hypotense, this condition mucin response and that is good response to the tumor, good response to chemotherapy therapy. So that is totally considered negative. Because we have to put up this considered the mucin response is a positive response. Vascular, how to differentiate the vascular blood diagnostic? In the case of the local advanced tumor, we have therapy, chemotherapy. So now we have to assess whether the tumor have regressed or not. So whether it's a carcinoma in the tumor, for that the differentiation sequence is very important. So this is the tumor in the mid rectum, which is showing diffusion of 6 cells. So after treatment, we can see this is a hypotense tumor. Now the tumor has regressed, but we don't know whether this is fibrosis or no. So this is after happening in the part, but we look at the DWI. So as compared to this DWI images, so what tumor is showing major system? Only this part of the tumor is showing major. It means if the tumor has regressed significantly by chemotherapy, only this part is the active part. So this is not a complete response. DWI images are very important to report the previous tumor. So DWI have to be ADC images because ADC is the negative reported DWI. Which region is applied on DWI, it should appear over the ADC. That only is considered a diffusion restriction. Also, we are highlighting here that this is a path restriction. So this should be there for the DWI images. Based on the DWI and D2AD images, so we have a tumor created out. TR is the complete response, no plus but treated tumor. TR is a gas prognosis, more than 70%. T3 for more than 50% prognosis on which is that is a high cancer. TR is the more little prognosis to see, but mostly tumor. T4 TR is the when we have to reach the tumor, we have to give the reporting based on whether we are at TRG1, TRG2, TRG3 based on that. Future reduction research. Now the dynamic task arrival is coming, then we can dynamic task part of the work. We have to correlate with that one. When we have given a price, we say without giving a task over part of the hybrids. What is the engagement? We combine all the scan that will be that is this is the star. The first step we have to one DRE step identified and then invasive model the tumor and then the claim that tumor depression and etc. These are staging as the tumor the complexity of basics flowchart. The multiple choice for the staging advance and assessing the surgeon in the negative surgical margins. MRI fixing the accurate assessment of the MRI and the fit of complex for surgical multi-parametric MRI at the in multi-parametric we mainly removing the DWI now we are dynamic MRI. Cities for the no for ECG, but for the med. So thank you.
Since was students.
Yeah, yeah. No, no. It's for that. Yeah, but me, how we differentiate the lower of the tumor? If it's based on not based on the imaging, diagnosis of lower of the cancer is nowadays that has changed. This is accessing whether the image will do the but